We hope that all of you are in a good condition so that we can pay close attention and follow this event until finish. Should be noted that on this happy occasion, there are several rules that must be obeyed by all the participants. First, please rename your Zoom accounts by writing the name of institution _ your name. Second, please turn off the microphone and listen actively during the presentation. Third, we will feel so happy if you could turn on the video in a polite context and in the hope that continuity of today's event can be carried out properly. Fourth, Q&A session will be held after the presentation, led by the moderator. Fifth, for the participant who wants to ask a question, you can write it in a Zoom chat column. However, we will prioritize the participant who wants to interact directly with our speakers by using a raise hand feature. Sixth, your attendance will be proven by fill in the attendance link on the Google form, which will be shared by the committee twice, in the morning session first and the afternoon session second. Okay, gratitude and thanks for the blessing that we received so we can gather here today on a virtual connection. Let's say thanks to our God, Allah Subhanahu wa Ta'ala, the Lord of the world, the Lord of the universe, who has been giving us his blessing and mercy so that we can gather here in this event with peace. Amen. Secondly, may peace be upon our Prophet Muhammad Sallallahu Alaihi Wasallam, who has guided us into the right ways of life. And now we are going to take a picture together. I think for this second day, I will ask for the operator, please. Would you please take a picture? And for all the participants, to open up the camera first, because we will have a documentation for today's morning. Okay, I will wait for a while and give a chance for the participant who still uncam the camera. Okay, give me your best posture. Okay, let's take a picture first. 1, 2, 3. And then the next slide. 1, 2, 3. And then the next slide. 1, 2, 3. Okay, I think the last. 1, 2, 3. Okay. Okay, we are done. Thank you for all the participants here. Let's begin the first session of our conference today. The keynote of speaker for fifth topic of our seminar is Professor Yoko Shimpuku from Hiroshima University, with the topic of research career in midwifery, challenges and considerations for ensuring quality of evidence-based practice. Before we get into the main agenda, let me introduce our special moderator that no longer stranger for us. It is Mrs. Mergi Gayatri, who will lead our discussion today. But before we begin, let me briefly explain about her background. I will share the screen first. Okay. As you can see over here, Mrs. Mergi Gayatri, BAPP, SC, MSc, domiciled in Malang, Indonesia. She has 9 years, over 9 years of experience in maternal health midwifery research and education, and also she's active in 3 different institutions as an employee, which is assistant professor in Brawijaya University, and then the science officer in Summit Institute for Development Indonesia, and then also a researcher in Center for Health Financing Policy and Health Insurance Management, Faculty of Medicine, Gajah Mada University, Indonesia. She had graduated from University of Nottingham for her master degree in 2016. As we can see here, she also have myriad of grants from various institutions, not only in Indonesia but also from the international, which was funded, which was a grant 100 million rupiah. And because of that, she also have lots of publication because of the project and research that she has done. And we can see here, she also an active representation, not only in Indonesia, but also in 2022. It's recently she is presented in the ninth International Public Health Conference 2022 in Malaysia. I think there's a lot of her achievement that I couldn't say one by one, but however, I will just greet our excellent moderator here. Good morning, Mrs. Margi.
Good morning. Assalamualaikum.
Waalaikumsalam warahmatullah. Okay, have you take your breakfast first?
Yeah.
Okay, alhamdulillah. So I hope that you also in a good condition and you're getting very well today. And alhamdulillah, for the next agenda, I will leave it to our moderator. Okay, Mrs. Margi, time is yours.
All right. Thank you very much for the Mrs. MC. Again, thank you very much for your kind introduction for me, very detailed. And yeah, good afternoon, ladies and gentlemen. My name is Margi, the moderator of this session. I'm very, very grateful to be able to lead this session again, and then very nice to meet you all. Also, I saw that our speaker today has come, Professor Shimpuku, and we are very welcome you here. And before we start her lecture, I'd like to introduce you to our honorable speaker in this session. So let me just share my screen. Okay, so briefly, okay, so her name is Professor Yoko Shimpuku. Well, she is a Vice President of International Public Relations, also a professor at Global Health Nursing, Graduate School of Biomedical and Health Sciences, Hiroshima University. And Professor Shimpuku is a midwife and also a researcher in global health. She has conducted field research in Tanzania to improve maternal and child health. She also completed her PhD in nursing at University of Illinois, Chicago, as a former executive committee of the Global Young Academy and a member of the Science Council or Young Academy of Japan. She has been contributing to discussion and writing statements for a wide scope of issues in science and society, such as post-pandemic recovery, sustainable development goals, and etc. And invited to at the IAP conference, STS Forum, G-Science, and S20. She was recognized as one of the 100 outstanding women nurse and midwife leaders by WHO, UN, and other international organizations in 2020. Wow, I'm speechless, right? I mean, she is very great. And last but not least, she was appointed as the Vice President of International Public Relations in Hiroshima University in 2022. And yeah, again, I can't read all of her publications because there are a lot of, she is very active in doing research and publications. And again, so we are looking forward to your lecture today from, one of the 100 outstanding women nurse and midwife leaders in the world. And then, yeah, I'm sure that all of the participants cannot wait for her lecture today on research careers in midwifery, challenges and considerations for ensuring quality of evidence-based practice. So I'm welcoming Professor Shimpuku.
Thank you very much for the kind introduction, moderator. I'd like to share my screen. Here you go. Does it look okay or it's fine? Oh, okay. So today I'm gonna talk about research careers in midwifery challenges.
Recording stopped.
For ensuring quality of evidence-based practice. I'm Yoko Shimpuku. I'm a professor in global health nursing in Hiroshima University.
Recording in progress.
I'd like to introduce myself a little bit. I am a midwife in Japan, and I got my PhD in the US, and I have been working in Tokyo and Kyoto, and now I'm in Hiroshima. And I'm doing my research on maternal child health in Africa. And I've been working in Global Young Academy and Young Academy of Japan. And I'm also a mother of a daughter who is 1 year and 7 months now. And my life really changed when I went to Chicago. This is my second home. It's quite cold in winter, but it's a very beautiful city. And the good part is the encountering many people over there, many international people. There are international students and also professors are very active in global health and international activities. And when I was taking the course in anthropology, one professor asked me if I can go to Africa with her. And I was very surprised when I got this offer. But because they offered me, because I am a midwife and they wanted to do maternal child health project over there. And I was an international student, so they thought I can be flexible in the international context. So they offered me to go with them. So I said yes, because the professor was showing some photos from Africa, and I was very interested in what they are doing in Africa. So when I first went to Africa, I was still like 26 or 7. So I was still young. So I said, okay, let me get this opportunity and see how it turns out. And Tanzania, maybe you may not familiar with the country, so I would like to talk a little bit about Tanzania. This is where it's located. It's in the east side of African continent, and in this map, Japan is here. And recently, I goes to Tanzania through Middle East countries like Dubai or Doha. Then it took like 20 hours to arrive there. And before, when I started going in 14 years ago, I needed to have like 2 or 3 transits, and it took like 30 hours or something like that. So compared to that, now it's became more convenient to go to Tanzania. And Tanzania is composed of the mainland and a small island called Zanzibar. And population is nearly 60 million now. And the urban population is increasing dramatically, and now 32% are living there. And population growth rate is nearly 3%. So many children are still born, and compared to Japan, we are having less and less children now. So I kind of envy that they are having many children there. And language, it's Swahili. They have other tribe languages when they are born, but they start learning Swahili in primary school, and they can also study in English from secondary school. So many people can speak 3 languages. And the religion is Christianity, Muslim, and domestic religion. And the GDP per capita is now it's over 1,000. So it's becoming a middle income country from low income country. And this is the map of north part of Tanzania. And this, I want to change the pointer. Here is Arusha, the middle part. This is the second city, and there is a Kilimanjaro airport in there. And this is Mount Kilimanjaro, which is very famous over the world. So you may know of Mount Kilimanjaro. And the part I went as a PhD student was called Haidom here. It took 6 hours from Arusha by car, and there is no paved road, so it's very bumpy to come up to the villages in here.
Professor Shimpuku, I'm sorry, could you please speak a bit louder, or maybe you can just,
Okay.
Speak near the microphone, please.
Okay. Okay, let me speak closer to the microphone. And this is how it looks when you are driving in the continent. It's very wide compared to Japan. The land scale is 2.5 times larger, and the population is nearly the half. So this means that people are living in a very large area and very scattered area. So it took time to go one place to the other. And this is the road you can see when you are traveling. So it's not paved. And this is the dry season, so it's still working. And when it becomes the rainy season, it sunk under the water. So it's quite difficult to travel, even in the dry season, but later on rainy season. And even in the dry season, the tire got punctures very frequently, and you have to have spare tire when you are traveling long way. So when I was traveling for the first time, we got 2 tires punctured, and we had only 1 spare tire. So it was difficult to travel on the middle of the road. And we were waiting the rescue to come. And it took nearly the half day, so it became night. I was very afraid that maybe animals could come, but it was okay. And in the end, rescue came, and we went to the research site together. So it's a lot of adventure when you are traveling in Africa. And this is the research site. There is a missionary hospital. Over there was Norwegian missionary who built the hospital long time ago, nearly 50 years ago. And because of the funding from outside the country, it's better conditioned compared to other government hospitals. And there was an outreach program. So I went to traveling to the very far villages with a medical team. And the anthropologist professor asked me if I can join the medical team. And I said yes. For this anthropology kind of project, it's important to kind of experience in the culture. So I was experiencing what they're providing in medical team in this context. And this is when I was volunteering as a midwife, measuring blood pressures and measuring their fundal height and all that stuff. And I was realizing there was some smell that is not very familiar to me. And I asked, what is this smell? And they say, because the water is not very available there, they were putting cow's butter on the skin to prevent the skin to be too dry. So because of that, this unfamiliar smell came to me, and I was kind of realized how it is difficult to live without water. And when we provide as a medical professional, we can easily say, or take a bath or wash hands to prevent infection. But in their context, it is not very feasible to do, like, take shower every day. So that kind of context, if you don't experience in the context, it's difficult to understand, and you can say from outside, oh, why they don't do like sanitary behavior. But the environment is really difficult to do that. And this is the hospital setting, and there are many mothers and babies there. Compared to Japan, we are having much less and less babies nowadays. So I was very surprised to see so many mothers having babies, especially in rural sites. Their total fertility rate is like 4.8 now, nearly 5. So the average woman have 5 babies, but in the city areas, women have less babies, maybe 2 or 3 babies. So this means that in rural sites, they have more babies, like 10 babies, 15 babies. So it's quite a lot of patients coming into the rural hospital. And compared to the city area, you may know that midwives are much less. So one midwife is carrying in a lot of workload in the rural hospital. For example, this hospital, one midwife was delivering 15 to 20 babies per day. When I was working in clinical, I delivered maybe like 3 babies per day. It was normal, but 15 to 20 babies per day is not very normal to me. So I was very surprised, and I was kind of emphasized with midwives how difficult job they are doing. And this is the baby's care unit, and it was not much medical tools or machines available there. You can suction the baby, but it's only that. And because there is no infant warmer, they heat the whole room, then the babies cannot get cold. So in the room, it's very hot as an adult being there, but for the baby, they just warm the entire room. And this is the birth toolkit, and it's very minimum. There is scissors to cut the cord, and there is the tool to cramp the cord, and that's pretty much it. When I teach midwifery in Japan, I teach
Oh, I think, yeah, there's something wrong with Professor Shinjuku's connection. So yeah, we're waiting for her to come back. So while waiting for Professor Shinjuku to come back, yeah, I would like to remind you that if you have any questions, please, you can, turn on your microphone and then just deliver your questions to her, like directly. Or if you don't want, or if you can't turn on your camera or microphone, please kindly send your questions to the chat box on this Zoom. So, because she is very amazing. She is one of the best nurse in this world. So yeah, I'm sure that we will gain a lot of knowledge or experience from her. Okay, so let me check whether she's back. I think she's not yet back, right? Okay. Or maybe the committee, could you please, contact her? Hi, Professor Shimpuku. Yeah, glad to be back. Okay, yeah.
Cut a little bit. I'll redo it. Sorry for the inconvenience. My computer suddenly got cut.
All right. Yeah.
Yeah, I was explaining how little the material they have in the context in the rural side. And this is the delivery room. There are 4 delivery rooms in the hospital. But as I said, there are 15 to 20 babies born per day, more than like 6 to a bit more women having contractions at the same time. So some women are delivered outside the room, like on the corridor. We put the bed and to deliver baby. And there is water tank here. This is not for like water delivery. This is to wash women because, as I said, there are many places they cannot access to water easily. So they just come and wash themselves there. And this is the bed on the corridor. Sometimes women deliver there, but it's difficult to keep the privacy when you deliver babies on the corridor. And on the right side is baby's fetoscope to hear the baby's heartbeat. And in Japan, we use a monitor, the electronic monitor to measure baby's heartbeat. So as I was educated in Japan, I didn't really use this tool before, but when I was working there, I delivered some baby with this, and it was quite difficult to use this tool and watching babies coming and listen to the fetal heartbeat and waiting for the baby's head with the glove you wear. It's quite difficult to do it. The monitoring the baby's heartbeat when you don't have electronic monitor. And this is the postpartum room. And women are sitting on the bed, and there was babies also there. And sometimes when it's crowded, 2 or 3 women can share the beds together. And you can notice the mosquito net because of the malaria. It's quite widely spread. So they use mosquito net even in the hospital. And this is after washing, they put like tools like this, but in Japanese standards, it's quite not very sanitary to do like this. So we are kind of worried about the infection after delivery because of this sanitation and disinfection. And there was, in some hospital, there was infant warmer, but very old and very not clean. I was also worried about infection if I put the baby there. And delivery bed look like this. So it's not very comfortable because there is no cushion or mattress. Woman just lie down with this plastic seat. So to not to get the blood and water on the bed, it's not very comfortable when you are having contraction and waiting there. And our midwife just went to massage the woman because this is what we do. But if you deliver 15 babies per day, you cannot have time to each woman to massage them. So it's quite difficult in that context. And this is the maternal health indicators in Tanzania. The maternal mortality ratio in 2015 data is 556 over 100,000 live births, and births attended by skilled personnel was 55% in rural area. So nearly half of the women still do not have medical personnel when they give birth. They are delivered by TBS, family members or friends. And this is antenatal care coverage, and the antenatal care 4 times more, is nearly 50%. So still half of the women do not have enough antenatal visits when they are having pregnancy. And also institutional delivery rates by region. In the city area, it's quite good, but as you go far from the city, the rate is going down. So there was quite disparity according to the region. And in that kind of context, as a midwife, I was kind of wanted to know how women think when they are delivering in the hospital. We know that 50% do not come, but I kind of want to focus the woman's experience when they are having a baby in the hospital. Because from my point of view, there are much less care available in the hospital context, but women come to deliver there. So I wanted to ask how they think. This is kind of a midwifery point of view. So when I was searching the literature about this research question, I didn't find much research back then. It was 2008, 2009. So I studied this research when I returned to Tanzania in the following year. This is my doctoral dissertation, Women's Perceptions of Childbirth Experience at the Hospital in Rural Tanzania. And the purpose was to describe maternal perceptions of childbirth experience with respect to the support they received and wish to receive during childbirth at the hospital in rural Tanzania. And you may see the details in my paper, but as a result, what we are finding is there was difference in help and care. There was Swahili words kusaidia and kutunza. There are two different meanings. One means help, one means caretaking. So when I ask about women, what kind of help they are receiving, they talk about technological support from nurses, midwives, and doctors. But when I ask about care, they talk about caring and love support of the family. In the Japanese midwife sense, care also should come from midwives. We, as midwives, provide care, but in the kind of very difficult condition, midwives are too busy delivering babies, providing technological support. So family members are crucial to provide care. And what women want, they were describing safe, normal birth and family support. In fact, it's quite similar to what women describe in Japan. We want safe, normal birth and we want family support. And especially the family support, what they're saying, I want it to be with my mother. I don't know, it's better for me to stay with my mother because I feel secure. And another say, I want my husband, not my mother. I really loved him when I was pregnant, and she was laughing. So family support for them was very, very crucial. And there was gaps, and of course, and when I ask about their experience, they are talking about the gaps that they wanted the nurses or midwives to be with them, but it was not possible. For example, I was calling the nurse, but she was not listening. I was calling her to help me because the contractions are very strong. The nurse told me to wait while she was still walking around. When I was pushing, she told me if I didn't push, she would slap me on the cheek. What upset me was the habit of nursing passing around while I was calling for help. Maybe it'd be better to go to another hospital for another pregnancy. I don't know. I don't even want to have a baby again because nobody will help me. I was very sad to hear this kind of description mothers were giving. I want women to be happy with the baby and happy with pregnancy as a midwife. So I really think we needed to do something to improve this condition. And my implications from the study was the prioritizing providing quality care by listening to woman's voice. At that time, they are very rare to find a study about woman's voice. So my study was trying to give the voices from the woman. And also it is important to integrate family support from antenatal period. Some women come with family, but some don't. It depends on the situation, but if we include family from the antenatal period, they kind of prepare to come with delivery with them. That was very important to have care during delivery. So that was my second implication. And after doing this research, my mission for research became to create an environment where women living in any places can get access to the best care and give birth safely. And there was this statement by WHO in 2014, the prevention and elimination of disrespect and abuse during facility-based childbirth. So that kind of situation was not particular in Tanzania. There are many places women didn't receive proper care in the hospital. So WHO was saying every woman has the right to highest attainable standard of health, which include the right to dignified, respectful health care. And in fact, I translated this statement into Japanese to let Japanese midwives know what's going on in the world. And there was some little review about perception and experience of labor, companionship, qualitative research, synthesis. It was from Cochrane Library. And they are starting kind of a study I was doing and collect all kind of similar study and made a systematic review from qualitative evidence. And it was a kind of a new movement. Before, the only RCTs can be used for the Cochrane Library review, but now they are using qualitative study because it's important to have perception and experience of women. And they use my study as one of their review article. And there was another review article so from social science and medicine about disrespect for intrapartum care during facility-based delivery in sub-Saharan Africa. They also use my study about my woman's experience in Tanzania. This kind of a movement was very important to move the policy changed to focus on women's experience. Then WHO published new guidelines about intrapartum and antenatal care in 2016 and 2018. Now they put the title of a positive childbirth experience, a positive pregnancy experience. So they start focus on women's experience in their recommendations. It's quite important that they change the guidelines to focus on women's experience. And this kind of a project was not very new in Japan. We did a kind of humanized childbirth project through JICA this long time ago. It was 1990. Japanese midwives traveled to, this is Brazil, and provide teaching to the midwives. Then they kind of teach how they take care of women. Then women became, before this project started, women were very loud, screaming, and they were wanting to have cesarean section and so on. But after midwives become more attainable, they started to become very calm and quiet, and they are having more natural births. So it was important to have midwife care to have a natural delivery. And this is the concept of humanized childbirth described by Dr. Misago in the JICA project. And she was describing the value of humanized childbirth. The first one is active participation and decision-making of women. So woman is center in the childbirth. And also evidence-based practice is important, and in a decentralized system of birth attendants and institutions, and community-based primary care. So that is the value we have been doing as a humanized childbirth. And there was another concept of woman-centered care. We want to provide respect, safety, holism, and partnership, then women can become empowered and professional nurses' autonomy can increase. That was the concept we developed in Japan. And in Tanzania, because we wanted to midwives to learn more about this woman-centered care and humanized childbirth, we opened the midwifery master's program in the National University. Then it became a system that midwives can get degree and they can also learn what's important in midwifery. And before COVID, I was traveling to Tanzania many times to provide teaching in practice and theory, and they become very active in promoting humanized childbirth. And also I brought many Japanese students so that they have exchange with Tanzanian students and Tanzanian midwives. And also we invited Tanzania midwives to come and learn in Japan. We have birthing center in the community and women have exercise class and they also experience what pregnant women experience in Japan. And we have a more exchange among young researchers as well. Then we can produce some of the research projects in the country. And the next was my research. This is after that I was listening to the woman's perception. I was developing the educational program so that women can and family member can learn how important it is to prepare a woman to have an institutional delivery, and family can support preparation and attend the delivery together. And this education was very successful, and I changed the paper-based materials into smartphone app, because in Tanzania, smartphone usage is widely increasing. So we started using the educational app so that anybody from anywhere in the country can download and learn from the WHO guideline and my research study. And this originally developed for midwives. Then midwives can learn this WHO guideline. We developed the content according to the each trimester, and content can be used because it explained why it is important to learn about these contents in the guideline and how they can use in the practice. So it's quite easy and useful for them to use the app. And we also provide some of the information about COVID from WHO, because if you are in the front line, it's difficult to have newest information. So through the app, they can get access to the newest information. And we also had the SNS function so that midwives can exchange information and talk about what they are doing, and they can learn from one another. And this is the app usage of the pilot study. And we asked the 24 midwives to download and continue to use, and nearly 90% continued to study at 2 months. And they had very high motivation as a professional group. And there was lack of other source of study materials. So they only use them because they don't have other textbooks or materials. And the app was very new, so they used this app to study, and they enjoyed the communication in the SNS function. And before and after the pilot study, we provided mini quiz, and they increased the score after they learned it through the app. And this is the comment from one of the midwives. They said, "For me, I found the app to be really good. At first, it helped me at any time or anywhere I thought I could educate a pregnant woman. I educated her with confidence because I had material in my hand. So I was always at peace even when I was in our village on a holiday. I was able to open the app if I have pregnant woman and continue providing education without any problem. And when I faced the question, I'm thankful that there were people who are very active, especially that white woman. I have forgotten her name. In fact, it was me. And interviewer said Yoko, and Yoko, yeah, she was active. Sometimes even at night when you ask a question, she answers quickly. So in short, I really enjoyed that I had material in my hand all the time. So that was the effect we were having after introducing the smartphone app educational materials for midwives. Okay, that was my experience as a midwife and research. And now I'd like to share a little bit about leadership in science community. So this is the WHO Chief Nursing Officer, Elizabeth Elo. And she was saying that if you don't have a seat at the table, bring your own chair. As a midwife, you know the patients, you know a pregnant woman, how they experience because you are there. But if you don't bring that information, people don't know it. So people just make policy out of other information. So it's quite important for you, nurses, midwives, to bring information to make policy making. And I joined this WHO collaboration about early essential newborn care in Western Pacific region. They were doing a lot of a project to improve newborn care. And there are many like health policy officers and doctors there, but there was only 2 midwives in the group. So I was really thinking it's important to provide midwifery perspective. Otherwise, they decide their policy without our view. And also I became a member of Young Academy of Japan. This is more for contribution to the Society of Japan. We are trying to improve how we can contribute, how scientists can contribute to the society. And Young Academy was the last term. I was the vice chair. So we are doing a lot of projects together with other disciplines. For example, chemistry or biology or psychology or any kinds of disciplines. We have a lot of other members. So we have interdisciplinary collaboration to make Japan's better. And this is the Global Young Academy. There are 200 scientists who are selected to become a member. And I was only one midwifery researcher there. So I was explaining how midwives are doing research. And I also became an executive committee. I think it's rare for midwife or nurse scientists to be like executive committee leadership position in the science community. It's important to represent so that you can share what you are doing in your very important area. And they also provide science leadership program at the Global Young Academy. As a new member, you can get this program. So I was learning the leadership in Global Young Academy again. And what they are providing is the main idea is collective leadership. There are many aspects leader wants to have. For example, inquire, gather multiple perspectives, connect, understand context and network, engage, inspire ongoing action, strategize, develop credible, relevant solutions, empower, create alignment on goals and direction, reflect, assess challenges and strengths. There are many aspects leaders should have, but you cannot be perfect in all aspects. For example, I think I'm strong in this engage or connect, this kind of parts, but I'm not very strong in this strategize or empower, that kind of part. So I can make a team with somebody who is very strong with strategy making, so that our team can be a very good as a leader. So you don't have to be a perfect leader. You need to collect a member. That is a collective leadership. so that your team can be very strong as a leader. And this is the journey of leadership I read from some book from Noda and Kanai. I would like to share some parts. The book says, the people around me will be happy to help those who have a genuine passion and who seriously talk about their dreams and ambition to realize something. In our leadership journey, we are helped and supported by others. We are not making the most of them. They are making the most of us. And we should believe that by doing so, we can do the best. While self-interest and altruism became merged, and for myself became for others, and for others became for myself, the leader sublimates her dreams into everyone's dreams. So I have been trying to do this kind of leadership so that people will follow me and join that team. Then my team becomes stronger to realize something. So the point of the leadership is find your mission, but be flexible. On the way, there are many problems and difficulty you need to adjust. Or you need to have a mission, but be flexible. The second is to create a foundation, understand the system, to clearly see a way. This is the vision. You need to have vision, but if it's not very realistic, people are difficult to follow. So to make the vision that can be followed by other people, you need to know what system you are dealing with and find a way to solve the issue you are tackling. And the third is connect with others and inspire them with passion, enthusiasm, and joy. That is connection. I am very like to do this connection because I like to make a big team to create a very strong team. So I was giving this lecture and giving speech in many places because I want to inspire other people, and they can also join as a team to become to make the world better. And as a leadership position, I have attended many scientific conferences. And for example, this is a G7 Academy meeting in Paris. Can you see any other young people in the team? Of course not. It's a meeting of the president of academy or Nobel laureates. So there are very senior scientists who are gathering there. But in Japan, they assigned me to go there, and I was very unique. So the chairman asked me what I'm doing, and I was sharing how we should develop young scientists from the point of young scientists and how the voice of young scientists can be involved and seriously considered in the high-level meetings. It's important to bring you the perspective of young people, because if you decide the important decision by only one generation, the other generation can get the consequence, but you don't really contribute it to. So it's important to contribute the decision making from the diverse point of view. This is a Tsukuba conference in Japan. We conducted it in 2019 and 2021. This is before COVID, so we gathered in Tsukuba together with Nobel laureate, and we discussed how we can improve the condition and environment of young scientists so that we can produce better outcomes for the future. And it was important to be aligned with make discussion with Nobel laureate. They are very famous and powerful, but young scientists, we are also have unique perspective, and we can contribute to the society. So we gather together and have discussion together. And also I was talking in IAP, this is Inter-Academy Partnership and UN conference and AAAS and INGSA. This is the International Network of Government Science Advice. And those kind of like meetings, they are doing policy making. So to contribute to policy making, I make the opportunity to very useful for the because I was bringing the perspective of young scientists. And when I was vice chair, I was also invited to talk with the former parliamentary secretary, and we are discussing how we can change the policy for supporting young scientists in Japan. And in the end, the cabinet office announced the whole package to support young scientists in January 2020. And this is when I gave a speech at the United Nations headquarters for the International Day of Women and Girls in Science. And when I gave speech, other young girls and young women are listening to what we make speech. And they, in the end, after the conference, they came to me and said they are very inspired by the speech, and they're happy. They wanted to be like a scientist in the future. So it is important to inspire other people, especially younger generation, so that they dream of more opportunity and get the opportunity in the end. Because of those kind of unique contribution to the society, I was selected as the one of the 100 outstanding women nurse and midwife leaders by WHO, UNFPA, and so on. So I think I was not doing to be like awarded, but when you are doing the unique contribution and using your leadership for the society, somebody will notice you and you'll be rewarded for that. I was very happy to receive this award. Okay, this is my last slide. I'd like to show this take-home message as I shared before. Find your mission, but be flexible. Create a foundation and understand the system to clearly see a way, and connect with others and inspire them with passion, enthusiasm, and joy. And there is a Swahili proverb: if you want to go fast, go alone. If you want to go far, go together. So let's go together, then we can go far. Thank you very much.
Wow, thank you very much, Professor Shimpuku, for amazing presentation, and what an amazing take-home message. Yeah, you're right that we can go far if we are not together. And then actually, I've just realized that I've read many of your works, to be honest. I read some works in Africa about experience pregnant, and then it was very amazing and very insightful. And I thought I also cited your research. And yeah, all right, thank you very much for sharing your amazing experience, and then also sharing your knowledge to us regarding research in midwifery. And then I think it's very great to know your work in Tanzania, which is very different, totally different from your, for your culture, for instance, and then us, even though, to be honest, we also still use that peanut horn in the field. And and it was also taught in education. So yeah, so maybe we can have a further conversation later about that, because it's very diverse, right, in every country. All right, thank you. So now we are coming to the Q&A sessions. So I'd like to let the participants who want to ask a question, or even you have any comments, or even you want to share your experience with Professor Shimpuku here. All right, so any questions? So you could use the raise hand here, or just deliver your questions on the chat box, because we have a bit, we have time, about 25 minutes yeah, to have a conversation here. Okay, any questions so far? Okay, so okay, good. We have Ibu Safira Kansa. So could you please turn on your microphone and then, yeah, just deliver your questions directly. Yeah, could you please unmute yourself? Yeah, because we can still hear your voice. Sorry. Okay, all right.
Okay, thank you. Yeah, I want to ask a question to Professor Yoko. First of all, I'm so glad to see you, Professor, because I'm interested on your research about the childbearing in Tanzania. So what is my question is, how big the patient's psychological conditions to childbearing for women? So is it really affect the woman for birthing a baby? Because I saw one of the slide. It's written that one of the patients said that the midwife doesn't really look like care to the patient. So is it affect to the her childbearing?
Yeah.
Thank you very much for the question. I believe it's important to provide care for the woman so that their experience or their perception of their childbirth experience become better. And that can promote women to come to the hospital again for another pregnancy or any other occasions. The issue of Tanzania is not many people come into the hospital for pregnancy. They consider pregnancy as normal things for regular day. So if there is like bleeding or big issue, they come. But if there is nothing, they don't come. But as a midwife, we know that it's important to provide regular health checkup, and so that they can know if there is any signs of complication, we can notice that and we can provide proper care. So to make women to believe in our midwifery profession and hospital, I believe the psychological effect of the care is very important.
Yeah. Okay, so Ibu Safira. Yeah.
Okay, thank you, Professor.
All right, great. Yeah, so thank you for the answer. So let me just briefly translate it into Indonesian. So ya, benar sekali ya. Jadi memang untuk experience itu sangat penting gitu ya saat ibu dia ketemu dengan bidan. Dan ya, kurang lebih seperti itu. Alright, so next we are moving on to the next questions. Any other question? Or maybe you want to share your experience. So okay, so while waiting for the questions from the parties. Okay. Alright, so oh no, it's the same person. So Ibu Safira, would you like to ask some another questions? Or okay, I think no. Well, I have questions. So we're waiting for the questions to Professor Shimpuku. So it's very interesting to know that one midwife assisted like for 15 to 20 labors a day. So what do you think about that? I mean, did you give them like, I don't know, maybe suggestions or how to, to continue to what I'm trying to say is that to ensure the quality, to ensure the quality, because you know that if you have like that many patients, so I'm sure that it's a bit challenging to do that. Yeah,
that is a very important question, and I was also wondering how we can solve these issues, because there are too many pregnant women already and there are less midwives, and it's not very quick to develop midwives. And because that's why we developed the midwifery master's program in the National University. Then midwifery leader can be developed in the country, and they can go to Ministry of Health, or they can go to district council or hospital. They can become nursing director or nurse in charge. Those kind of leadership positions, they can make change. Especially in the ministry, they can increase the budget for hiring midwives. They can train more midwives, or they can improve the quality of education midwives are getting. That kind of change is needed. Otherwise, if midwives are too much busy already and you want to increase the workload, they cannot do because it's simply impossible. So to make the change in the environment and society, we develop the leaders in the country.
Yeah. Do you think that, I mean, so some women reported that, you know, the midwives did, you know, this were very respectful during labor. So do you think it's also one of the reasons why, because they have a very high workload during labor?
Yes, and they paid much less compared to the standard. So if you don't have enough payment, you have your own family and you are coming for the job and you need to have another job because your salary is low, then it's difficult to be very kind to take care of the patients. So I believe it's important to change the environment, especially work condition and salary. For that, we need to make policy change.
Yeah. I mean, it's very hard, you know, when you have very less payment. But do they have a shortage of midwives in their country? Because I mean, I once had a conversation with my friends who from Ghana, and they said that they have female midwives, while in Indonesia we can't, because the definition of midwives in Indonesia are female. So we men cannot be a midwives. So she told me that in Africa, in general, they allow men to be a midwife. So because they have a shortage of midwives there. So how about Tanzania?
Yes, it's the same in Tanzania. They have male midwives. I think it depends on the scope of practice. In Japan, we don't have male midwives because our scope of practice is very close to women. We do like breast massage for breastfeeding, and we take care of any privacy parts. And for Japanese women, we want women to take care of us for that regard. So by law, we don't have male midwives in Japan. But in Tanzania, what they are doing, the midwives are doing, is delivering babies simply. For that, it's very similar to what obstetrician is doing. Then I think it's possible to become male midwife to just to deliver baby simply.
Yeah, but you have also, you know, male obstetricians, because some people, you know, are wondering why we can have a male obstetrician while we can't have male midwives here. So yeah. I think your answer is very clear because we are very, you know, work very closely to women, right? Okay, so yeah. Jadi tadi saya juga menanyakan gitu, karena di laporannya beliau ya, di penelitiannya beliau tadi bilang bidan-bidan di sana lumayan agak itu ya, tidak ramah gitu, tidak sopan gitu kan kepada kliennya. Ya betul, memang mungkin karena kaitannya dengan tugasnya yang sangat banyak gitu kan. Tadi bisa dilihat jumlahnya 15 sampai 20 persalinan dalam satu hari, dan beliau juga bilang ya itu memang butuh kepemimpinan yang sangat bagus gitu, yang bisa merubah itu gitu, yang bisa memberikan. Dan juga salah satu faktornya tadi kaitannya dengan mereka gajinya sangat dikit gitu, dan malah di bawah rata-rata ya, di bawah standar gitu. Jadi memang itu juga perlu diperhatikan gitu. Meski menurut saya juga di Indonesia much better to be honest ya. Dan nah itu tadi untuk summary ya dari conversation saya dengan beliau. Okay, so we are having another question on the chat box. So let me check. Okay, so yeah. Ibu Mawan had an experience in 2012. She, you know, involved attended a training in Osaka. She saw that midwives in Japan, are more likely to visit. I don't know in whether it's a good translation, but they tend to visit the women, not waiting for the women to come for them. So and then, for example, to meet pregnant women or women with diabetic. So is it included in the curriculum during the education?
So this means like treat like care for complications or home visit, or which is the question?
Yeah. So she tried to say that in Japan, what she observed during her training in Osaka, that midwives, so they're very active. So they don't wait for pregnant women to come to visit them. Instead, they come to visit the women. Is it also part of the curriculum during the education?
It's not a big part of curriculum, but we are allowed to have to make a birth center in the community, and you can be the owner of the birth center. And with the function of birth center, you can visit the homes and to check pregnant women or to check the babies. So I think by law, we are allowed to have that kind of services independently. That is what how I think midwives in Osaka are doing.
So, I mean, is it also, part of the regulation by the government that midwives should visit their patients or their pregnant women?
Yes, by regulation, all mothers who just had a baby, they submit like a postcard to the local governments, and they can send midwife to the home.
Wow. During pregnancy or after labor?
Especially after labor, to check the baby.
Yeah, I think it's similar in Europe countries, right? European countries, some midwives will visit them during postpartum period, right? Ya, sebetulnya itu jadi sebetulnya ya bidan independen ya, jadi katanya boleh gitu. Cuman memang sebetulnya nggak masuk juga gitu di dalam saat pendidikan gitu ya. And then so another sharing experience that, for example, another in the case of preeclampsia, midwives also come to visit the women, to just measure the blood pressure and then prepare the foods, to visit the women at home. Yeah, I mean, it's very good. Yeah, so we can know that actually in Japan they provided such care. So maybe we can also try to have an implementation in our country, in Indonesia, right? Yeah, because sometimes we have also a challenge in terms of utilization. So yeah, there are also some barriers to visit healthcare providers in health facilities in Indonesia, because we have a very various in terms of geography. Yeah, so sometimes they can't reach us. So do you also have a kind of similar situation in Japan? Like geography, or are there barriers to visit midwife?
I think compared to Indonesia, it's not too difficult to access to healthcare and we to go to the home, because geographically we are kind of gathered together. We are island also, but we are not very far. And as the governmental regulation, we are officially sent to their home. So it's kind of easy if the system allows you to do so. So I think the first step is to have communication with the local government or national government as well, to make them kind of a system to send midwives officially to the pregnant woman or woman after birth. then I think it will be easier for midwives to do so.
Ya, alright. Ya, jadi memang harus kerjasama juga dengan pemerintah lokal ya. Kalau memang misalnya kita ingin memberikan layanan gitu kepada ibu-ibu gitu kan, karena memang kita nggak bisa deny kalau di Indonesia kan masih banyak ibu-ibu ya yang masih terbatas karena akses gitu kan. Yeah, any more questions or thoughts or comments or what you want to share experience? If you don't have any more questions, I have the last questions, because our topic on this session is actually related to research, right? So how to, because actually we have a very good research over there, but sometimes it's very difficult to implement, to be like evidence-based practice. So do you have any advice so how to merge that research to be evidence?
So as I am doing in Tanzania, I try to merge this big guideline made by WHO and practice in the field. And there should be something in the middle. You need to explain why this guideline is important and how you can use this information in the practice. If there is no connection between that, it's difficult to use guideline in the practice. So evidence-based practice is much harder. So I try to be like moderator of these two, then provide the information for frontier workers. I think somebody who has academic knowledge can translate that kind of guideline into practice. It will be easier for everyone to do evidence-based practice.
All right, thank you very much. And yeah, we still have another questions. Ibu Mirani, could you please turn on your microphone, and then you can deliver your questions. Nah, Ibu Mirani, silakan. Ibu Mirani Safaringga. Atau kita ke Bu Fatima Tuzahra. Silakan Ibu Fatima.
Sorry, I can unmute myself. Just unmute by committee. Thank you, our beautiful moderator. I'm so glad to see you, Miss Margie. Your accent, it's so make me feel like facing a native. And Ms. Yako, I'm so impressed with your experience and your research experience and practice. And I just want to have a simple question. My question is whether in Africa there is no effort from government or institution or non-profit organization to help healthcare there. We know all eyes will be very concerned about Africa regarding health issues today. How is your experience about this, especially about the health of pregnant woman or a child or teenage health? And how about today? I know you conduct your research several years ago, and how about today? I'm just curious what happened now in Tanzania. That's it, Ms. Margie. Thank you.
Yeah, all right. Thank you very much for the questions. So yeah, Professor.
Okay, thank you very much for the questions. And in Tanzania, government are providing free care for pregnant women and children under 5. So the cost is not a big issue because they are provided as free. The issue is women do not come to the healthcare or hospital because of many other reasons. As I said, there could be a psychological reason. They have bad experience before, so they don't believe in healthcare. Or there are some other costs you cannot pay, like transportation or that kind of thing, because they live very far from the hospital. That is another thing. So to solve that issue, I was trying to provide support by a smartphone app because they have smartphone and they can download the app. Then they can access to the information. Then this app is promoting preparation and come to the hospital. So I hope in the future, more people will come to the hospital because they have connection through the app and they believe in healthcare.
Ya, ya, ya. Jadi memang app-nya tadi bisa bantu ya juga ya untuk akses ya. Dan harapannya memang semakin banyak gitu ya karena kan hanya membutuhkan koneksi sebetulnya ya. Okay. So now we are still having another people who want to ask. Ibu Fatima. So apakah bisa dibantu untuk meng-unmute beliau dari panitia? Silakan Ibu Fatima Zahra. Okay, so we're still having other questions in the chat box. So let me read the question for you. And yeah, in Indonesia, midwives, the government provides some trainings for midwives, such as normal labor, and then CTU in terms of the family planning, and then to be able to support midwives to do their work. So in Japan, do you have trainings for midwife, or is just literally from their educations?
Yes, we do have training for midwives after graduation. So we get education in university or colleges. Then after graduation, there are many kind of training or like study group or those things through Midwifery Association or Academy of Midwifery. Those kind of places you can access. And many of the training are free or very cheap price. So midwives can update the knowledge without much of the cost.
Yeah. So ada juga ya trainingnya ya. And then one of the two last questions. So what kind of efforts that Japan government have done to reduce maternal and neonatal mortality?
In the context of Japan, I believe one was the education of midwives. Long time ago, like 100 years ago, we also had very high maternal mortality and infant mortality. But we educate midwives back then was still like traditional birth attendants, and we educated them, and their practice become more scientific and evidence-based. Then mortality became lower. And there are many other policies that support midwives and mothers and babies. For example, maternal or child health handbook we are producing, and I think we imported it in Indonesia. I think those kind of education for pregnant women is also the key, because without educating themselves, it's quite difficult to find complication or any issues, because they don't stay in hospital for the whole pregnancy. They are stay at home. So we need to educate pregnant women through this kind of policy. Then it's mortality ratio become lower.
Yeah. All right, thank you. And then we're still having another questions in the chat box. And I think I also experienced that. I mean, yeah, Ibu Octavian has an experience to go to a job fair, and then there were many, institutions who offer midwives to work there, but she found out that there are only nurses in Japan. So in Japan, our midwives are different with nurses, because I also got some offers for my students to go to work in Japan, but I'm just wondering, because they actually call us. They know that we are midwives, but they actually provide that we will work in Japan as a nurse. So yeah.
That issue I understand. We have nursing license, but after getting nursing license, we need to get education as a midwife to like upgrade as a midwife. So the first step you have to have is nurse. You all have to have nursing license to become midwives. So you are get offered as a nursing in the beginning because you have to have it. In the future, if you get education and pass the qualifying exam, you can be a midwife in the future. But first, you have to be a nurse.
All right. Oh yeah, all right. It's clear. I mean, we used to be like that in 90s. Yeah, but now we can, study midwifery right after the high school, like in the UK, because I mean, yeah, in the US and other countries, I think, yeah, it's similar to Japan. All right, so one more question. I think this is the last question because we got many questions for Professor Shimpuku because your amazing presentation, I guess. All right, so one last question. Is home birth allowed in Japan?
It's very less now.
Okay.
After the war, we kind of got the system from the US, and from the US, we were kind of taught to have institutional delivery, hospital birth, and midwifery home birth is only less than 1%. It exists, but very rare nowadays.
Mm-hmm. Is it because home birth is not safe in Japan?
It's safe, but people believe it's safer in the hospital. And there are many hospitals you can access to, and we have kind of too many hospitals or clinics that can offer the service. And nowadays, women kind of prefer to go to the hospital.
Oke, ya jadi masih boleh, cuman nggak banyak katanya, kurang dari 1%, karena memang persalinan di Fasiankes lebih aman, ya, evidence menunjukkan. If you don't mind, we still having one more questions. All right, so yeah, this is gonna be the last questions. All right, so one more. The question is about how to screen whether the women is high risk in Japan, because in Indonesia we have a local versions to detect the high risk pregnant women.
In Japan, we are having many antenatal care visits. In average, women come to the hospital 14 times per pregnancy. And during the visit, we check the health conditions and women are examined if they have risk or not. So according to this health checkup, they are diagnosed as risky or not. So during the antenatal visit, we provide checks.
Do you have kind of scale, to use to tell whether the women are high risk?
Yeah, we do have it. According to the Ministry of Health, we have the scale, but we can use. But even without the scale, we can individually check the woman. Then we just assess and diagnose if women are risky or not.
All right. Thank you very much for Professor Shimpuku for your amazing and very insightful presentation, and then your answers to all the participants' questions. I was including my questions. Yeah, thank you very much. I really enjoy your works, and I always read your publication, to be honest. And I'm very honored to be able to meet you virtually in these occasions. All right, so let's come to the conclusions. Yeah, we've learned a lot from Professor Shimpuku that, actually every country has, their own culture, unique. But again, our goal is to be, good healthcare workers for mothers, and we'll try our best. So don't forget that evidence is very important to support us during our practice. So yeah. Thank you very much for Professor Shimpuku, and then for UNAND, yeah, for this amazing conference. And again, I'd like to send my gratitude to UNAND for letting me to be a moderator again today. And then, yeah, we are looking forward to, attending your another conference next year. All right, thank you very much for today's sessions. And then, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. And I'm giving back to the MC.
Okay, thank you. Thank you, Mrs. Mergi. We would like to continue our schedule, but firstly, I also want to thank for very excellent experience and priceless knowledge that Professor Yoko Simpuku delivered to us today. Well, I would like to inform to all of the participants today that we should rearrange our rundown that perhaps you already read on the WhatsApp group, but however, because of some of the things, we should postpone our next schedule. So we will have a break for 1 hour and 30 minutes. So our next session will start in 12:30. Jadi saya mau menginformasikan kepada semua partisipan di sini bahwasanya karena sesuatu hal narasumber kita akan melanjutkan sesinya di sesi ke-6 pada jam 12.30 sehingganya kita akan ada break di 1,5 jam mulai dari jam 11 ini sampai jam 12.30. Untuk semua partisipan dapat stay di sini atau juga dapat bergabung kembali pada jam 12.30 untuk mengikuti kegiatan kita selanjutnya karena masih ada banyak narasumber yang hebat-hebat dan juga membawa experience yang luar biasa sekali untuk kita. Dan juga saya ingin menginformasikan kepada peserta oral presentation yang belum menyelesaikan presentasinya tadi dapat mengikuti kembali atau bergabung kembali ke breakout room yang sesuai dengan kelompok masing-masing dan juga melanjutkan presentasi selama masa sesi break ini. Baik, untuk itu saya undur diri dan silahkan melanjutkan kegiatannya masing-masing jika ingin makan atau sholat dan lain-lain. Saya persilahkan. Baik, Assalamualaikum warahmatullahi wabarakatuh. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. So in this occasion, I would like to open our seminar again. I would like to also remind that on this happy occasion, there are several rules that must be obeyed by all the participants. First of all, please rename your Zoom account by writing the name of the institution and then put your name after the underscores. Secondly, please turn off the microphone and listen actively. And third, we will very happy if you could open your video camera in a polite context. And then fourth, Q&A session will be held after the presentation led by the moderator. Fifth, for the participant who wants to ask a question, you can write it in Zoom chat column, but we will prioritize the participant who wants to interact directly with the using raise hand feature. And lastly, your attendance will be proven by filling the attendance link on the Google. So you will get the afternoon session after this session ending. Okay, guys. We would like to start our sixth session for our seminar. The keynote speaker for this session is Dr. Efrida MKes SPK from Andalas University with the topic Updates of Education Learning Methods in Health Education. The next discussion will lead by Bu Heni Fitria SSTMK as moderator. But firstly, I will share her awesome background first, yeah? Okay, it's already appeared in your screen that our ma'am here, Heni Fitria SSTMK, is a lecturer and also midwife since 2016, 2011. So she started her education in midwifery in 2008 in Poltekkes Kemenkes Padang and gradually continue her study and got her title in master degree in 2017 in Master of Midwifery, Faculty of Medicine, Andalas University. But now she's a lecturer in undergraduate midwifery program, Andalas University. So we can see here, there's a lot of certifications in basic obstetric maternal neonatal life support in 2016. And then she also gained certificate mom and baby therapist in 2019. And lastly, acupressure for midwifery in 2022. She also have a very strong track record in research. Like recently, she got the association between the macronutrient intake with stunting incident in children aged 24 until 59 months in the Ikurkoto Primary Health Care Center of Padang. And I think many more track record that I could say one by one. However, I will greet our great moderator today. Good afternoon, Ibu Heni.
Good afternoon, Miss Hani.
Yeah, so Bu Heni is actually my lecturer too in midwifery program. So have you take your lunch, ma'am? Okay.
Yes, of course.
Okay, nice. Then for the next session, I will give the screen and the control to Ma'am Hani. Time is yours, ma'am.
Thank you very much, Hani. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang dan salam sejahtera untuk kita semua. Ibu-ibu, kita akan melanjutkan kegiatan berikutnya pada Annual Conference of Midwifery 2022 hari ini. Memasuki sesi berikutnya, izinkan saya, Heni Fitria, yang akan memandu sesi 6 kegiatan kali ini. Nah, pada kesempatan kali ini kita akan disampaikan topik yaitu Update of Educational Learning Method in Health Education oleh pembicara yang sudah membersamai kita yaitu Ibu Dr. Efrida MKes, SPPK Konsultan. Sebelumnya saya ucapkan terima kasih dan selamat datang kepada Ibu Efrida yang nantinya akan memberikan pemaparan kepada kita semua. Selamat siang Ibu.
Terima kasih, selamat siang Bu Heni.
Iya, terima kasih Bu udah join. Baik, izinkan saya untuk menyampaikan sedikit profil beliau. Ibu Dr. Efrida SPPK Konsultan MKes. Beliau lahir di Kota Pekanbaru 2 Oktober 1970 dan saat ini beliau bekerja pada Fakultas Kedokteran Universitas Andalas dan juga di RSUP Dr. M. Jamil Padang. Riwayat pendidikan beliau, S1, beliau selesaikan pada tahun 1995 di Fakultas Kedokteran Universitas Andalas, kemudian melanjutkan SP1 pada Fakultas Kedokteran Universitas Pajajaran dan selesai pada tahun 2007. S2 beliau juga lulus pada tahun 2007 di Fakultas Kedokteran Universitas Pajajaran. Kemudian beliau melanjutkan S3 pada Biomedis Fakultas Kedokteran Universitas Andalas. Kemudian SP2 lulus pada tahun 2019 di Fakultas Kedokteran Universitas Gadjah Mada. Beliau juga memegang beberapa pekerjaan dan jabatan, diantaranya adalah Kepala UGD Rumah Sakit Umum Daerah Muara Labu, kemudian pimpinan Puskesmas Surian Kabupaten Solok Selatan, Dokter Poliklinik Rumah Sakit Umum Aisyah Padang, Rumah Sakit Islam Yarsi Padang, staf pengajar di Hiperkes Padang, Apikes Dharma Lambau, Stikes Perintis Padang, SMF Laboratorium Rumah Sakit Hermina, Rumah Sakit SPH, kemudian Sekretaris Bapem FK UNAND, Ketua Bagian Patologi Klinik dan Kedokteran Laboratorium FK UNAND, Kepala KSM Patologi Klinik dan Kedokteran Laboratorium Rumah Sakit Umum M. Jamil, Sekretaris Program Studi PPDS Patologi Klinik FK UNAND, Kepala Laboratorium Biomedik FK UNAND, Ketua PDS Patklin Cabang Padang, anggota Komisi Ujian Nasional Kolegium Patologi Klinik, dan Wakil Dekan 1 Fakultas Kedokteran Universitas Andalas pada saat sekarang. Beliau juga aktif dalam berbagai organisasi, diantaranya Ikatan Dokter Indonesia, PDS Patologi Klinik, Himpunan Kimia Klinik Indonesia, Perhimpunan Onkologi Indonesia, Perhimpunan Hematologi dan Transfusi Darah Indonesia, Kolegium Patologi Klinik Indonesia, dan Perhimpunan Biokimia dan Biologi Molekuler Indonesia. Demikian profil singkat beliau. Baiklah Ibu-Ibu peserta, sebelum materi disampaikan oleh narasumber, izinkan saya untuk mengingatkan beberapa ketentuan pada sesi ini. Pemaparan oleh moderator, oleh narasumber kurang lebih selama 60 menit. Setelah itu kita masuk pada sesi tanya jawab. Bagi ibu-ibu peserta yang ingin menyampaikan pertanyaan, boleh menuliskan pada kolom chat ataupun raise hand pada saat diskusi. Terima kasih. Ibu-ibu peserta, selanjutnya kita akan menyaksikan pemaparan materi dari pembicara kita. Kepada Ibu, kami persilahkan.
Baik, terima kasih Ibu Heni. Suara saya cukup jelas terdengar?
Jelas, Bu.
Baik. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Pertama izinkan saya menyampaikan ucapan terima kasih atas waktu yang diberikan untuk sharing informasi terkait dengan judul yang diberikan kepada saya, yaitu update metode pembelajaran dalam pendidikan kedokteran. Slide. Mohon maaf, ini kayaknya terbalik slide setelahnya. Nah, ini adalah beberapa alasan kenapa perlu adanya update metode pembelajaran dalam pendidikan kesehatan. Jadi seperti kita ketahui, pendidikan adalah suatu proses yang dinamis, sehingga perlu selalu dilakukan secara periodik revisi terkait dengan kurikulum, kemudian terkait dengan metode pembelajaran ataupun metode-metode asesmen sehingga dapat mencapai apa yang sudah dicantumkan pada kurikulum terkait dengan profil maupun capaian pembelajaran yang kita inginkan terhadap mahasiswa. Kemudian beberapa hal yang menjadi latar belakang kenapa penting melakukan update ini adalah teknik pengajaran yang kurang inovatif pada suasana akademik membuat kurikulum itu menjadi inadekuat, dan ini merupakan suatu hambatan yang signifikan untuk lebih baik atau lebih maju ke depannya. Dan pelajar ataupun mahasiswa tentu saja membutuhkan skill yang inovatif melalui pembelajaran interprofesional, apalagi untuk pendidikan kesehatan, baik itu bidan, perawat, ataupun dokter, tentu saja sangat membutuhkan interprofessional learning. Oleh karena itu, perlu untuk memperkenalkan dan mengimplementasikan suatu kurikulum yang fleksibel, yang mengakomodir pembelajaran yang modern, untuk terjadinya keseimbangan dan untuk menjembatani adanya gap antara metode pembelajaran yang tradisional ataupun konvensional dengan pembelajaran modern yang dibutuhkan. Slide, mungkin ke slide pertama. Slide pertama, nah ini dia. Oh ya, jadi mengapa perlu dilakukan update serta inovasi terkait dengan pendidikan kesehatan? Yang pertama adalah adanya ketidaksesuaian, kalau kita amati sering adanya ketidaksesuaian antara kebutuhan masyarakat atau populasi dengan kurikulum pendidikan kesehatan. Nah, inilah perlunya kita menetapkan di awal visi keilmuan dari suatu program studi, kemana arah yang akan kita capai 25 tahun ke depan atau 50 tahun ke depan terhadap program studi dan lulusan kita. Nah, ini juga kita perlu mencermati adanya Undang-Undang Perguruan Tinggi Nomor 12 Tahun 2012 tentang reposisi perguruan tinggi, di mana di situ disebutkan bahwa program studi itu perlu memiliki visi keilmuan, karena dari situlah diarahkan kemana nanti lulusan kita akan memiliki keunggulan ataupun penciri dari suatu program studi dibandingkan dengan program studi lainnya. Dan tentu saja visi keilmuan dari program studi ini harus berdasarkan kebutuhan pengguna, kebutuhan stakeholder, sehingga ketidaksesuaian antara kebutuhan masyarakat atau kebutuhan pengguna, kebutuhan populasi dengan kurikulum ini dapat diatasi. Kemudian yang kedua adalah kurikulum yang sudah ketinggalan atau outdated, serta metode pembelajaran yang juga sudah tidak sesuai dengan kebutuhan. Sehingga kita perlu melakukan secara periodik revisi kurikulum baik yang bersifat minor maupun yang bersifat mayor. Dan perlu kita cermati bahwa sesungguhnya seperti yang dipaparkan di awal bahwa kurikulum itu sesuatu yang bersifat dinamis, sehingga bisa saja terjadi perubahan setiap saat tergantung kepada kebutuhan pengguna. Kemudian alasan yang ketiga adalah jumlah sekolah-sekolah kesehatan yang semakin banyak jumlahnya. Tidak hanya Fakultas Kedokteran, pendidikan kedokteran yang sampai saat ini saja di Indonesia sudah lebih dari 90, namun juga pendidikan kesehatan lainnya termasuk bidan dan perawat serta sekolah-sekolah kesehatan lainnya. Karena memang dari survei yang dilakukan, lapangan kerja untuk sekolah-sekolah kesehatan termasuk luas dan masih sangat dibutuhkan, apalagi untuk di Indonesia. Masih terdapat kekurangan ratusan ribu tenaga kesehatan, sehingga berbagai medical school pun saat ini didirikan. Oleh karena itu perlu standarisasi metode pembelajaran, sehingga lulusan yang dihasilkan pun akan terstandar. Kemudian mengapa perlu update? Karena perlu peningkatan kualitas. Jadi tidak hanya kuantitas, tapi juga perlu peningkatan kualitas terkait dengan pembelajaran. Kemudian hal lainnya adalah karena tidak adekuatnya bimbingan karir yang dapat membantu mahasiswa ataupun pelajar untuk membuat keputusan terkait dengan profesi kesehatan yang dipilihnya untuk karir ke depan. Ini mungkin lebih bersifat atau ditujukan kepada spesialis, ya dokter spesialis, karena memang banyak sekali spesialisasi, tidak hanya spesialisasi satu tapi juga dua, dan itu tentu saja membutuhkan bimbingan karir sehingga mahasiswa dapat mengarahkan pilihan profesi kesehatan yang diminatinya. Slide selanjutnya. Slide selanjutnya.
Bentar Bu, mohon maaf. Ini sepertinya ada kendala sedikit.
Ya, tadi. Ya. Nah, ini juga mengapa kita perlu melakukan update adalah kurang adekuatnya kemampuan serta kompetensi pada pendidikan kesehatan. Kemudian oleh karena masih berkembang atau masih berjalannya teknik-teknik pembelajaran tradisional ataupun konvensional, walaupun sebenarnya sudah ada metode-metode baru yang diimplementasikan secara saintifik dan berdasarkan evidence base. Selanjutnya. Umirani selanjutnya. Ini ya. Apa yang bisa dilakukan oleh institusi terkait dengan kepentingan update tadi? Yang pertama adalah mendidik profesional dengan kualitas yang baik untuk melakukan pengajaran dan pelatihan pada sarana pembelajaran kesehatan. Nah, ini merupakan faktor penting untuk meningkatkan pengajaran, efektivitas, serta vitalitas akademik. Ini dapat dilakukan dengan berbagai metode. Kalau kita contohkan di institusi kita, akan selalu ada peningkatan mutu untuk meningkatkan kualitas staf pengajar melalui berbagai kegiatan refreshing, baik itu refreshing tutorial, kemudian instruktur skills lab, pelatihan-pelatihan pembuatan skenario, dan lain sebagainya. Kemudian meningkatkan ketertarikan serta motivasi institusi merupakan hal yang krusial, di mana pengembangan fakultas menjadi suatu dasar yang penting dalam meningkatkan suasana akademik serta inovasi-inovasi. Nah, ini tentu saja membutuhkan orang-orang ataupun pemimpin-pemimpin yang memiliki motivasi tinggi untuk pengembangan institusi sehingga dapat dihasilkan suasana akademik yang unggul dan inovatif. Slide selanjutnya. Nah, ini saya ambil dari beberapa guideline terkait dengan dasar utama dalam melakukan pembelajaran pendidikan kesehatan. Yang pertama adalah adanya kompetensi di masing-masing bidang. Nah, ini mutlak diperlukan jika kita ingin menghasilkan lulusan yang memang sesuai dengan kompetensi yang kita harapkan. Tetapi di dalam prakteknya sebenarnya ini juga perlu kecermatan kita masing-masing karena adanya secara kompetensi di antara masing-masing bidang. Saya contohkan misalnya saya sebagai seorang clinical pathologist, dalam hal ini banyak sekali secara kompetensi yang menyangkut ke bidang lain. Namun tentunya institusi perlu menetapkan bahwa saya ini lebih cocoknya kompetensinya di mana dan memberikan bahan ajar apa sehingga memang memberikan kompetensi yang baik bagi mahasiswa. Saya contohkan misalnya ya untuk di kebidanan misalnya. Ada pemeriksaan protein urin misalnya. Protein urin ini tentu saja diarahkan nanti untuk mendeteksi atau men-screening ibu-ibu hamil dengan kecenderungan preeklamsi atau eklamsi. Namun di sisi lain, hal ini juga bisa diberikan oleh praktisi lain, misalnya ahli biokimia misalnya. Tapi dikembalikan lagi ini kompetensi apa yang diharapkan bagi seorang bidan misalnya. Kalau dia hanya sekedar ingin pandai untuk melakukan secara prosedural pemeriksaan protein urin, maka itu tentunya tidak itu yang kita harapkan, karena itu bisa saja dilakukan oleh seorang laboran misalnya, bahkan mungkin laboran lebih kompeten dibandingkan dengan seorang bidan. Tapi tentu saja di balik itu harus diketahui bahwa pemeriksaan itu memiliki kaidah-kaidah sehingga hasil yang dikeluarkan valid dan akurat dan terpercaya, presisi dan akurasi. Sehingga ada tahap-tahap yang perlu dilalui, mulai dari pengumpulan spesimen, transportasi, bagaimana mengedukasi pasien untuk mengumpulkan sampel, bagaimana transportasi sampai di lab, pengerjaan, di dalam pengerjaan ada prosedural yang harus dikontrol kualitasnya, kemudian dalam hal pelaporan bagaimana menginterpretasikannya sehingga dapat diterima dengan baik oleh klinisi. Nah tentu itu bukan bidangnya orang yang ahli di biokimia, tapi adalah seorang clinical pathologist. Nah, kompetensi di masing-masing bidang ini perlu dimaklumi bersama-sama sehingga memang kita bertanggung jawab penuh terhadap kompetensi yang diharapkan ke mahasiswa. Kemudian capaian pembelajaran lulusan yang tentu saja harus tercantum jelas di kurikulum. Kemudian setelah capaian pembelajaran lulusan kita tetapkan, maka tentu kita perlu menetapkan capaian pembelajaran mata kuliah ataupun modul atau stase atau sesi pembelajaran. Kemudian tentu setelah kita menetapkan capaian pembelajaran, kemudian capaian pembelajaran mata kuliah, bagaimana metode pembelajaran yang akan kita pergunakan, terakhir adalah bagaimana asesmen yang kita lakukan, sehingga dapat menjawab apakah kompetensi sudah tercapai atau belum. Slide selanjutnya. Nah, ini saya kutip dari pernyataan dari WHO, bahwa pendidikan kesehatan itu sebenarnya tidak terbatas dari hanya sekedar mendiseminasikan informasi-informasi terkait kesehatan, tetapi juga bagaimana menumbuhkan motivasi, kemudian memperkuat atau lebih baik dalam hal skills, serta juga confidence, kepercayaan, menumbuhkan kepercayaan diri sendiri, sehingga kita dapat mengambil suatu tindakan atau aksi untuk meningkatkan kesehatan. Jadi luas sekali sebenarnya apa yang dimaksudkan dengan pendidikan kesehatan oleh WHO. Tidak hanya dalam hal menyebarkan informasi kesehatan, tapi juga bagaimana meningkatkan motivasi, skills, kepercayaan diri sendiri sehingga kita dapat melakukan suatu aksi atau perbuatan untuk meningkatkan derajat kesehatan. Sehingga WHO menyampaikan bahwa pendidikan kesehatan itu haruslah berfokus kepada 4 hal. Yang pertama adalah bagaimana meningkatkan kapasitas individu melalui pendidikan. Kemudian yang kedua meningkatkan motivasi, kemudian membangun skill, Kemudian meningkatkan teknik-teknik untuk meningkatkan kesadaran. Nah, ini merupakan poin-poin penting yang harus kita cermati bersama, bagaimana menimbulkan motivasi kepada mahasiswa. Karena tanpa motivasi, tanpa rasa ingin tahu, tentu saja kecerdasan yang sudah ada akan menjadi sesuatu yang tidak ada manfaatnya karena tidak ada keinginan untuk berbuat atau berperilaku seperti itu. Slide selanjutnya. Ini beberapa penelitian yang malah menggunakan model atau teori pendidikan kesehatan ini, promosi kesehatan ini untuk mendesain program-program di universitas terkait dengan pengembangan kurikulum dan lain sebagainya. Jika kita lihat sejarahnya di FK kita sendiri, maka ketika kita mulai melakukan proses pembelajaran PBL, Problem Based Learning, maka saat itu prodi-prodi lain pun di luar FK UNAND berupaya juga untuk mengembangkan problem based learning ini, karena ternyata memang dari berbagai artikel ternyata dengan menggunakan metode problem based learning, mahasiswa lebih dapat mengakomodir atau lebih dapat mengenal lebih dini permasalahan-permasalahan kesehatan dan dapat mengintegrasikan ilmu yang diperolehnya lebih awal. Kemudian penelitian-penelitian lain juga telah menggunakan pendidikan kesehatan dan promosi kesehatan ini sebagai model untuk pendidikan, bagaimana pengajaran pendidikan kesehatan dilakukan. Slide. Nah, ini dari Sadegi. Saya ambil dari Sadegi, mendapatkan beberapa metode yang inovatif dalam melakukan pendidikan kesehatan dan beberapa pelatihan terkait dengan kesehatan. Nah, pertama katanya bisa menggunakan YouTube, kemudian menggunakan metode simulasi, kemudian menggunakan smart mobile device, perangkat seluler dalam kerangka social network. Kemudian menggunakan feedback dari pasien, bagaimana persepsi pasien terhadap mahasiswa, dan itu kita pergunakan untuk meningkatkan kualitas mahasiswa. Mungkin bisa melalui kuesioner yang kita rancang sedemikian rupa, sehingga kita dapat menggali bagaimana persepsi pasien terhadap mahasiswa yang sedang melakukan pembelajaran, misalnya bedside teaching misalnya. Slide. Ini dengan menggunakan YouTube, sebenarnya mungkin kita sudah melaksanakan juga dari beberapa keterampilan klinik yang kita share di YouTube, ternyata memang itu dapat meningkatkan pemahaman yang lebih baik dari apa yang kita share ke mahasiswa. Di samping itu tentu saja lebih mempersingkat waktu karena apa yang ada kita videokan dan kemudian kita suruh mahasiswa untuk menonton terlebih dahulu, tentu saja akan lebih menimbulkan pemahaman yang baik bagi mahasiswa sebelum kita melakukan latihan. Kemudian di samping video-video Quizlet, kita juga dapat memberikan bahan ajar melalui video YouTube sebelum kita melakukan pertemuan secara langsung kepada mahasiswa. Dan kemudian juga dengan menggunakan YouTube ini tentu saja lebih memperkaya lingkungan pembelajaran. Ada inovasi-inovasi baru mungkin yang ada di berbagai YouTube dan itu sudah ditonton oleh mahasiswa sebelumnya, sehingga lebih memudahkan bagi kita ketika melakukan pembelajaran secara langsung. Dan adanya strategi-strategi baru dalam pembelajaran tentu saja lebih memotivasi dan lebih mengikut sertakan mahasiswa untuk mengenal teknologi-teknologi baru. Slide selanjutnya. Nah, kemudian ada metode lain yang disampaikan untuk lebih meningkatkan pemahaman pembelajaran simulasi. Di sini dikatakan pada artikel ini sebenarnya simulasi ini lazim dipergunakan dalam pembelajaran, tetapi tidak hal yang biasa pada pendidikan kesehatan. Nah, setelah saya baca lebih lanjut artikel ini, ternyata yang dimaksud dengan simulasi ini adalah seperti virtual reality. Jadi bagaimana kita berada di dalam suasana itu. Jadi benar-benar berada di suasana itu seperti kita main game. Nah, ini mungkin yang dimaksudkan belum merupakan hal yang biasa pada pendidikan kesehatan. Walaupun sebenarnya di beberapa institusi simulasi berupa virtual reality ini sudah dipergunakan pada beberapa metode pembelajaran, terutama pada kasus-kasus yang sulit atau yang jarang, kemudian dibuat suatu virtual reality sehingga si mahasiswa merasa benar-benar berada di dalam lingkungan yang sulit tersebut. Nah, ini mungkin simulasi yang dimaksudkan pada artikel ini. Karena kalau kita melakukan simulasi, sebenarnya pada setiap aktivitas pembelajaran kita melakukan simulasi. Misalnya sebelum kita melakukan atau melatihkan keterampilan kepada mahasiswa, tentu kita melakukan simulasi terlebih dahulu, kemudian mahasiswa kita lihat bagaimana mengerjakannya, kemudian diberikan feedback. Tapi yang dimaksud pada artikel ini, simulasi ini sebenarnya adalah simulasi secara virtual reality, sehingga bagaimana mahasiswa benar-benar terlibat di dalam situasi tersebut. Slide selanjutnya. Nah, ini tadi yang metode lain, yaitu menggunakan perangkat smart seluler dalam praktek pendidikan kesehatan berbasis jejaring sosial. Nah, ini juga merupakan suatu inovasi dalam pembelajaran kesehatan, di mana di beberapa institusi juga di dalam review artikel ini dijelaskan bagaimana kita bisa melakukan sharing ilmu pengetahuan, misalnya terkait dengan kearifan lokal di suatu negara, misalnya yang tidak ada di negara lain. Nah, melalui jejaring sosial yang kita buat, kita dapat melakukan focus group discussion atau melakukan pertemuan langsung melalui media sosial sehingga dapat dilakukan sharing ilmu pada saat itu. Atau misalnya di suatu negara atau di Indonesia misalnya, banyak penyakit-penyakit tropis yang tidak ada di negara lain, maka ini juga bisa didiskusikan melalui perangkat smart seluler dengan membentuk suatu grup-grup diskusi sehingga dapat berbagi informasi. Kita mengetahui tentu saja saat ini smart mobile device ini menjadi suatu perangkat seperti suatu kewajiban ada pada setiap orang, sehingga tidak salahnya atau sangat tepatlah kita mempergunakan smart mobile device ini untuk meningkatkan inovasi pembelajaran. Tapi tentu saja kita harus melihat apa kira-kira yang perlu kita diskusikan dalam kerangka jejaring sosial ini. Dan tentu saja melalui jejaring sosial ini kita dapat melakukan penelitian-penelitian bersama dengan berbagai institusi. Slide selanjutnya. Nah, ini tadi yang terakhir disampaikan oleh peneliti terkait dengan inovasi pembelajaran adalah bagaimana kita mendapatkan refleksi diri seorang mahasiswa dari pasien yang dirawatnya. Nah, ini sebenarnya juga sudah dipergunakan di beberapa fakultas kedokteran, dan kebanyakan ini dipergunakan untuk mahasiswa yang melakukan bedside teaching, artinya melakukan pemeriksaan kepada pasien. Kemudian setelah itu, setelah mereka selesai melakukan visit ke pasien, maka diberikanlah kuesioner kepada pasien dengan seluruh pertanyaan yang diharapkan dapat menggali bagaimana mahasiswa berkomunikasi, kemudian bagaimana empati mahasiswa terhadap pasien, kemudian bagaimana cara melakukan pemeriksaan, apakah skill-nya sudah terpenuhi. Nah, itu kita harapkan ada persepsi atau refleksi diri mahasiswa dari pasien. Kemudian temuan itu tentu saja akan disampaikan kepada pembimbingnya atau preseptornya, dan ini akan sangat membantu sekali feedback pasien ini supaya bisa meningkatkan kemampuan mempromot skill staf kompetensi mahasiswa. Nah, ini merupakan metode sebenarnya yang sangat mudah kita lakukan dengan menyusun terlebih dahulu kuesioner untuk menggali beberapa hal yang tadi sudah dijelaskan terkait dengan komunikasi, empati, kemudian skill. Kita sebenarnya juga bisa menggali refleksi mahasiswa ini dari selain dari pasien juga dari keluarga pasien. Jadi banyak hal sebenarnya yang bisa kita lakukan untuk meningkatkan kompetensi mahasiswa. Slide selanjutnya. Nah, ini adalah beberapa metode pembelajaran modern yang saya ambil dari beberapa artikel. Jadi yang pertama adalah case-based learning. Jadi bagaimana dengan case-based learning ini mahasiswa memperoleh kasus dari awal, dan dari kasus itulah mereka kemudian mengambil kembali prior knowledge yang sudah mereka pelajari sebelumnya. Kemudian evidence-based medicine ini sebenarnya evidence-based medicine ini bagaimana cara kita mengambil keputusan terkait dengan pengobatan ataupun penegakan diagnosis berdasarkan penelitian-penelitian yang sudah dipublish. Nah, ini juga ada metodenya bagaimana kita mengambil suatu artikel sehingga dapat diambil sebagai evidence base untuk meningkatkan pelayanan. Kemudian juga metode pembelajaran lainnya adalah problem based learning, dan ini sudah kita lakukan sebenarnya bagaimana mahasiswa dipaparkan dengan skenario-skenario dari awal, kemudian didiskusikan pada diskusi tutorial, sehingga memang kita harapkan mahasiswa sudah terpapar dari awal. Kemudian pembelajaran dengan peer group. Kemudian juga metode pembelajaran lain seperti flip classroom. Flip classroom ini sebenarnya bisa kita lakukan dengan sangat mudah, bisa dengan menggunakan video-video yang sudah kita buat, atau misalnya kita memberikan pengajaran, terus kemudian kita rekam, kemudian kita berikan dulu kepada mahasiswa, sehingga ketika kita sudah berada langsung di ruangan kelas, kita tinggal menanyakan kepada mahasiswa hal-hal apa saja yang belum dia mengerti, sehingga kesempatan untuk berdiskusi dengan mahasiswa menjadi lebih banyak dengan flip classroom ini. Jadi ini juga merupakan suatu metode yang dikatakan oleh para ahli sangat baik untuk menunjang perkuliahan yang interaktif. Jadi saya memberikan kuliah, saya rekam terlebih dahulu, kemudian saya share kepada mahasiswa, mahasiswa disuruh mempelajari, kemudian pada saat saya berada di ruang kelas, saya tinggal menanyakan kepada mahasiswa apa-apa saja yang belum mereka ketahui atau apa-apa saja yang mereka ingin diskusikan pada saat itu. Nah, metode-metode pembelajaran yang disampaikan ini tentu saja dapat meningkatkan clinical reasoning, kemudian berpikir kritisnya seorang mahasiswa sebagaimana yang kita harapkan pada metode pembelajaran problem based learning. Dan tentu saja lebih bisa melakukan manajemen terhadap waktu. Seperti dengan flip classroom tadi, ataupun dengan memutarkan video terlebih dahulu kepada mahasiswa ketika keterampilan klinik, tentu saja kita akan sangat banyak bisa memanajemen waktu, dan hal-hal lain yang lebih krusial akan dapat kita diskusikan pada saat sudah berada di ruangan kelas. Slide selanjutnya. Ya, mungkin itu beberapa hal yang ingin saya sampaikan, mungkin tidak banyak slide ini, tapi mudah-mudahan dapat memotivasi kita untuk lebih melakukan inovasi dan mengupdate terkait dengan metode-metode pembelajaran di bidang kesehatan, karena bagaimanapun tentu saja kesehatan suatu bidang ilmu yang membutuhkan pencapaian aspek knowledge, skill, dan attitude yang saling berkaitan, sehingga diharapkan memang pelayanan kepada masyarakat, kepada pasien akan lebih baik lagi. Mungkin itu yang dapat saya sampaikan. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Baik, terima kasih banyak Ibu. Luar biasa sekali menambah wawasan kita tentang update dari bagaimana metode-metode pembelajaran yang ada di pendidikan kesehatan. Baik, Ibu-Ibu peserta, silakan jika ada pertanyaan, langsung menuliskan pada kolom chat ataupun boleh raise hand langsung. Silakan Ibu-Ibu. Ya, ada pertanyaan dari Ibu Dina. Silakan Bu Dina.
Oke, baik, terima kasih Ibu Heni. Izin bertanya kepada Ibu terkait dengan pemaparan yang Ibu sampaikan tadi. Perkenalkan Bu Dina dari Prodi Kebidanan. Ada hal menarik tadi yang Ibu sampaikan di bagian ada beberapa metode yang inovatif selain dari penggunaan YouTube, ada simulasi, juga penggunaan sebentar ya. Penggunaan YouTube, simulasi, penggunaan smart mobile, dan juga ada feedback dari pasien. Yang ingin Dina tanyakan di sini, Bu, sekiranya inovasi ini bisa kita terapkan, mungkin seperti penggunaan smart mobile ini, seperti apa gambaran mekanisme yang bisa kita terapkan, dan kemudian Bu, untuk feedback dari pasien ini, apakah ini bisa kita implementasikan di tahap profesi, atau bisa kita implementasikan pada mahasiswa yang sarjana yang sedang berlangsung saat ini, yang kita jalankan itu ada MBKM gitu. Mohon masukan dan penjelasan dari Ibu. Terima kasih Bu Heni.
Terima kasih Bu Dina. Silahkan Ibu.
Baik, terima kasih Ibu Dina, pertanyaannya sangat baik sekali. Nah, saya jawab yang terakhir dulu ya, tadi terkait dengan apa tadi feedback dari mahasiswa ya. Yang kita dapatkan sejauh ini memang feedback ini ketika mahasiswa melakukan bedside teaching kepada pasien langsung, baik itu mahasiswa dalam tahap kegiatan di sebelum masuk ke rumah sakit atau preklinik ataupun sudah berada di rumah sakit. Karena tentu saja kita perlu mendapat gambaran bagaimana sebenarnya, terutama yang diharapkan di sini adalah bagaimana mahasiswa berempati kepada pasien. Kemudian juga apakah sudah melakukan komunikasi efektif dengan pasien. Tapi yang ditanyakan apakah juga bisa dilakukan pada mahasiswa yang yang sarjana ya. Saya rasa bisa saja sebenarnya ya. Karena ketika kita melakukan skills lab sebenarnya ada pasien simulasi, baik itu adalah sesama teman atau memang benar-benar pasiennya yang kita ambil. Ada di beberapa skills lab kita menggunakan orang tua bayi misalnya ya, atau memang menggunakan pasien-pasien tertentu. Jadi bisa saja kita sebenarnya melakukan baik pada tahap sarjana maupun pada tahap sudah berada di profesi. Mungkin itu jawaban saya terkait dengan feedback dari pasien ya. Jadi bisa saja dilakukan sebenarnya pada tahap pendidikan sarjana maupun tahap klinik. Yang dilakukan sejauh ini memang lebih banyak pada tahap klinik untuk meminta feedback dari pasien. Kemudian tadi terkait dengan penggunaan smartphone ya. Saya sendiri sebenarnya belum pernah juga menggunakan hal seperti ini dalam melakukan sharing keilmuan dengan smartphone berbasis jejaring sosial ini. Tetapi dari beberapa penelitian ataupun artikel terkait dengan hal ini, yang seperti sudah dijelaskan tadi, jadi kita sudah memiliki jejaring sosial dengan beberapa kolega di luar negeri, dan terutama pada tempat-tempat yang memang sudah melakukan kerjasama biasanya dengan kita, kita bentuk suatu jejaring sosial, dan di sana kita melakukan penelitian bersama, biasanya seperti itu yang dilakukan. Atau juga bisa kita sharing terkait dengan metode-metode yang memang dilakukan di suatu tempat. Nah, bisa juga seperti itu. Tapi sejauh ini sering melalui jejaring sosial ini adalah melakukan penelitian bersama, kemudian dari penelitian bersama itu kita aplikasikan untuk bahan ajar misalnya, seperti itu. Jadi lebih ke ini biasanya ya, peer group, membentuk jejaring sosial peer group. Atau melalui organisasi profesi misalnya, bisa juga seperti itu ya. Melalui organisasi profesi bisa dibentuk jejaring atau peer group, dan melalui jejaring sosial kita melakukan FGD. Mungkin seperti itu jawaban saya, Ibu Dina.
Ya, terima kasih. Ya, gimana Bu Dina?
Terima kasih banyak, Bu. Tapi barangkali yang terkait dengan smart device tadi, Bu, bisa saja kira-kira mahasiswa secara mandiri membuat grup-grup seperti itu, apa kita sebagai dosen yang memfasilitasi seperti itu, Bu? Maka
sebaiknya kita yang memfasilitasi. Jadi artinya memang peer group itu adalah peer group yang tentu saja yang bertanggung jawab ya Bu Dina ya. Jadi saya sampaikan tadi misalnya melalui organisasi profesi misalnya. Tadi di organisasi profesi itu kita buatlah peer group, dan dari situlah kita melakukan diskusi.
Baik, terima kasih banyak Ibu informasinya, Bu.
Terima kasih Bu Dina. Baik, selanjutnya Ibu-ibu peserta, silahkan untuk jika ada masih pertanyaan, silahkan menuliskan di kolom chat ataupun boleh raise hand. Ya, kita masih ada waktu sekitar 7 menit lagi. Dipersilahkan kepada ibu-ibu peserta.
Oh ya, saya tambahkan sedikit, sebenarnya penggunaan smart mobile device ini bisa juga sebenarnya melalui organisasi mahasiswa ya. Pengalaman saya itu di TIMSA, mereka kan memiliki organisasi secara internasional ya, dan itu juga bisa dibuat jejaring sosial, dan melalui jejaring sosial itu mereka melakukan FGD, bisa juga seperti itu.
Baik, terima kasih Ibu. Dipersilakan kepada ibu-ibu peserta jika masih ada pertanyaan. Silakan boleh langsung raise hand ataupun menuliskan di kolom chat ibu-ibu. Baik, Ibu, sepertinya tidak ada pertanyaan lagi untuk diskusi. Mungkin kita bisa akhiri sesi diskusi kali ini, Ibu peserta. Terima kasih banyak kepada Ibu Dr. Efrida yang sudah berkesempatan memberikan topik materi pada acara kegiatan ACM kita pada tahun ini. Terima kasih banyak, Ibu.
Ya, sama-sama terima kasih. Mudah-mudahan kita dapat selalu melakukan inovasi terkait dengan pembelajarannya.
Baik, amin ya rabbal alamin. Baiklah, saya coba merangkum sedikit tentang diskusi pada sesi 6 pada pagi hari ini, bahwasanya ada 4 teaching method inovatif yang bisa kita laksanakan pada pendidikan kesehatan, yaitu penggunaan YouTube, kemudian simulasi, kemudian juga menggunakan smart mobile device, dan juga feedback dari pasien dengan menggunakan kuesioner untuk mendapatkan refleksi diri. Baik, Ibu, saya mohon maaf apabila ada kekurangan kesalahan selaku memoderatori sesi pada siang hari ini. Wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Makasih, Bu.
Makasih ya, sama-sama.
Izin Ibu, mungkin kita sesi foto bersama untuk sesi siang hari ini, Bu. Boleh Ibu-Ibu peserta untuk jika bisa untuk mengaktifkan kamera videonya, karena kita sesaat lagi akan melakukan sesi foto bersama dengan Ibu narasumber kita. Baik, Ibu-Ibu. 1, 2, 3. Sekali lagi. 1, 2, 3. Baik, terima kasih banyak Ibu-Ibu peserta dan juga Ibu narasumber. Akhir kata, wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
Warahmatullahi wabarakatuh.
Dikembalikan kepada Miss Hani.
Okay, thank you very much, Bu Heni, for the help leading our session today, and also excellent speaker in the 6th presentation today. Thank you very much for the very enlightenment presentation from Dr. Afrida. And thank you for the loyal participants which are still here with us, because it will be more exciting with the greater speaker ahead. Now we will move and begin the next topic of our conference today. The keynote speaker for this session is Camilla Gerhard Nielsen from Southern Hospital, Denmark, with the topic of maternity service in Denmark, Hospital of Southern Denmark, promoting normality from pregnancy to postpartum period. Now, before we get into the next agenda, let me introduce our moderator that will lead our discussion today. So this session will be moderated by Dr. Anissa Anzar Aprilianti. But before we begin, I would like to give a brief explanation about Dr. Anissa background. Okay. Okay. Dr. Anissa Anzar Aprilianti. She studied her doctor profession in Trisakti University Jakarta and finished her profession in 2017. Right now, she is a resident of obstetric gynecology in RSUPM Jamil Padang, Andalas University. And if we can see here, the employment history of her is actually started in 2017 until 2022, and she's internship in Bangli General Hospital, and then in 2018 she is also a doctor in charge in Anissa Medical Clinic, Cilegon, Banten. In 2021. She is also a company doctor of Lotte Chemical Titan Nusantara, Cilegon, Banten. There's few of courses that she already gained, like in COVID-19 vaccinator training by Ministry of Health in 2020, and the normal childcare by JNPK-KR 2021, comprehensive emergency neonatal obstetric service in 2021, contraception technical update in Padang 2021, and recently is basic surgical skill 1 obstetric gynecology collegium in Pekanbaru 2022. She was also a volunteer vaccinator for USAID EPIC COVID-19 project in 2021. And her publication is about relationship between parity, age, and history of cesarean section with placenta previa in 2015. She is also an Asian Medical Student Association from 2013 until 2015, and also Indonesia Medical Association till now. Okay, without any further ado, I think we should greet our lovely moderator right now. Hello, Dr. Anissa.
Hello, Miss. Thank you so much
Hello.
for letting me join in this conference. Thank you for the brief explanation about my city. Thank you very much. Right now,
Okay.
okay. So can you hear my voice clearly?
Yes, absolutely.
Okay, thank you. All right, maybe now it's time to welcome our speaker. Does Miss Camila is here already? Okay. Good afternoon, Mrs. Camila. Thank you so much for joining us today. How are you today, Miss?
I'm good, thank you. Thank you for inviting me.
Okay. What time is it right now in Denmark, Miss?
It's 8:30 in the morning, so good time.
8:30. Okay, it's still in the morning. All right. Now it's around 1:30 p.m. here in Padang. Okay, let me introduce our participants about the CV of yours, Miss. So this is the CV of our lovely speaker. The full name of our speaker is Camilla Gerhard Nielsen, and now she is an obstetric consultant in Akranes, Iceland, and CEO of Obstetricwise. The employment history of her is very remarkable. She's starting in 2003, and now she is still working in hospital of Akranes, Iceland. And for education approval, she is graduated from University of Aarhus, Denmark in 2002, and then a specialization of gynecology and obstetrics completion in May 2014 in Denmark. She's also a psychotherapist in taking psychotherapist education in 2007 until 2011 in Denmark. She's also teaching so many courses, starting in upright breech birth, holding seminars for doctors and midwives in 12 delivery units in Denmark. And then she is keep continuing her teaching works, and her projects is also remarkable. There's so many projects she's involving from 2010 until now. And for the courses and conference, she's also dedicated her work in neonatal resuscitation in 2008, and then active management of labor in 2008 in Dublin, and also endometriosis in 2008. She's also having so many publications, starting from with Mr. KG Nielsen, or Miss KG Nielsen, and AB Barford, and Miss and M. Gerhard, and also so many publications. Okay. And she's now is also a member and co-founder of Danish Society of Psychosomatic Gynecology and Obstetrics since 2012 21, and also member of MUK Medical Education since 2018. So here is a brief introduction for our lovely speaker, Ms. Camilla Gerhard Nielsen. So maybe right now we can start our seminars today, Miss. Is that okay? Is there anything else you want to add?
I will say a little bit more.
Okay.
But for now, I'll just start sharing my screen, if that's okay.
Yeah, sure. All right.
Thank you much for the lovely introduction.
Thank you, Miss
You're
Camilla.
welcome. Yes. So I would like to thank you for this opportunity to talk to you today. And it's always a lovely opportunity to look at your own maternity service from the outside and go through it and think, what are we actually doing? Because this is, of course, everyday life for me. And the pictures I put in my presentation, I always enjoy that very much because it gives a good counteract to the whole having to think a lot. So the pictures I put in today's presentations are all from Denmark, which is a very entirely different country from Indonesia. I've not yet been to Indonesia, but I've heard a lot about it. My husband traveled there in the 80s and is, of course, very excited about it. So we're hoping to go there someday.
Yes.
So what I'm going to talk to you about today is maternity services in Denmark. And also I'm going to talk about a department that has a vision and positive teamwork between doctors and midwives. My name is Camilla Gerhard Nielsen. I'm was presented an obstetric consultant, but I'm also a psychotherapist. And I'm educated in Denmark and worked most of my life in Denmark. But currently I have a year in Iceland and I enjoy very much going to different countries, working for a year or 6 months. I work in New Zealand also for a year. And I like this, adding this perspective to the job that I do. And it's the best way to see and experience a new culture is actually working there. Because I travel so much and teach so much, I had to make a company, which is what you can see here, the Obstetric-wise. And I teach doctors and midwives around the world. And my aim with that is to minimize unnecessary obstetric interventions. That's what I really, that's very near to my heart. So where is Denmark actually? It's here at the top of Europe, bottom of Scandinavia, and it's a very small country compared to you, only 5 million people. It has 60,000 births per year and 21 birthing units. And the one with the red circle in the bottom, that's the department I'm going to be telling you about. So this means a very small country, 21 birthing units, maximum 1.5 hours transportation to any birthing units. There's also 3.5% home births. The conditions there is that the emergency cesarean section is always possible because always there's a specialist on call at the hospital. The emergency staff and the surgical room is already ready for cesarean section. And this is different from where I'm working currently in Iceland, where we have to call in the team. And I'm also at home. I'm very close to the hospital, but it makes things decidedly different. So in Denmark, if you press the button, you can do a first-degree cesarean section within 15 minutes, or actually 7 minutes we've tried, and second degree within 30 minutes. So the first one is if the baby is close to dying, like total abruption or rupture of the uterus. But the second degree is if you're having threatening asphyxia. The national cesarean section rate is 19%, and we have national guidelines on most obstetric topics because we have an annual obstetric meeting where we try to look at the current evidence and the newest evidence and the old evidence, and then we try to agree, which is not always completely easy, but we do manage most of the time. One thing that's also quite different, I feel, from other countries in the world is that if you have a complaint for as a birth or something like that, or at the hospital, then you don't cover for it yourself. You can never be sued as a doctor or a midwife. It goes through the Danish Agency for Patient Complaints and the Danish Patient Compensation. So that means that you're not economically responsible, and neither is the hospital, but it's a common assignment, which also means that you're not as worried as I was, for instance, in New Zealand, where you had a little bit of the same, but you could still be prosecuted as a single person. I feel this makes me take better decisions, that I'm not worried about my complaints. And a little bit of background, because I feel our countries are so different, is I'll tell you that our country is, I like to call it a social democratic country, which means it's not a socialist country. It's more, but it has some socialistic tendencies, like we only have public health care, which means that you never pay when you go to a doctor or a hospital. That means also there's no economic interest of the healthcare staff. Which makes it quite different from many other countries where it's a mix of public and private. Also in Iceland, I get money from every patient I meet, and that feels very odd. And it makes some doctors in some countries see people more than they actually have to. And I really like this way that in Denmark, we only see what's necessary, what has what can I say, that has a meaning, that it has to have some sort of consequence. Otherwise, we shouldn't make an examination. And I feel that in some other countries, then people make examinations just because, we can, or we are concerned, but to make it only when it's deeply necessary, I feel that makes good sense to me. So also we have public welfare, unemployment support. So you never have to be scared that you have to leave your house or you don't have anywhere to stay, because you'll always be supported by the government, which is in fact, of course, our high taxes. So from my salary, I pay 52%. My husband pays 38%, depending on your income. It also means there's a little bit of Big Brother is watching you. I think some people would say that we have a social security number since birth, so we can all time be traced to what did you do then, where did you live, what was your income, what is your bank, stuff like that. But it also gives a high level of freedom, because then you can easily move between different places, different universities. All the time you have support, and I really, as you can hear, I really like it. Something that my husband always laughs at, because he's from Holland. He says, Denmark is one of the only two countries in the world that has a state church, which means, in fact, just that we pay part of our taxes to the church. Well, unless you unsubscribe, you can't say, well, I'm not a Christian, I don't want to pay to this. And there is freedom of religion, but just saying that, my husband says it's only Denmark and Iraq, I think, that has state churches. And he finds that a little bit funny, that Denmark, that sees itself as such a free country, has a state church. It also means that university, you don't pay for, don't pay for any education. And you also get funded when you're studying. Here you can see my son when he was 10 years old. He's now studying at university in Copenhagen, and it's for free, and he also gets paid from the government or from our taxes to support him through university, and he doesn't have to pay it back afterwards. It means that how do you then get into university? Then the grades decide it. So if you're really skilled, you can get into the the most difficult educations, and you of course have to have high grades to study medicine, but actually you have to have higher grades even to study midwifery, because there are so few midwifery places and it's such a popular study. So we have some really, really smart midwives in Denmark, I have to tell you. There are other ways to get into university. Like, I didn't realize I wanted to become a doctor, so I didn't really make an effort to get the best grade. But then you can get in by doing an interview or showing that you're doing something that is in that direction. Like, I was in Africa working at the time where I applied, and working at a children orphanage and stuff like that. And then you can also get in. But mainly it's the grade that gives you the right to enter. So, to the birth. A normal birth in Denmark is midwifery-led. It's one-on-one care. Well, you have two people at birth, so the midwife will call an assistant or maybe another midwife, but it means that there's no doctor present. So if you're a normal pregnancy and a normal birth, you never see a doctor during your whole pregnancy and birth. And this is something that we really value. And fortunately, it's also been shown in several research articles that midwifery-led birth gives lower intervention rate and the women feel better. Where in some countries, I don't actually know how it is in Indonesia, but I know from some countries that you have to call the doctor, so they will deliver the baby because that's what feels safest there. But I think that's part of actually our normalization in Denmark, is that normal birth is with midwifery-led. If there's a high-risk birth, like here we have the breech, the upright breech, then the birth will still be midwifery-led, but the team will be behind her. So if you look at this room here, then on the left you see the partner and the woman, and then you see the midwife coordinator with the gray hair, and the midwife with the blonde hair with the woman close to the woman. Then there's a nursing assistant in the corner. The junior doctor is recording, because that's what we do with all our upright breech births. And on the right-hand side is our obstetric consultant or gynecological consultant. So we try to still make the birth midwifery-led, because it's so important for the woman, this contact that she's had with the midwife during the birth. That's what makes her feel safe. And if we are a really good team, we can easily do anything we want. I can still, if I'm the one sitting in the corner, I can still say, how about could you possibly, what about moving? Did you guys see the CTG? And we prepare the women and say to them, we're going to be talking together, and we will also tell you what's going on, but we need time, we need each other. So two heads are better than one, we usually say. So in an emergency, so if we're going for a cesarean or a vacuum or something like that, then the doctor or the midwife coordinator is the team leader, and the midwife steps a little bit to the background as part of the team, but she will still be the one in main contact with the woman. Yeah, this is about Hans Christian Andersen. I don't know if you know him, but he's the world famous Danish fairy tale writer. And he wrote the adventure about the ugly duckling. And I just wanted to show you this, but in fact, that's not what I wanted. I just thought it was a really lovely picture. And also with the bicycle in the back. Denmark is a bicycle country, so we bicycle everywhere we can, from you're very little till you're very old. We now have electrical bicycles, so old people can also still bike. No. I wanted to say something to you about Danish midwifery education, and I don't actually know if it's completely the same as in Indonesia. Maybe I'm just going to bore you, but I hope that you will bear with me. I have a Danish midwifery assistant in my company that helps me with practical stuff, and I spoke to her about how is it actually with midwifery education. So the midwifery education is 3.5 years. You don't have to be a nurse before, as in Iceland, for instance, you have to be a nurse before you apply to become a midwife. You just have to have the very high grades to get in. And you do alternating 6 months school and 6 months practical. The first part, in the very beginning, you actually start with 14 days of observational clinic to find out if this is what you want, and where you can do stuff like measure blood pressure, but don't do vaginal exam, and you are accompanying a midwife. And actually, there's a dropout here. I was surprised by this high dropout, 10 to 20%. And my lovely midwifery student Maya, she said she thinks it's because of the change of schedule that people say, I wasn't prepared how hard it is to work at night also. And I think also some drop out because it's just overwhelming and not what they thought it was, probably. When they're at hospital, we divide them in red, yellow, and green, which means the first time they're out, they have a red badge. Second time, on the second year, they have a yellow badge. And the third year, when they're out, they have a green badge. So I also, as an obstetrician, I can't know all the midwifery students really well, but I can see their badge. Okay, this is somebody I need to team up with if she's green. But if she's red and yellow, I will still talk to her midwife, and then they can talk about it afterwards. In your education, you always come to the same department. So it means you come back every 6 months, you are in the department. The first year is mainly uncomplicated births. The second years, you participate also in emergency situations. The third year, you have independent births under supervision. And the 7th semester, you have a bachelor assignment. They also do quite a lot of simulation training. It means that they have birthing simulators like this one, the Prompt Flex, that I have used a lot for the upright breech, as you can see. But they use it also for vaginal exams, for breech, for shoulder dystocia, cephalic malpresentations like occiput posterior or forehead presentations. They also learn IM injections that way, and also do simulation training for postpartum bleeding. In all the Scandinavian countries, there is, however, a midwifery crisis. And I was asking Maya about why is that actually? And she said it's simply that the pay is not good. It's just good and not good enough for always being on call and having this huge responsibility. They have responsibility for life and death, and they don't have a doctor behind them. Well, they can always call a doctor, but we're not there. And then the working shift. And she said even a new midwife earns the same as a waiter. So I do understand that there is this big crisis. So it means that a lot of midwives, they decide not to work at the hospitals. And this is the same in Norway and Sweden also, and a little bit in Iceland, that they just do something else instead of this hard work that's not too well paid. But what I'm also seeing is that the working conditions highly matter. So the Hospital of Southern Denmark that I'm going to tell you about, they don't really have a recruitment problem because the working conditions are so good. The teamwork between doctors and midwives and the innovation and the belief in normal birth, I think it does something to the midwives. There was recently actually a big article in one of the newspapers about this department, how happy they are with their working conditions, but they still also want higher pay. But just saying that then the departments where there's not maybe the same respect for midwives, they have more difficulty recruiting, in my opinion. So briefly about the doctor education, we have 6.5 years in university with 12 weeks of practical period. So significantly less than the midwifery students, actually. Then after we finish university, we work 1 year as a candidate, and then we specialize. And to specialize, you need 1 year of introduction. And then you need to apply for 4 years of specialization. And that's actually where it can be really difficult to get into your specialization. I have to say, for me, it took 3 times, even though I had a few articles and a lot of teaching and a lot of seminars I've been at, then they didn't feel I was very clear focused going the right direction or the straight direction, because as you can see on my CV, I've been a lot of places, I've done a lot of things, I find everything so interesting, I just need to experience it. So that's mainly why it took me so long to get into specialization. But when you are in specialization, then it is organized with what workshops do you go on, what seminars, which department are you at? You're at a small hospital, you're at the university hospital where you're really busy, and you are also in the surgical department for 6 months. So that is something that I find is really a good organization of the doctor education in specialization in Denmark. And especially also the way that you're evaluated. So you have a lot of functions you need to fill out that you have done, and you need to show your progress and stuff like that. So it's not based on exams, it's based on clinical knowledge and know-how. And I feel that's very valuable. I feel the Danish doctors are very skilled clinically, but when I compared myself to some of my New Zealand colleagues, I felt that they theoretically were far better than I was. And it's, what type of doctor or what type of person you are, what you would prefer. And I prefer very much the clinical way. So maternity care in Denmark, it's based around vandrejournalen, it's called, and it's translated into the walking journal. So it's a communication between the general practitioner, the midwives, and sometimes the obstetricians. And as you can see a little bit of it, but in the left-hand corner, that's white here, the patient's name, then there's a doctor's name, general practitioner, then there's the expected due date from period, from ultrasound, and then you have the blood pressure, the weight, the estimated weight of the baby, and small comments. So this is something that the woman always keeps with her, and it's mainly in paper, but it's becoming more and more electronic. So you can access it anytime, anywhere. So when you have a positive pregnancy test, the first thing you do is that you visit your family doctor and you fill out this paper. They fill it out together, and then you refer to the local hospital. Then you have midwifery visits. You have 6 in all, aiming for the same midwife. It's not always possible. 30-minute consultations, more and longer visits if you have social problems, drug abuse, or previous loss of a child. After birth, it's something that there's not that much of in Denmark. You have 4 nursing visits in the first year, and you also see your general practitioner 1 time after 8 weeks. But if you do have problems like social problems, drug abuse, anything like that, then you have more visits. But in Iceland, they have 6 visits by the midwife already in the first short period of time. So it's significantly different in Denmark. Everybody's offered to go to the hospital for their first trimester nuchal scan. And this is something that's really quite remarkable about Denmark. And I don't know how I actually feel about it, is that, so if you find a high risk for Down syndrome, then 95% of women will have an abortion. And there is free abortion in Denmark until 12 weeks. And after that, you have to apply. And if there's a good reason, you can have that. But it's made before we had 100, I think actually 200 children with Down syndrome per year, and now it's down to 10 per year. So it's quite an eradication of this. But this is something that's been decided that's an offer. Then you can have a second trimester scan for placenta and for malformations. The only patients that see an obstetrician are the risk patients, like high BMI, high blood pressure, previous IUGR, twins, gastric bypass surgery, but also if you have a depression or social problem, because if with social problems, we have we're obliged to say this to the government. So if we feel that somebody has not a stable social situation, we will say this to the government, the community, and they will make an interview with the couple and visit them in their home and see, are these people, do we deem them adequate to be parents? And this is, of course, a very rare thing. And when we say it to the patients, we say, so I have to say this to the community, that you smoked hashes for 10 years up till your pregnancy, and that's probably not going to be a problem, but for some it will be. Some will have problems finding their own feet after that. So that's why we're offering you to have an evaluation from the community. And it doesn't mean that they're going to take your baby away, but it does mean for some, if you have a current drug abuse, maybe not marijuana, but if they are using heroin or something like that, then the community has the right to take the baby away. Yeah. So we also see women with previous cesarean or traumatic birth experience, and that's what I do a lot in my consultation in Denmark. I talk a lot about that, and I'll get back to that a little bit later. The cesarean section rate in Denmark has been rising. Fortunately, now it's been stable for some years, around 20%. But as you can see, from 1996, it was 12%, and now it's 20%. So something happened here. And I looked at it worldwide. Why is there this why is there this increase in the world? And it's partly because of CTG monitoring. It's been shown that if you listen intermittently, you have a lower intervention rate than if you do CTG. But in my belief, CTG is probably also reducing the amount of cerebral palsy, but it's has been difficult to show this. I know that some don't agree with me on that, but that's my opinion. Then there was a term breech trial who took out basically all the breech birth. Nobody gave breech birth for a while. Now we're trying to get back to that. I'm traveling around the country teaching breech in a new way that seems maybe safer. Then there was the VBAC decline, that vaginal birth after cesarean, that less and less of those gave birth. And when you look at it worldwide, it was mainly about litigations, the fear of being sued. And the physician, if you look at the private practice, there's a way higher cesarean section rate than if you are in the public. So was there actually an economical indicament to do a cesarean because you get paid more? That's what some of the articles I read would say. In Denmark, I think it was mainly because of maternal request, that if you were worried about childbirth, it now came a tradition to say, well, it's really important women can decide, so you can decide vaginal birth or cesarean section. It's free for you to decide. And I'll get back to that a little bit more. And I do know that the cesarean section rate rise is not a problem all over the world. Actually, there are countries in the world where the cesarean section rate is possibly too low to save the adequate amount of children. This is what it looks like. I don't know if this is actually true for Indonesia, that you have a cesarean section rate between 8 and 10%. But I know that it's correct for Denmark, that we have the cesarean section rate of 20 to 21, and Iceland has a cesarean section rate. This is Iceland up in the corner here. That's where I'm currently living, of 16, 17%. So it's really different all over the world. And I realize not everybody is where they need to reduce the cesarean section rate, but I think everybody needs to hear about normalizing birth and intervention. So what WHO has looked at is the association between maternal and newborn mortality rate and the cesarean section rate. And they say that if you have a cesarean section rate higher than 10%, it didn't necessarily associate with reductions in maternal and newborn mortality rates. But what they say is that cesarean section needs to be undertaken when it's medically necessary and there is no specific correct rate. You should rather focus on providing cesarean section to all women in need. And what they've also said is that probably a cesarean section rate between 10 and 15% is probably where you can keep a low mortality rate for children, but also a low asphyxia rate for babies. So in Western countries, it doesn't really make sense to look at neonatal mortality rate anymore because it's extremely low. What we'd rather look at is the cerebral palsy risk. That's what we need to keep down, of course. So this department that I'm talking about, Hospital of Southern Denmark, where we aim in every way to reduce unnecessary interventions. It has 1,650 births annually, and on call is a 24-hour midwife coordinator, 2 to 3 midwives and 1 assistant, and 1 obstetric or gynecological specialist with 1 junior doctor. And why I say obstetric and gynecological specialist is because in Denmark, we specialize during daytime in one or the other. So I'm an obstetrician in the daytime. I see pregnant women, speak of fear of childbirth, and my gynecological colleague makes surgery, for instance, and have outpatient clinic. But in the evening and night shift, we're all on call for exactly the same. So we really try to train our gynecological colleagues as well as the obstetricians. In this department, our teamwork is central between the doctors and midwives. And that's something I'm going to talk a little bit more about, because the more I talk about it and the more I experience in the world, the more I see that that's actually the essence of everything. But also in this department, there's a common strong wish to promote vaginal birth. And then it's also a department that's really innovative and easy to change. And that's actually why I came to this department 7 years ago. I was working in New Zealand and wanting to go back to Denmark, and I called delivery suites around Denmark, and I saw what are your goals, and do you have a job for me? And plenty of jobs, but not so many with goals that matched mine. But here I've been allowed to implement a lot of things, really good and sensible things that we all agree on, and it makes us also proud of our goals and our results, as you can probably hear. So what happened in this department was that around 2008, it was a department on the brink of disaster. There was no recruitment, no doctors. And what you see here, the blue line is cesarean section rate for Denmark. The red line is the overall cesarean section rate for Hospital of Southern Jutland. And what we managed was to reduce the overall cesarean section rate down to 13%. From the 20 it was in 2008, sorry. And the main difference was on the elective cesarean section. That's the blue line, where we reduced it from 8 till 3%, and it's still the 3%. And the top line, the red one, is the emergency cesarean section rate at the same place. And it's so few. So the line is, of course, a little bit up and down. And the yellow, the green and the purple one is the national emergency and elective cesarean section rate, which didn't change significantly during those years. So what I was saying was that we feel vaginal birth is really valuable if you can have a safe birth, good birthing experience, and at your own terms. We feel that vaginal birth is better than cesarean section. And you could, of course, talk about the long-term risk after you have a cesarean. There's a higher risk that the next baby is going to die in the uterus. There's a higher risk of placental malformation. There's a higher risk of having long-term pain. But what I feel is really not talked very much about is how is it when you have a very positive birth experience, the potential of the vaginal birth. And when this is a focus group interview with 30 Swedish women that all had a very positive birth experience, and women that saw themselves as willing to run their own lives and take a responsibility in their birth and what their expressions were after. This is something that I really feel is just, I love reading these expressions. They felt their birth was amazing, wonderful, magical, incredible, unbelievable, overwhelming also. And they said it was a life-altering moment. They thought it was engaging. They felt safe and secure. They felt close to the earth, happiness through a special voyage, in flow, proud, grateful, relief, and positive toward the next birth. And this is something I rarely hear after an elective cesarean section. This is something I feel is not spoken very much about. And I would like that to be part of the evaluation when you say, well, vaginal birth and cesarean section are equal, but they're not, in my opinion. They're maybe for the baby, they're equal risk, for the mother, more or less equal risk. But this is something that has a really huge potential that I think we need to address. So in this department, we took some steps, and I will go through the steps one by one. So the midwife coordinators is a midwife that has the same education, but then will be more and more specialized. She will be 24-hour on call, which means she'll have an overview of all the births going on. She will know the guidelines really well. She will know all procedures really well, and she will know practical stuff. Oh yeah, now we have a new GPS machine. I know how to work it, because she'll rarely be in a birth, except if there are just lack of hands. She will also be in a birth, but she will also be present at all emergency situations, which means that she has a lot of experience. And these women are a team of 6. It means that it's a really close group. And very, very central in this whole teamwork, that I feel that the teamwork between doctors and midwives is that the midwives are experts on normal birth, doctors are experts on pathological birth, and by sharing this knowledge, we are a great team. But so what I want to go away from is that the midwife have the normal birth, and then if you want a cesarean section or a vacuum, you call the doctor, and then they do that. What we have tried to do is that when you have a problem, you call the doctor, and then you work together about it, and you always respect each other. So you can't, as a doctor, come in and say, well, I decide, so blah, 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 blah. No, when you're in the situation, you decide together. It's your responsibility together. And I do know that if you have a complaint, then it will be the doctor's fault if the doctor is there. But in this situation, it's your responsibility together. So in the delivery suite, the teamwork is between these groups here. The midwife knows the birth. The midwife coordinator has the overview, has been there several shifts on the back, on the outside. The woman knows how she's feeling, and the doctor can put all these things together and sum up a plan. So that's why I always try to promote respectful communication in the room. Always start by asking the woman, how is she feeling? Because it's very central for me understanding the birth and making good decisions, but also respecting the couple. So when I take a decision, I always hear the team before I decide anything. And it can be really quick. It can be like, I don't see any other options than a cesarean. Do you have any ideas? No. Okay. Or it can be, can we look at the CTG together? I'm wondering, do we have any options? And a longer talk. And my Icelandic midwives were asking me, so how do you do that in the room? And I say, well, I keep it quite openly for the couple. I say, it's good for us to discuss this. We are not seriously worried, then we would just do a cesarean section, but we are thinking, what are our options? And then we'll tell you what are the options, and are you happy with these options? So a timeout we have invented, and we use that if the midwife has questions, like a progression, then she'll call the team, or maybe the midwife coordinator, and maybe she will call the doctor, and we'll look at why do we have a lack of progression? Is it perhaps an occiput posterior, or what is going on? Is the woman exhausted, or if she has questions about the CTG, then the team will go together. And because the discussion we have around it is really valuable. I feel now that I'm in Iceland where the teamwork is not as strong, that I stand alone with these decisions, and it's completely different in my head how I have to react from when I had a team around me where we were discussing together, all professionals together. We also took in the time out for the couple if they have questions or are afraid or overwhelmed, and especially for the ones with birth plans where they have fear of childbirth, we say, but always use your time out. Say, listen, I am in so much pain and exhausted, and it's like the last time that was traumatic. And then we'll come in the team and say, okay, you're in so much pain. Your epidural is not working. How about if we get the epidural done again and then we talk? Would that be okay with you? Okay. And then it works, and then we can talk. So you are now 4 centimeters. You were 2 centimeters a few hours ago, or however we are, wherever we are in the birth. And then we can make suggestions, and she has to, or they have to accept it and be happy about it. Otherwise, it's not going to work the rest of the birth. This is a picture of our teamwork when we have a breech delivery. We always do a timeout outside the room where we divide our roles. And again, as you can see, here's the specialist, the junior doctor, the midwife coordinator, the assistant, and the midwife. We are the team, and we have to decide. So who is going to do interventions? If there are any intervention in this breech birth, who's going to tell us when the 5 minutes start? Because we have 5 minutes from buttocks till head in the upright breech birth. And then we go inside and we tell the woman, we're just outside in the hallway because we need to divide our roles. And we go inside the delivery room and we tell the woman, so this is what's going to happen. We are going to be your team today when you have your birth. And we always try to be quiet and respectful in the room. So when we talk together, that we do it in a calm manner. But we also tell her, we would like you to be upright for the last 5 minutes when you push out the baby, the body, but we want you to be able to really fast come on your back and up in stirrups if we need to do anything. So another segment of our good department and our reduction in intervention and the good working conditions is the morning conference, actually, and it starts 8 a.m. sharp. So if you're 1 minute late, you might miss some of it. And the head of the department leads. All the doctors are there, midwife coordinator, nurse coordinator, midwifery leader, and sometimes some of the midwives, but they don't always have time. They always also have another morning conference. It's a very strict structure. Within 10 minutes, the nurse coordinator says, what is the assignment of the day for each doctor? The doctors on call do a handover and plan only for inpatients and only for something that needs to be said. So it's not allowed to make stories about, yes, we did 3 cesarean sections, and yeah, I was also very tired with it, and the husband said, and blah, 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 blah. The stories, we don't do that. It's only what's really necessary for the next team to do their job. Then we hear from the gynecological departments about inpatients that were not mentioned really briefly. The postnatal ward also really briefly. Who do we need to see on a ward round? The secretary gives also brief messages. And then the delivery unit will give us a status of what's going on in the birthing suites. In room 1, we have Amelia. It's her first baby. She is 39 plus 6. She is spontaneous onset of labor. She's now 6 centimeters. She has an epidural and it's not really progressing. In room 2, we have blah, 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 blah. And then we'll talk through all the birth, but really short and thorough. And this is the midwife coordinator who does that. In my opinion, it's really valuable because she's so structured compared to the random doctor that might be more, well, a little bit more fluffy in the handover. That means that when this is done within 10 minutes and sometimes 4, 5, 7 minutes, then we have at least 20 minutes to go through what interventions did we have the last 24 hours. And the midwife coordinator makes a summary. It can be a cesarean, it can be a postpartum hemorrhage, a vacuum, ventuse, CTG, a manual rotation, breech deliveries where we see films or do reconstructions. And then the assessment is done with a learning focus, not blaming. So the midwife coordinator decides which case should we look at today and relays the case punctual and structured. And the doctors from the shift can comment if necessary. The obstetric specialist leads the evaluation of the CTG, gives informal final statement. And this is all done with learning purposes. And sometimes we will see a film like this, but since you're recording this, I'm not going to be showing you the film, unfortunately, because what we were allowed to record our upright breech births, and we keep them in a secret place. So I'm allowed to use them for teaching purposes, but not really share them with anybody. But this could be something that we would see a breech birth, and then there would be an evaluation. Oh, maybe you diagnosed this maneuver wrong, or you did it right, but we always try to, I'll get back to that. So a discussion could also be from the physiological CTG concept. When did the infant become affected? Could something have been done prior to the pushing? Could we have maybe pushed every second time, given Bricanyl? Or should it actually have been a cesarean section? But what's really important is that we always do it with respect. We do know that the day after you have the clever hindsight. So it's important that you don't blame anyone. Because the on-call team had the final decision. And I have to say that recently I had my first case where I thought I probably made a mistake. I misevaluated the situation. And this is first time in my career. And I had to go to a morning conference and say, this is what I see when I look at the day after. I should probably have done this or that. And the response from my colleagues was really heartwarming because I was feeling bad about making possibly wrong decision. And they were saying, but we do know that you did the best you could in that situation. And thank you for giving us this opportunity to see what you did so we can all learn from this next time. And I must say, it's the first time I've been on the other side myself. And it just relieved me so much to be sharing this in the team that we carried this together. And by sharing this is also giving a gift that we are allowed to look at these cases. And I'm saying, I possibly should have done something else. I made a mistake, I feel. That is really a gift. And it's the most valuable way to learn because it's real life cases and nobody is feeling bad about it or should not be feeling bad about it. What we also do at the morning conference is we do consensus decisions, so the wisest possible decisions and no personal responsibility. So if somebody wants an induction for no medical reason, then you can say, I will take it up with my colleagues and we'll decide together, instead of saying, well, I will say yes or I will say no. We, of course, team training of emergencies, gynecologists, as well as obstetricians. We have this new implementation, the upright breech birth, and then we have repeated training on that to make sure it's well implemented. We monitor our numbers. So these are the years and the percentages, how many births, how many first-time mothers, who had these different BMIs, who had cesarean sections, emergency, breech. So this makes this we can evaluate this every year and see, okay, we are rising a little bit in the 3rd-degree tears. We need to do something about that. We also have postnatal consultations, all women with a midwife, where she looks at the tears, she talks about the birth, and if she seems unhappy in any way, she gets a follow-up, a postnatal consultation. And if after any large intervention, so like after postpartum hemorrhage or cesarean section, the doctor needs to go and see the woman before she leaves the hospital to say, why did we actually do this cesarean section? Because some women will come after 3 years and say, gosh, my baby almost died during birth. And when you look at the CTG, the baby was nowhere near dying. It was maybe a little bit stressed and there was lack of progression. But it feels so sad that couples have thought their baby almost died during birth. So we go in when they're straight in then when they have come out after sedation or pain, and then talk to them about why did it actually happen. And we always recommend a vaginal birth next time, unless if it was cause a rupture of the uterus or something like that. But mainly we say, so next time we recommend a vaginal birth. We are also very proactive with, these are just a few examples that I could find of articles that we put out in the local community. So we give information to the community that we value vaginal birth and that we would always recommend it if there's no contraindication. We have meetings with the general practitioners saying this. So now when we get a referral from a general practitioner, it will be more like, this woman needs a birth plan, where in the 5 years ago, it would be, this woman wants a cesarean section. So it's really good that the local community knows this, that's what we value. And I think this is part of why it's not so difficult anymore. We really also value our outpatient clinic for fear of childbirth, which is a mix of the obstetrics and the therapeutic counseling. And I feel that makes it valuable, where in Iceland, you can see a psychologist, but I feel if it's something related to birth, the psychologist will lack the knowledge of the birth in itself. I feel that the obstetric knowledge is really important. We are a team, 3 midwives and 2 obstetricians. We meet 4 times a year where we talk about how is it going? How is this case? Could we do something differently? So a few years back, we realized that sometimes we were too late in recommending the vaginal birth because we saw the women with previous cesarean, we saw them in 2nd trimester. So we changed it to the 1st trimester. And we feel it made it really very different to see her at 13 weeks and say, we recommend vaginal birth. We would like to offer you to work on that. So stuff like that. The 4 meetings are really valuable. And 2 of those times we'll have a supervision by a psychologist for difficult cases, because we're not psychologists. I'm a psychotherapist, but the rest of the team is not. And it just, So we actually, based on this, we had a national day on fear of childbirth where we outlined everything we do in our birth plan team. And it was an amazing day with that really good feedback. So this is something I also travel around doing, days on fear of childbirth. The birth plans, as I said, we do them in 1st trimester for fear of childbirth in first-time mothers, which we don't have very many of, or from previous traumatic birth. And what's really important is that these birth plans that are really specific, that they are supported by everybody. So when I sit in my consultation and say, you will always be invited in if you need to come, then it's important that she's not met on the phone. Well, you could also stay at home. I don't think you need to come in. So everything is supported by everybody. And we, of course, evaluate if these birth plans were realistic. I mean, did I decide something that was completely unrealistic for the team that was there giving birth with her? But it's working really well, I feel. In the birth plan clinic in itself, it's really important that we recognize that everything the couple is telling us, it's true for them. their story is completely true, and together we'll take care of this. This is something I really promised them. And that's the best start for any consultation, I feel. And then we try to be as specific as possible. The story they come with, go into details. Why are they scared and what exactly are they scared of? And look at the birth plan for next birth. I don't really have time to go into this today, even though I could talk, as you hear, a whole day about this as well. Because I have to finish almost. But this was a little overview of how we try to keep birth natural. And what I do in this company that I had to make because I'm traveling around is that I give workshops and lectures on reducing interventions on upright breech birth, fear of childbirth, and occiput posterior and obstructed labor like intrapartum ultrasound and rebozo, and also obstetric emergencies in home birth. I love home birth. I gave birth at home to my own children. And I feel it's a really good place to be if you have a skilled midwife and a good transfer and the correct visitation. So all in all, I aim to reduce unnecessary interventions. So this is just a little advertisement for my webpage if anybody wants to see this. So thank you so much for your time. I realize this is a lot of information and a lot of stuff you already know. But I will just hear if there are any questions or comments, and I think I will probably stop sharing the screen so we can all see each other.
Okay, Ms. Camila, thank you so much for your wonderful explanation about the healthcare system in Denmark. So as I follow the presentation, I realized there's many differences between healthcare systems in Indonesia and in Denmark. So there's so many issues we should discuss about that. But maybe right now we can start about the question, Ms. Camila, from the audiences. Okay. Yeah. There are some questions, and first question is come from Ms. Mawan Frisanti from HK Women Hospital. To Ms. Camila, what is the role of the midwives that working in hospital to educate? Can you hear me clearly?
Yeah, I'm just going to turn up the volume a little bit. Yeah.
Okay, sorry. What is the role of the midwives that work in hospital to educate the pregnant woman to choose vaginal birth than cesarean section? Because here in Indonesia, there are some issues that most of the pregnant women wants cesarean section as the option for their deliveries. Please give us advice and some skills how to educate and how to attract, and so many women want to having vaginal birth than cesarean section. Thank you, Miss. Maybe.
Yeah. So there was one line I didn't hear. Was it about why did they want the cesarean section? Was there something about infection or?
Yeah, maybe there are so many reasons why they want cesarean section, but for that many reasons they prefer to have cesarean section than vaginal birth, because now in urban areas there are some shifting reviews that cesarean section is better than vaginal birth because the pain and so many other reasons. Maybe there's a false information that that we have right here, but that's what really the fact. Okay, so for the time.
Yeah, actually, I think one of the things I feel that when women, first-time mothers, are afraid of giving birth is that it seems all so unclear. They come and say, there are it's so unclear for me what's going on. So what I do with them is actually I do a flow chart. I do like boxes. I write with them. Okay, a birth can only start in two ways. The water breaks or the contractions start. Then you go to the delivery suite. Then you will be in inactive labor. Then you will be active labor, where you dilate from 0 to 10 centimeters, then the head comes further down, then you do the pushing, and then you have birth. So putting this into these boxes is just a really simple thing to say to people. And also I say, so you will dilate as a first-time mother 0.5 centimeter per hour. You will push for a maximum of 2 hours, maybe maximum of 1 hour. And this making it clear that there aren't a million ways to give birth, it's something that's really reassuring for them. Then you can also say, but of course we know that 1 out of 10 will have a cesarean section during birth. And if you have that, this is what will happen. And I feel that knowledge is something that's really important. And I don't know if you have the possibility for Antonox or for epidural, but that's something we also educate on. These are your options for pain relief. And then I would talk about the risks of cesarean section, that there is an increased risk that your next baby will die before birth. It's not a very high risk, but it is increased. There is a risk that your placenta will grow into the uterus, which is something that's actually very serious or can be very serious. So for me, it would be education. And that's what we do in our consultation, that we have birth preparation on the natural birth and on the complicated birth and on the postnatal period. And then I wouldn't be afraid to use the research about the fantastic birth. I mean, this life-altering experience of a vaginal birth, this is a huge potential. For me, it's been the biggest moments of my life, even though it was extremely painful. But I would do lectures on that with the community, and also have maybe have a support team of, there must be women there that have given birth and have good birth experience. That could be something you could also use, have like little expressions from like the research paper they did, say this is from our local community. Somebody said my birth was a life-altering moment. Somebody said it was the happiest moment of my life. Somebody said it was really hard, but I'm so proud I did it. Stuff like that. You could put that out in the community. Use your newspapers a little bit, or your podcast or radio or whatever people listen to. That's probably what I would do.
Thank you so much for the answer, Ms. Camila. I agree about what you said before about to educate the pregnant women about give them a better understanding about what is normal labor is and what is the complication of the cesarean section. But maybe the core problems is the backgrounds of the women, because in Indonesia we don't have same backgrounds. They're only study until elementary, and then the other only until junior high school, and also the economical status. So we have a bigger challenge to educate, because we have to speak and communicate in their perspectives. We cannot give them the same explanation that we give to one woman to other women. And as we know, that also needs time. And in Indonesia, we have not better ratio between the healthcare provider and the patient, because in your presentation, you said there are 30 minutes consultation for each patient. But here in Indonesia, because there's so many patients, maybe we can just give him the examination, and then the consultation is less than 15 minutes. So we cannot give them the bigger explanation. So we just have the point, and sometimes it's not enough for them. So they still believe that their perspective is true, something like that.
Yes. So we do also group education.
Mm-hmm.
So it's not with the single woman, but it's group education. So you have, in some places it's 100 people together, but the most beneficial is probably about 10 to 15 couples. So the husbands are there as well, and talk about stuff like, the little boxes I made. That's something everybody can follow, even though they have, or at least my women that with menstrual retardation or something, they can still follow boxes in a flow chart. How does it actually happen, this birth?
So for the explanation, we also have to give the education to the family, right? And make a group discussion with other pregnant women so they can share. And that's a good advice, Miss Camila. Maybe we can apply that here. Thank you so much. To Miss Mawan Prisanti, is there any additional question about the previous question? Okay. Is that enough, Miss Mawan? All right. Next to the second question, it is from Astin Marian to Miss Camila. Is there any barrier that midwives in Denmark in doing home visit care? Is there any barrier to the midwives there in Denmark in giving the home visit to the pregnant women after birth? What barrier?
Yeah, so I think the reason that it's a nurse that has the home visit after birth, it's just a lack of midwives, actually. So this is also the nurse can follow these families until the child goes to school, actually. So it's where it's not just about the birth or the neonatal or the baby. It's also somebody that can follow them until school age. I think that's probably why we chose to do it that way. But I do know that if you give birth at home, then you will have a visit by your home birthing midwife, because then you will not be in the hospital. And what would be really nice is that the women go home very early after a birth. They go home the same within 24 hours, the majority of them in Denmark. So it would be really nice if they could have a home birth, but that's just economically not possible, unfortunately.
Okay, so that is a very interesting point, that home birth is suggested for pregnant women. But here in Indonesia, because of the facility and the competency of the midwives for the equipment, we doesn't recommend a home birth anymore. So right now, every delivery is suggested to do in clinic, and there's so many private clinics here in Indonesia, and the problem is we don't have a team. The midwives working together with the other midwives, but there's no team like what you have there in Denmark, like one obstetrician and one documentator. We just have 2 midwives and working together to helping delivery of the baby. So we don't have many team to make the safest delivery as possible. But that's a great example to do a better delivery.
Yeah, and I think what is important with the home birth or the clinic birth, where you only midwives, is the visitation. That if you evaluate the woman's risk before she gives birth, then it should be safe enough to give birth in home or in clinic, in my opinion.
Okay.
So
pardon?
Yeah. So if she's a low risk woman, then I feel it's fine for her to give birth in the birthing clinic without a doctor present. If you have a good possibility to transfer her, if you say, oh my God, she is now, the CTG or the heart rate is going tachycardic now, I would like to transfer her, or she has no progression, I need to transfer her to a place where there are doctors available to do a cesarean if necessary, and only keep them while they are completely normal, because then it's probably the best place to give birth, because it's low intervention and good care.
Yeah, maybe because I agree, at home we can feel more comfortable. We are not stressed to deliver a baby, but what being the issues here is what is normal, because we don't have many equipments for screening. For example, in first trimester, we don't do a nuclear scan. We only have ultrasonography for screening for congenital anomalies. But for the simplest examination, like the ultrasonography, we don't also always have here, especially in rural areas. So that's why what is normal is not always normal. We just thinking that normal is having a baby growing until 9 months, but we don't know if they're having a congenital malformation, like maybe brachydactyly or other simple malformation. So what we don't have here is the screening, the good screening about what is normal and what is not normal.
Yeah.
Something like that.
Yeah. That does make it completely different.
Okay. Completely different. Okay.
Yes.
Yeah, that is the big problem we have here, because the large demographic areas and so many citizens and different backgrounds. So it's really big challenge for us, the healthcare providers, and also the government as the policymaker. So to the third question, it's from Perwita to Ms. Camila. What are current issues related to digitization in midwifery care? Thank you. So as we know right now, the internet has been the biggest life of us, like everything we post it in social media or something. And is there any influences between the digitization and in midwifery? Is it a positive influence or it is a negative influence?
I think it is mainly a positive influence, because there will be, like, I have a group for women giving breech birth. I have a Facebook group for them, and I'm the, I can give comments and tell facts in a good manner. And there will be other midwives, midwives that have a group where they can tell people about this and that. And then there will be smaller groups where there are only women and no healthcare providers. Well, they will talk about, but in my group, they said it's really dangerous, this or that or that. And especially in Iceland, it's a lot more than it is in Denmark, where in Denmark, I feel the women are better educated. They have more information already from the healthcare provider. So they know much more about normal health, about normal birth. So I feel that we actually use it in a very valuable way, the digital, the social media for birth. Then there is actually a small, but it's a really little group. But as I was saying, in really rare occasions, the government can take your child away from you if you are evaluated to be just not able to take care of your child. And these women, they can still go on the internet, and they have discovered that if you just move to Germany across the border, then nobody will take your baby away. So they will come to our hospital for consultations and then move to Germany, so nobody takes their baby. And those are some women that are psychiatrically really disturbed, and that's something that actually, the internet make that possible. But it's a little group of 5 to 10 women. So all in all, I feel it's positive, because we are putting out so much information. And of course, everybody has access in Denmark to internet and mail, and so they can read anything also from the hospital and from the government.
Yeah, I agree about the positive influence that social media can give to so many pregnant women. And maybe we can, as a healthcare providers, we can use social media as our platform to educate more. Like maybe we can be friends with our patients in Facebook or our Instagram, so we can give them a better education. So as a healthcare providers, we can use our platforms to educate our patients. And but in other issues, maybe false information is very easy to get from the social media. So it's the biggest challenge because sometimes because what they read in internet, they feel like they know more about that than the healthcare providers. So sometimes, yeah, it can be misleading, and it's our job to understand.
I agree.
Okay.
And in the beginning, when they came with these stories from the internet, I was maybe a little bit annoyed, but now I'm seeing it as part of my daily life to say, oh, I could see why somebody would say that. It's probably this and that and that. So I try to explain why would somebody say that on the internet, and then I'll say, but the risk of having, postpartum bleeding that you could die from, it's probably in Denmark 1 out of 500,000. So you can see it's a really low risk, but of course there will be one if we have 60,000 births a year. And so I try to put numbers on it so that what they read on the internet suddenly is not 100%, but it's, and all women in Denmark are okay with percentages, or 1 out of 1,000 or 1 out of 100,000. And I feel that that gains perspective to that. So I'm trying to be more respectful for what they bring, because they did do some research online, and I have to respect that as well.
Thank you. So as healthcare providers, we also need to update about the current issues that happening in our social circle, so we know about what really happens, and so we can give them the better information. Thank you for the question, Parita. And the other question, from Farina. Thank you for the excellent presentation, Ms. Camila. There's a question. How to start a regulation like this so between professions can jointly care for a mother from the beginning of pregnancy planning? Okay. So the question is, what kind and what we can do to start a regulation where we healthcare providers can join together to give the best treatment for our patients, from the midwives to doctors to nurses, so the outcomes of mothers and children are better. What kind of regulation that you think we can do here?
Yeah, I I don't know Indonesia very well, but I am suspecting that education and using the community more, I think that would be the way to go. So you need to, what I'm doing in my current department in Iceland actually is I can't team train, because first I have to make sure that we all have the same knowledge. So that's our first goal, is to have the same knowledge. What is actually a risk in pregnancy? How often do we recommend to see them? So that would be something for you also, what are the benefits of normal birth? What are the risk of cesarean section? That would be one education for the community. And you could also use community persons that have a good voice, that have positive ideas about childbirth, and also use yourself, your own experiences. And then about the doctors and the midwives, it takes usually, I'm just putting people in boxes, but usually the midwives are keen to have teamwork, and the doctors are a little bit more reluctant, because I think what I found out now is that because the doctors have such a big responsibility, because it's there in the end, they will have the blame if something happens. So they have to see that it's valuable to do teamwork with the midwife. So it's a circle kind of. So if the midwife offers her opinion on something and say, how would you feel that we discuss this? I would like to discuss this with you. Would that be okay? That then the doctor would all of a sudden see, oh, I do have a valuable team member here. But if they come in the room and then the midwife just goes in the corner and says nothing, then the doctor will just continue in their own, I have so much to think about, I have such a big responsibility, I need to act. Or so it's for me it's a circle that we need to make a good circle, and probably it means to have some team meetings and say, so how could we start to respect each other's opinions more? And also, as I said, the midwife coordinator, if you're in a bigger place, that has the overview and is more specialized than the normal midwife, that's a good step between the midwife and the doctor. I don't know if any of this is realistic where you work, but that would be my first ideas.
That is a wonderful opinion, Ms. Camila, because teamwork is really important for us healthcare providers to give the best treatments for our patients. So between our profession, we should not thinking that one is better than another, but we are working together as a team for our patients. So and we also need to have a better communication. Like we have to maybe have more meetings and other seminars to strengthen our bonds and educational updates about what happens around us. So yeah, maybe that's the best way, but it's far from happen, but maybe we can start little by little. Okay,
and sorry, sometimes
question?
it also takes one clinic that does it. So if you have one clinic that has both doctors and midwives, and you start there to educate them and see and monitor their results and see, okay, they're actually reducing their cesarean section rate without putting anyone in danger. They have a happy population of women coming there. That's what we've been doing, and that's been spreading then to other instances. It's difficult to change a whole country at once, but start with one unit and say we have this goal, and you need to have the bosses on board, of course, and so all the leaders have to agree to this. Otherwise, you can't change anything at all. You have to have a green light from them to say, okay, this is valuable, let's do that. And I'm happy to come and give my opinion also. If you invite me, I'll come and talk to you about
this. We are looking forward about your arrival in Indonesia, Ms. Camila. Yeah, that's a lovely answer. And maybe there's so many differences, but we can adapt some points. And I agree that we can start little, and if it can progress, it can make a big change. So we have to start by ourselves before we change the society, right? Yeah. Okay. So the other question, there's two other questions. First is from Miss Fatima to Zohra to Miss Camila. How we can give suggestion to mother
So I can't hear you anymore, but can you possibly hear me?
The case in pregnant women after delivery, Miss?
Now I can hear you again, but you just fell out a little bit.
Yeah. Okay, let me.
But I can read the question, and I heard part of it. So the first one about the traumatic childbirth experience, first time. Then, as I said, I would listen very much for the specifics. Was it because of birth, or because she felt alone, or didn't feel communicated with? And are you in a position to promise her that that will not happen next time? Do you have a team that you can trust will do that for you? Because if you promise her something and then when she comes in, the team just talks over her or doesn't give her pain relief, then you can't really say that. Then you can say, the best thing you can say is that for almost everybody, the second birth is way shorter and way less it's much less painful. So that's a really good start for a birth, because it's only the first birth in usual women that is extremely painful and long. So it depends really on whether you have a team that you can trust or not. And if you do have a team, then you go through her specific points. What didn't feel good to her the first time? And, even though you think this is really normal, don't say that to her, this was so normal. Why are you crying about this? Nobody would say that, but just saying that we can see it's progressed really fine. And in our opinion, it's a normal birth, but her experience is always true. So I would try to go into the details. So next time, if this happens, we want to do this and that and that. And we want to offer you the possibility of a timeout. If you feel I'm completely stressed or traumatized now, then we need to come and talk to you about what's going on right now. Yeah, and I always forget to thank for the questions, but I'm really enjoying this. I just have to say, I'm just not used to the thank you and being so polite as you are, I think. Sorry.
Thank you so much. We also have a wonderful presentation from you right now, and we're also enjoying this. There's some other last question, maybe, Ms. Camila, before we end the presentation. There's a question from Alea. How can we guarantee our patient to get vaginal delivery, considering that many women want sexual cesarean even though vaginal delivery complications are smaller? For example, you said there's a maternal request. And do you always accepting the maternal request for cesarean section, Ms. Camila?
No. So we had a development. In the beginning, we said no. Now we say, I hear that you would really like a cesarean section. What I would like is to talk to you about, why do you want this? And then I would always recommend you a normal birth, but not until you feel safe doing it. So can we have a talk about, why do you feel unsafe? Is it because of the pain? Because then we have pain relief here. That's possible. Is it because of the unpredictability? Like I was saying, it looks like it's all over the place. Then I can show you in a flow chart that it goes like this and that and that. Or is it because you feel shy for other people seeing you without clothes on? Then I can promise you we'll cover you as much as possible. Is it because of you're afraid of what will happen to your vagina? Then I can say it's something that heals really well, and it almost goes back to the same way it was before. And so I try to go into the details of, why do you want it? And I have to say, I always recommend you a vaginal birth. But I think she needs to be met in her, why is she wishing this, before I can say no. But I do say, I don't offer you a cesarean section after the first consultation. I offer you to go into a conversation with me. That's what I offer you to do. But I'm not going to give you just a cesarean section because you want to know the date of the day your baby is coming or something like that. That's a no from me. But if you're really scared, even after we finish our conversations, then we will consider it and we'll talk about it. But not after one. Yeah.
That's very interesting, because what we believe that if a maternal request, then we just do it anyway. So if there's a maternal request, we as healthcare providers, we should still give them the best explanation about what best for them, so they can have better understanding, and for the conclusion is up to them what they choose, right? And what I adore most about you, Ms. Camila, is that you're very passionate about your work. You're very gentle with your patients, and you're always talking to them like they are very important and they are very close to you. So that's what makes you great, I think. And so for our midwives here in Indonesia, maybe we can take example from Miss Camila that if we want to be healthcare providers, we should put in our hearts that what we do is for our patients. There's no other issues that we want, like we want to be rich, to be a doctor, or we want other things than the best interest for our patients. So thank you so much for your lovely presentation this afternoon, Ms. Camila. Maybe for right now, I give to the moderator, to the MC.
Okay, thank you so much, Dr. Anissa, for helping us through this session. And also, thank you very much for sharing your experience and knowledge to us, Mrs. Nelson. Now we will begin the 8th session of our conference today. The keynote speaker for this session is our Dean in Medical Faculty of Andalas University, Dr. Afriwardi SH SPK OMA, with the topic of interprofessional collaboration for service excellence in midwifery care. This stage will lead by Ibu Mirani Safaringa SSTM CAP, but firstly, let me give a short explanation about her background. Okay, as we can see here, Bu Mirani right now is a lecturer in midwifery field, especially in undergraduate program Andalas University, and she started her education in midwifery in 2009 and finished her master degree in 2018 in Andalas University. So her thesis is actually focusing in analysis of implementation maternal care program in independent midwifery clinic in Padang City. And as we can see here also, her work experience is not only in the educational fields, but also in a clinical setting. Like in 2013, she also practicing in midwifery at Midwives on the independent practice in Padang Panjang, but also she continue as an educator and clinical instructor in Alifah Sekolah Tinggi Alifah Padang, Sumatera Barat, and then right now she is a lecturer in Andalas University. And also we can see here there's a lot of research project and selected research paper. And she already released 3 books related to a midwifery field, like Character Building for Nurse and Midwifery, and then Midwifery Care Cycle Guidebook for Neonatal Infants, Toddlers, and Preschool Children. And lastly, Leadership Cycle Guidebook in Midwifery Services. I think there's a lot of more in her resume, but however, we will going through directly to our ma'am here. Assalamualaikum, Ibu Mirani. How are you, Ibu?
Waalaikumsalam. I'm good. Thank you, Hani.
Okay, Bu. I will give the full control and screen to you. Time is yours, Bu.
Okay, thank you so much, Hani. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Izinkan saya untuk memoderatori dengan bahasa Indonesia. Kali ini kita akan ada materi dari Dekan Fakultas Kedokteran Universitas Andalas yang sangat luar biasa. Selamat sore, Pak.
Ya, Assalamualaikum warahmatullahi wabarakatuh. Selamat sore.
Ya, izinkan saya menyampaikan sedikit CV beliau. This is our incredible Dean saat ini, Dr. Afriwardi SH SPK OMA. Beliau merupakan Dekan Fakultas Kedokteran Universitas Andalas. Beliau menempuh pendidikan yang sangat luar biasa dari spesialis Universitas Indonesia, ilmu kedokteran olahraga, kemudian beliau juga seorang magister agama, kemudian beliau juga menempuh pendidikan hukum di Universitas Taman Siswa. Beliau banyak sekali mengikuti pelatihan profesional seperti yang bisa kita lihat di monitor. Kemudian juga beliau seorang aktif peneliti yang aktif dengan pengalaman meneliti sejak tahun 2008 hingga sekarang. Dan beliau juga merupakan seorang penulis karya ilmiah yang sampai sekarang telah banyak mengeluarkan karya-karya baik apakah publikasi penelitian maupun buku yang telah beliau ciptakan. Juga aktif mengikuti konferensi dan seminar serta simposium hingga tahun 2021 ini. Juga banyak sekali mengikuti kegiatan profesional dan pengabdian kepada masyarakat. Baik, demikian saya sampaikan terkait profil beliau. Saya undang langsung kepada Bapak Afriwardi. Silakan Bapak, waktu dan tempat saya persilahkan.
Ya, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore, pribadi. Baiklah, pada kesempatan ini saya diberikan kesempatan untuk memberikan satu materi yang menurut kami sangat menarik. Ya. Kenapa? Karena judul yang diberikan kepada kami itu adalah satu judul yang memang inilah sebetulnya yang diperlukan saat sekarang. Gimana ini? Karena pada saat penutup daripada proses layanan, kalau kita memang ingin dapatkan layanan yang excellent itu, memang kuncinya di sini, di topik ini barangkali. Karena kalau tidak kita lakukan ini, maka semata-mata akan buyarlah apa yang kita cita-citakan untuk memberikan pelayanan yang terbaik terhadap masyarakat kita ini. Baiklah, boleh minta diizinkan saya untuk share. Okay.
Silakan Pak.
Saya bisa dilihat. Oke, bisa dilihat ya. Anda. Ya, yaitu Interprofessional Collaboration for Service Excellence in Midwifery Care. Ya, jadi kita berharap pada kesempatan ini kita akan memperlihatkan bagaimana sudut pandang kalau kita lihat dari sisi dari sisi perspektif sosial, maka kita akan melihat betapa pentingnya kita untuk bisa melaksanakan kolaborasi ini. Apakah bisa di ini ya?
Bisa Pak. Izin untuk slideshow mungkin Pak, mohon maaf.
Bukan, maaf sebentar. Ini kenapa kok ininya taruh di bawah dia ini? Sebentar. Ya, sebentar.
Baik Pak.
Ya, sebentar, ini ada kekeliruan kayaknya.
Tak apa-apa, kami tunggu Pak.
Ya. Oke, sebentar. Udah ya?
Udah, Pak.
Ya, ya, baiklah kita ini kan pertama kita melihat bahwasanya proses yang terjadi pada saat kita berbicara mengenai kebidanan ini itu mau tidak mau kita akan berbicara dulu apa itu di kebidanan itu ruang lingkupnya ya. Kenapa? Karena kalau kita lihat ruang lingkup kebidanan itu sebetulnya adalah merupakan sintesis itu dari berbagai disiplin ilmu ya yang ada di kebidanan tersebut. Walaupun memang nanti kekhususan tersebut ini akan kita ambilkan pada proses melahirkannya. Tapi kita melihat kalau kita mengatakan sintesis berbagai disiplin ilmu mana saja yang akan terlibat ya. Kalau kita runut satu-satu sepertinya karena ini adalah proses yang melibatkan hampir semua sebetulnya cabang keilmuan ya, keilmuan yang ada di dalam kehidupan ilmiah itu ya. Ada kenapa? Karena kalau kita perhatikan di sana ada kalau kita membagi aja ilmu dua, ada medis dan non medis, maka medis ada kedokteran, ada perawatan, ada psikologi. Nah, maka proses daripada kegiatan daripada kebidanan tersebut itu akan melibatkan semua ini. Itu juga nanti di non medis ya, itu dia juga akan melibatkan berkaitan dengan sosial budaya ya. Kenapa? Karena kegiatan ataupun proses terhadap kebidanan tersebut itu memang itu mau tidak mau akan melibatkan ini semua. Misalkan ada apanya dari kesehatan masyarakatnya, kemudian manajemennya dan lain sebagainya. Jadi kalau begitu kita melihat kalau kita mengambil dasar bahasa kebidanan seperti ini, maka kita akan mengatakan tidak mungkin ya, tidak mungkin kita akan bisa atau tidak bisa mengatakan bahwasanya sistem pelayanan di kebidanan tersebut itu akan bisa berdiri sendiri ya. Ya udah nanti bidan aja dalam tanda kutip kita bisa melaksanakan, tidak bisa seperti itu. Kenapa? Karena membangun kebidanan itu yang itu sudah dimulai dari tentu adalah dari latar belakang pemberian knowledge, kompetensi dan attitude-nya. Itu kan itu mulainya. Sehingga apa? Sehingga dari ketiga itu maka akan nanti akan muncul ada kompetensi. Kalau kita lihat ada kompetensi, ada kemampuan dia untuk melakukan kegiatan-kegiatan tertentu, maka kita akan bisa mengatakan bahwasanya kebidanan tersebut tidak hanya tidak bisa mengatakan dia akan menjadi ilmu berdiri sendiri. Nah, kenapa ini kita sampaikan? Karena memang kita melihat bahwasanya kebidanan itu karena ketidakmungkinan mereka itu akan berdiri sendiri, maka akhirnya dalam memberikan pelayanan tersebut itu wajib ada kolaborasi ya. Nah, wajib ada kolaborasi. Harus ada dia perlu bantuan orang lain ya. Nah, sebagai ya walaupun memang secara ilmu dasar sosial itu mengatakan tidak akan mungkin seseorang akan bisa hidup sendiri gitu di dunia ini ya. Mungkin kenapa? Karena manusia adalah sifat makhluk sosial dan dia memerlukan kebutuhan atau membutuhkan orang lain ya. Nah, sehingga kalau kita kaitkan antara bagaimana kita berusaha untuk membentuk suatu kerjasama yang baik, maka kita melihat kita memulai dari tadi adalah bagaimana ruang lingkup dari kebidanan tersebut. Kalau kita melihat dari ruang lingkup kebidanan, maka dalam upaya kita mendapatkan suatu pelayanan kebidanan yang melayan secara excellent atau dengan paripurna atau terbaik atau apalah namanya, yang penting adalah dengan derajat yang lebih baik, maka mau tidak mau kecabangan dasar tadi itu memang harus kita samakan, harus bersama-sama. Tidak mungkin satu saja dan tidak ada satupun yang nanti yang boleh dikatakan dia berpengaruh. Ya, sama dengan sepeda ini. Ya, kalau kita lihat sepeda ini, kita memperhatikan dan dapat kita pastikan di antara sepeda ini kan sepeda kan dibangun oleh macam-macam bahan dasar, ya, ada besi, ada karet, ada kulit, ada dari plastik dan dari lain sebagainya. Banyak sekali yang membantu kita atau yang membangun sepeda ini. Nah, sehingga apa? Sehingga pada saat kita mengatakan sepeda itu bisa berlari kencang dan dia bisa bisa digunakan dengan fungsi yang maksimal, maka semua komponen-komponen yang ada dalam membangun sepeda ini itu wajib dalam keadaan baik dan tidak ada saling kontra dan harus ada sinkronisasinya. Sehingga dengan demikian maka akan terjaminlah bahwasanya kita akan bisa mengatakan bahwa sepeda bisa berjalan cepat, berjalan baik dan sebagainya. Namun demikian kalau kita lihat dan kalau mau kita kembangkan lagi, maka seakan-akan kolaborasi ataupun bagaimana sepeda itu bisa berjalan dengan baik, tentu nanti akan banyak sekali nanti upaya-upaya ataupun jalan-jalan yang perlu kita tempuh bersama-sama. Misalnya, kalau seandainya sepeda ini kita bawa untuk jalan raya, apakah model ini cocok enggak? Nah, juga seperti itu. Sehingga apa? Sehingga kita mengatakan lingkungan dan semua yang terkait dengan sepeda itu, atau semua yang bersinggungan dengan sepeda, maka dia akan terlibat. Nah, dan dengan demikian maka kita berupaya bagaimana semua komponen-komponen, semua yang terlibat itu akan harus bekerja sama. Nah, sehingga kalau kita kembalikan lagi kepada topik kita, yaitu adalah mengikuti pelayanan kebidanan, maka kita akan tentu secara formal kita melihat keputusan Menteri Kesehatan RI nomor 369, ya, bahwasanya pelayanan kebidanan tersebut harus memiliki standar profesi bidan. Ya, ada standarisasi yang harus diberikan atau yang harus diatur oleh undang-undang. Kenapa demikian? Karena kita tahu bahwasanya undang-undang tersebut adalah untuk memberikan jaminan kepada seluruh masyarakat untuk mendapatkan layanan yang memang terstandarisasi. Terstandar itu ada ukuran-ukuran tertentu yang menjadikan layanan tersebut memang bisa diterima dan sesuai dengan undang-undang yang ada dalam praktek kebidanan tersebut. Tentu saja salah satu syarat utama itu adalah mengatakan bahwa bidan itu harus terregister, ya, ada STR-nya, ya. Nah, dan pada saat dia melakukan ini kebidanan, di undang-undang itu sekarang baru ada istilah, ada layanan mandiri, ada layanan kolaborasi, dan ada layanan rujukan. Nah, dari sekian banyak, dari sekian pengelompokan yang dilakukan, ada yang diinikan oleh undang-undang, maka kita melihat, sebetulnya kalau kita tujuan untuk melayani atau mendapatkan servis excellent daripada ataupun layanan terbaik daripada pelayanan kebidanan tersebut, tentu dari sekian ini tentu kita akan melihat, kita tidak bisa mengatakan apakah nanti mandiri itu tidak bisa excellent. Tidak juga seperti itu. Apakah harus dengan kolaborasi? Karena belum kolaborasi, belum tentu juga dia akan excellent. Kalau dia dirujukan, apakah itu juga sudah adalah dalam upaya untuk mencari kebaikan atau pelayanan yang terbaik. Nah, maka dari itu kita melihat di dalam praktek kita sehari-hari, kita akan melihat di mandiri dan ada kolaborasi dan ada rujukan. Namun yang jelas kita mengatakan begini, kita akan mengatakan bahwasanya dari kita melihat ini, ya, dapat kita bayangkan bagaimana seorang ibu ini akan diberikan anak yang mungkin pada saat itu baru dilahirkan, ya. Nah, kemudian kita mengatakan apakah yang dikatakan service excellent itu? Apakah dengan melihat gambaran ini kita sudah bisa mengatakan wah ini adalah salah satu service excellent? Ya, kenapa? Karena kita akan melihat service excellence itu kiranya tidak hanya ditentukan ya oleh layanan. Jadi artinya kalau seandainya bidannya sudah sudah baik, kemudian sudah ramah, senyum-senyum seperti itu, apakah itu sudah dikatakan baik? Belum tentu baik. Kenapa? Karena service excellence itu indikator-indikator yang digunakan yang dapat dipakai sebagai sesuatu bahwasanya service itu menjadi baik itu sangat bukti multifaktorial juga. Ya, kenapa? Karena kita tidak bisa mendefinisikan itu baik atau tidak. Apa yang kita pakai? Tapi yang jelas ada beberapa indikasi-indikasi
Izin sepertinya Bapak terlempar ya. Izin Pak, Bapak mute Pak, posisinya Pak.
Iya, sorry.
Maaf Pak.
Ya, enggak apa-apa. Udah ya?
Udah Pak, sudah.
Ini nggak kelihatan nih. Zoom-nya hilang.
Mohon izin untuk share screen kembali Bapak.
Iya, iya. Udah ya?
Baik.
Ya. Sorry, putus-putus ya ini kan.
Tidak apa-apa.
Jadi kita melihat di dalam service excellence ini memang kita itu tidak bisa mengatakan yang seperti apa service excellence itu yang ininya. Kenapa? Karena nanti juga akan dipengaruhi oleh faktor sosial budaya. Ya, contoh saja, apakah memang kalau kita membandingkan begini, kita dirawat kalau di Malaysia itu mereka dirawat seseorang dirawat itu sakit atau melahirkan langsung dibawa ke sana dan semua dilayani oleh orang lain, dilayani oleh perawat yang sudah memang digaji untuk itu. Nah, tapi kalau kita tanya kepada kepuasan pasien, itu bagi mereka itu tersiksa katanya. Nah, jadi memang sangat ini kita terhadap service excellence. Namun demikian tentu kita harus juga menyampaikan di sini bahwasanya beberapa kriteria-kriteria service excellence itu tentu sangat tergantung kepada terhadap bagaimana kita mendefinisikan dan bagaimana indikator-indikator yang kita gunakan. Ya, namun yang jelas indikator-indikator yang jelas itu yang baik itu adalah tentu adalah bagaimana terutama melihat terhadap terhadap tiga proses, terhadap tiga indikator. Pertama adalah proses pelayanan, yang kedua adalah sarana prasarana, dan yang ketiga tentu adalah berdasarkan SDM yang dimiliki. Ya, kalau kita uraikan sampai di sana, itu yang sebetulnya yang terjadi. Sekarang kita fokus sebetulnya salah satunya adalah pengadaan SDM sebetulnya. Kenapa? Karena di topik kita ini sekarang berbicara mengenai interprofesional. Interprofesional. Dia artinya bagaimana antara profesi itu bisa bekerja sama dalam rangka untuk memperlihatkan hasil yang lebih baik. Memang secara logikanya begini, semakin banyak interprofesi itu terlibat dalam satu pelayanan, dia akan menjadikan sesuatu itu akan menjadi lebih baik. Itu teori dasar yang kita gunakan. Tentu dengan catatan memang mereka itu bekerja sama dalam konteks saling menggunakan dasar-dasar daripada proses kerjasama yang baik. Ya, kalau di sana ada kecurangan, ada intimidasi, ada ini semua itu juga tidak menjadi baik. Ya, nah, tentu adalah integritas daripada semua itulah itu yang akan menjadikan sumber SDM ini akan menentukan bagaimana kita bisa menghasilkan layanan yang excellent terhadap proses pelayanan kebidanan ini. Demikian yang kita ingat. Kenapa? Karena kalau kita lihat juga asuhan kebidanan itu kiranya meliputi ibu hamil, ibu bersalin, ibu nifas, dan bayi baru lahir. kalau kita melihat ke sini, profesi-profesi mana yang harus melakukan kolaborasi, ya? Ibu hamil, siapa-siapa saja itu yang harus berkolaborasi, ya? Itu banyak sekali. Di sana ada ahli gizinya, kemudian ada tumbuh kembangnya, ya. Kemudian pada lagi untuk ibu-ibu juga ada tumbuh kembang. Kemudian pada ibu hamil juga perlu adanya dari psikologinya, sehingga mereka siap untuk menjadi ibu, ya. Nah, sehingga kalau kita perhatikan sambilnya satu misalnya, kalau menurut kami itu semua profesi itu akan bisa terlibat, ya, akan bisa bersangkut paut terhadap semua ini. Kenapa? Karena seorang ibu harus lahir dalam keadaan, atau semua ibu itu harus sehat jasmani dan rohani dalam rangka untuk menghadapi proses mendapatkan anak, atau dalam proses dia persalinan misalnya. Kenapa? Karena kan persalinan itu bukan dia adalah proses fisiologis, tapi tidak semua orang yang akan bisa mampu melewati itu adalah satu fisiologis. Ingat itu, ya. Namanya fisiologis, tetapi tidak semua orang yang akan mampu. Kenapa? Karena adanya beban-beban yang ada di pundak dia. Ya, kenapa? Karena seorang ibu hamil tersebut jangan disangka dia, semua ibu hamil itu hamil apakah dia gembira? Belum tahu, ya. Ada juga yang ibu hamil itu dia menjadi takut, ya, atau nilai dikaitkan dengan nilai anak. Ada juga anak yang tidak diharapkan, gitu, ya. Nah, sehingga apa? Sehingga akhirnya akan mengganggu keseimbangan rohani mereka. Nah, sehingga asuhan kebidanan pada ibu hamil saja kita lihat, maka semua cabang ilmu sesuai dengan definisi daripada keilmuan kebidanan yang kita inikan tadi. Ada melibatkan medis, ada non medis, ya, dan non medis itu pakai di bawahnya kita bikin juga, dan lain-lain, ya. Nah, tapi kalau kita lihat berkaitan dengan sosial budaya dan orang ini, tentu kita harus kita perhatikan dan harus kita ajak bekerja sama. Nah, walaupun memang, ya, kalau kita lihat di dalam praktek sehari-harinya, kenapa pentingnya kita ini, ya, pentingnya kolaborasi itu. Pertama, bidan itu dulu praktek itu sendiri, ya, itu bidan perorangan, ya. Kalau di undang-undang tadi itu adalah praktek mandiri, ya. Kalau di undang-undang dia melihat berdasarkan pada pelaksanaannya mandiri. Mandiri itu artinya mereka bertanggung jawab sendiri dalam memberikan asuhan, ya, dan mulai dari sejak hamil sampai melahirkan, dan juga harus merawat ikutan, ya, pada saat postpartum. Nah, sesuai dengan kewenangan, ya. Nah, ini sesuai dengan kewenangan ini tentu akan merujuk kepada undang-undang, ya, melihat kompetensi yang sudah dimiliki oleh seorang bidan tersebut. Nah, sehingga apa? Sehingga pada saat dia primary care ini, komprehensifnya itu dia harus tetap ada. Ya, dimulai dari hamil sampai kepada dia itu melahirkan sampai dia postpartumnya, ya. Nah, ini yang menjawab tanggung jawab perorangan. Dan ini adalah kebanyakan praktek-praktek bidan kita ini yang terjadi di tengah-tengah masyarakat kita, ya. Dan yang kedua, ada juga kiranya dia masih termasuk mandiri ini, tetapi adalah dia itu melakukan perawatan dengan sekelompok bidan. Ya, ini juga sudah dimulai juga sekarang. Ya, kenapa? Karena salah satu titik lemah dari primary care itu tadi itu adalah karena tidak semua bidan tersebut memiliki waktu yang pas untuk membantu. Ya, misal saja apalagi sekarang bidan-bidan ada yang jadi PNS, harus bekerja pagi, harus masuk kantor, kemudian siang nanti atau dia dinas malam atau dan sebagainya, yang menjadikan proses pelayanan secara pribadi itu tidak terpenuhi. Maka mereka bekerjalah beberapa orang bidan yang mungkin dia bagi berdasarkan waktu prakteknya, ya. Nah, tetapi mereka itu karena dia sudah melibatkan, jadi artinya ini kalau seandainya ini disebut intrapersonal, jadi artinya antara profesi bidan itu sendiri mereka bekerja sama. Sehingga apa? Tapi dengan demikian maka standar daripada praktek itu harus dengan dalam kelompok itu, ya, harus dengan filosofinya itu harus sama. proses pelayanan harus sama. Jadi jangan nanti kalau pada kelompok bidan itu, kalau ada bidan Ani, dia melayani standarnya begini. Kalau nanti datang pula yang lain, nanti bidannya yang lain, nanti pelayanan begini. Nah, ini akan menjadikan proses layanan itu menjadi tidak excellent gitu ya. Tidak menjadi lebih baik. Kenapa? Karena biasanya kan orang suka membandingkan. Ya, membandingkan antara, oh ya kalau ini bidannya, ini saya mau dengan bidan itu. Nah, akhirnya apa? Kalau seandainya itu jadi filosofi tidak sama, proses pelayanan tidak sama, maka ujung-ujungnya nanti akan menuju lagi kepada primary care. Ya, maksudnya begini, ada 5 bidan, ya 5 bidan A, B, C, D gitu ya. Nah, setelah mereka melakukan continuity of care selama 1 tahun, maka nanti kalau seandainya filosofi dan proses pelayanan dan partnership-nya terhadap pasien itu tidak sama, maka itu biasanya ujung-ujungnya nanti kalau pasien ini kalau dia tidak standar, maka si ibu dia akan memilih ini. Orang mengrekomendasikan dengan ini saja, mesti dengan ini saja, ya. Nah, sehingga apa? Sehingga pada saat tersebut maka harus diberikan komitmen yang sama terhadap proses pelayanan pada continuum of care ini. Kenapa demikian? Karena kita menjadikan kelompok bidan tersebut memang harus memiliki integritas yang sama, filosofi yang sama, proses pelayanan sama, partnership terhadap pasien itu sama. Misalnya standarnya, kalau pasien datang kita harus senyum, ya. Kalau dia datang apa yang ditanya dulu, kalau dia standarisasi itu dapat dilakukan, maka komitmen daripada mereka bisa dipertahankan, maka insya Allah continuum of care ini akan menjadi lebih baik. Apa yang diharapkan dari kita bekerja sama dengan teman-teman sejawat dari kelompok bidan, maka kita akan memiliki cukup waktu, ya. Jadi kita tidak terlalu terporsir, kita terlalu ini. Nah, apakah pendapatan bisa berkurang juga? Belum tentu. Ini tergantung kita. Kenapa? Karena kalau kita mau menaikkan pendapatan, ya udah dinaikkan tarif gitu, boleh aja sudah. Tapi tentu dengan catatan kita harus menjaga keseimbangan antara harga dengan layanan kita. Jadi sepanjang layanan bagus semua seperti itu, maka insya Allah akan menjadikan kalau dalam tanda kutip berkaitan dengan pendapatan itu akan bisa diselesaikan secara bersama-sama. Nah, kemudian baru nanti ada kolaborasi, pelayanan kolaborasi, ya. Kalau layanan kolaborasi ini adalah kolaborasi profesional lain, ya. Dia artinya sudah interprofesional. Nah, inilah sebetulnya yang kita yang kita topik utama kita ini. Nah, bagaimana kita bersama-sama dengan profesi lain, ya. Kenapa? Karena profesi lain itu maksudnya itu adalah dalam pelayanan kita terhadap pasien tersebut, ya, itu enggak semua itu harus berkontribusi sesuai dengan bidang yang masing-masing. Kenapa kita harapkan begitu? Karena di tengah-tengah kita ini, kalau kita tanya misalnya ibu seorang bidan, kita tanya apakah bisa dia mengobati pada perawatan anak, misalnya sana dia mengobati anak demam, sana mengobati anak kencang, di sana semua akan dijawab tentu bisa, ya. Bisa. Kenapa? Karena untuk dasar-dasar itu kita mendapatkan pemahaman yang sama. Kenapa? Karena dasar keilmuan tadi itu kan dikatakan bahwasanya salah satu ilmu medis itu adalah kedokteran misalnya. Yang untuk memberikan obat bisa, memberikan paracetamol ya bisa, memberikan ini ya bisa, ya. Artinya ada obat yang memang bisa dilakukan layanan itu oleh dari profesional bidannya. Tetapi apakah dengan demikian kita akan mendapatkan layanan yang terbaik? Belum tahu, ya, belum tahu. Karena mungkin saja tidak. Kenapa? Karena akan berbedalah orang profesional, misalnya dokter anak dibandingkan dengan ya, itu akan berbeda. Sehingga apa? Sehingga akurasi dan ketepatan diagnostik dan pemberian layanan itu akan menjadikan proses layanan itu dalam asuhan kebidanan akan menjadi lebih baik. Sehingga apa? Sehingga layanan terbaik itu akan kita dapatkan sesuai dengan pepatah ini, kalau maaf dari Islam mengatakan maksudnya kalau kita menyerahkan sesuatu kepada ahlinya itu akan menjadi baik. Tapi kalau kita menyerahkan tidak kepada ahlinya, tunggulah kehancuran. Nah, maka dari itu kolaborasi profesional ini perlu kita galakkan dalam rangka untuk layanan terbaik. Walaupun memang untuk kita menjadikan atau mendapatkan layanan terbaik itu memang tidak sesederhana ini juga kiranya. Ya, tidak sederhana ini. Kenapa? Karena ada faktor-faktor lain yang memang berada di luar interprofesional tersebut. Ya, berapa hebatnya orang antara profesional di sana, ada ahli kebidanan di sana, ada ininya, ada ini semua, ada bidan dan semua seperti dalam satu rumah sakit misalnya, kita ambil itu paskesnya. Nah, tetapi di sana itu kita tidak menemukan ada kolaborasi yang baik, ya, kolaborasi baik. Ya udah, kalau seandainya dia sakit atau tidak bisa makan, ya udah ditangani bidan aja, tidak seperti itu. Tetapi adalah bagaimana semua profesional yang ada di dalam satu ini akan memberikan kontribusi yang baik terhadap upaya memberikan layanan terbaik terhadap pasien itu. Nah, walaupun memang terakhir kita akan memberikan informed choice terhadap si terhadap ibu, ya. Setelah kita melihat ini, bahwasanya perlunya kolaborasi yang ditanamkan di dalam kehidupan pelayanan, maka di sana itu kita juga ya ada satu yang merupakan bagian daripada kepuasan daripada si penderita ataupun pasien yang kita layani. Kenapa? Karena di dalam informed choice itu sebetulnya perempuan manapun dia akan berhak untuk memilih, ya, tempat layanan. Tetapi dia itu boleh memilih itu ya jangan disembunyi-sembunyikan gitu, itu maksudnya. Karena itu enggak pas juga. Misalnya kita berikan kepada mereka, ya udah ibu yang paling baik itu melahirkan di sini gitu kan. Nah, padahal sebetulnya dengan kondisi dia ada tanda-tanda pinggul sempit dan ada lain sebagainya, ada faktor risiko, mungkin kita akan mengatakan harus kita berikan kita berikan informasi kepada si ibu itu, ya, bagaimana resikonya kalau kita pertahankan dia melahirkan di klinik ini, ya kan. Kalau tidak di klinik ini begini, kalau tidak kliniknya. Tapi yang jelas kita harus memberikan informasi, ya. Tentu informasi adalah informasi yang benar, ya, yang objektif, ya. Sehingga nanti tidak ada pemaksaan. Pemaksaannya ya udah, Bapak Ibu kalau seandainya Ibu nak mau sini ya sudah. Tapi membicarakan itu dalam suasana kosakata yang berbeda, ya. Sehingga dengan kalau kita membilang seperti itu, maka kita akan menjadi sulit, ya. Si pasien akan mendapatkan layanan yang tidak maksimal untuk itu. Mungkin sebagai pengantar itu yang dapat saya sampaikan dulu. Mudah-mudahan nanti kalau ada diskusi kita ini sering mendiskusi. Saya kembalikan kepada moderator. Ya, silakan.
Baik, alhamdulillah. Terima kasih banyak Pak Afriwardi untuk materinya yang sangat luar biasa tentang interprofessional collaboration, ya, apalagi di bidang kesehatan. Tadi seperti yang Bapak bilang bahwa bidan itu adalah pekerjaan yang terdiri dari berbagai profesi gitu, yang ruang lingkupnya. Dan kita tenaga kesehatan juga tidak bisa bekerja sendirian. Kita butuh kerjasama seperti itu untuk menciptakan service yang excellent, begitu ya Pak, ya.
Ya,
iya. Kemudian tadi juga disampaikan bahwa salah satu modal praktek bidan itu adalah partnership. Nah, jadi di sini partnership pun sebagai salah satu model praktek, tidak hanya berpartner dengan pasien, dengan keluarga pasien, namun juga dengan tenaga medis lainnya, sesuai dengan tupoksi masing-masing. Baik, kita masuk ke sesi tanya jawab. Silakan bagi audien yang ingin bertanya. Baik, sudah masuk satu pertanyaan dari kolom chat, Pak. Izin Ani bacakan. Terima kasih Pak atas materinya. Saya izin bertanya dari Ibu Verina. bagaimana membangun budaya otonomi bidan dalam interprofessional collaboration di rumah sakit. Seperti itu.
Ya.
Silakan Pak.
Ya, ini memang pertanyaan yang memang apa namanya yang cukup bagus ya. Kenapa? Karena memang ini kenyataan yang praktek daripada interprofessional collaboration itu kan umumnya berada di rumah sakit sebetulnya ya. Nah, tapi sebetulnya tidak hanya di rumah sakit, ingat itu ya, di rumah sakit. Contoh saja kalau di puskesmas juga sudah dimulai itu. Artinya biasanya berada di fasilitas kesehatan ya, fasilitas kesehatan. Di klinik juga seperti itu. Ya. Sehingga kadang-kadang di tempat praktek pun harusnya seperti itu. Ya, jadi tapi pertanyaan sekarang bagaimana kita bisa membangun budaya ya, membangun budaya otonomi bidan ya. Maksudnya begini, jangan disambungkan dengan otonom ya, karena kalau dibacakan budaya otonom artinya itu balik lagi itu. Ya, saya rasa mungkin pertanyaan bagaimana kita bisa membangun interpersonal collaboration di rumah sakit, mungkin seperti itu ya. Karena yang kita bangun itu adalah bukan budaya otonominya, tapi bagaimana budaya kita bersama-sama ya, kolaborasi bidan itu dalam rangka untuk memang betul ya, di rumah sakit tersebut kita mendapatkan atau bertemu dengan banyak anggota-anggota ataupun profesi-profesi lain yang berada di sana ya, profesi perawatan ya, kemudian ada profesi dokter, kemudian ada profesi rehab medik, ada profesi dan lain sebagainya, banyak sekali ya, sesuai dengan yang kita bicarakan tadi. Karena itu ya, bagaimana kita upaya tersebut? Kalau di pendidikan kita sudah memulai dari awal itu ya. Karena kita sekarang sudah masuk kepada upaya untuk melakukan pendidikan dengan interprofessional education (IPA) ya. Nah, itu adalah dalam rangka untuk itu. Ya, untuk itu. Nah, dan juga sekarang sudah di proses pendidikan, terutama di kesehatan itu ada academic health system sekarang. Nah, itu lebih luas lagi nanti kolaborasinya, ya. Nah, sehingga apa? Sehingga kalau kita mengikut dari academic system tersebut, itu kolaborasi yang kita bangun itu bukan hanya interprofesional ya, tetapi adalah semua yang melibatkan atau pemangku kepentingan terhadap pelayanan kesehatan itu, ya. Kalau di ini ya termasuk Pemdanya, termasuk dan sebagainya. Nah, tapi dalam konteks di rumah sakit, bagaimana kita ini kan tentu adalah bagaimana kita bisa membangun ini. Memang secara ini tentu akan dimulai dari diri sendiri gitu ya, diri sendiri. Artinya kita berupaya untuk bagaimana kita pengen dihargai orang, kan itu aja masalahnya itu. Ya, profesi kita bagaimana bisa dihargai orang. Nah, kalau kita mau dihargai orang, ya rumus dasarnya itu kan dikatakan hargai orang, hargailah diri kita dulu, ya. Hargai diri kita, karena dengan kita menghargai diri kita, maka mau tidak mau kita akan bisa merasakan bagaimana kita harus menghargai orang. Nah, sehingga kalau kadang kita lihat di sumpah kedokteran itu, bagaimana memperlakukan teman sejawat itu adalah sebagaimana kita ingin diperlakukan. Jadi artinya coba perlakukan diri kita. Nah, ini dasarnya. Nah, tentu dasar ini tentu kita harus melakukan melakukan sosialisasi ya. Sosialisasi itu dalam rangka untuk memberikan kesepahaman kita. Ya, kesepahaman kita. Ya, misalnya dalam merawat seorang mau melahirkan gitu ya. Nah, memang kalau kita lihat kan yang memberikan perawatan, memberikan proses melahirkan pada tersebut, tentu kan kita bisa melihat ya, karena tidak bisa kita kerjakan sendiri itu, ya udah pasti tidak bisa kita kerjakan sendiri. Nah, tentu kita akan berharap bisa tidak kita dibantu orang lain, bisa. Tetapi sebetulnya orang yang bantu ini kalau lebih baik tentu adalah orang-orang yang profesional di bidangnya, ya. Sama dengan kita dengan sepeda tadi itu. Ya, kalau kita misalnya ada bocor, bisa nggak kita menambalnya atau menambah anginnya? Bisa, tetapi alangkah baiknya dikerjakan oleh orang yang sudah paham betul. Nah, kalau ini bocor nanti kita tambalnya begini lebih tahan. Nah, sehingga apa sih kita berharap ya, kita berharap teman-teman semua mulai dari sendiri untuk bisa mengajak dirinya untuk merasakan, dan kedua tentu melakukan pendekatan yang bijak, yang bijak, sehingga teman-teman ataupun profesi lain tersebut merasa diajak, atau kita ayo bersama-sama, ayo diapain ini gitu kan, perawatan ini kita apakan gitu ya. Sehingga semua profesional yang ada di rumah sakit tersebut itu masih bisa terlibat. Namun demikian, sebetulnya tugas ini tentu tidak bisa dari diri kita sendiri, misalnya itu. Ya, oke lah, kita sudah ketemu dengan ini, dan biasanya ini tentu harus ada inisiatif dari rumah sakitnya. Untuk apa? Misalnya kenapa? Karena kan kerjasama itu kan dimulai dengan silaturahmi yang baik kan. Nah, mungkin silaturahmi jelek, terus dia bisa kerjasama. Nah, mungkin itu. Tapi adalah mulai dari silaturahmi yang baik. Nah, silaturahmi baik yang tersebut adalah bisa rumah sakit ataupun kita bersama mencarikan media untuk kita bisa melakukan aktivitas untuk meningkatkan silaturahmi ini. Karena dengan silaturahmi itulah dasar atau mulainya kita bisa melakukan kolaborasi. Coba aja kalau kita tidak bertegur sapa bidan sama bidan tidak bertegur sapa, misalnya kemudian jangankan bisa bekerja sama, bertemu aja tidak mau gitu kan. Nah, maka dari itu dimulai di sana. Artinya mulai dari diri sendiri, mengajak teman-teman, dan kemudian nanti kita berharap untuk menyampaikan kepada rumah sakit. Biasanya dengan rumah sakit itu bisa dibikinkan SOP-nya, SOP. Kalau seandainya orang hamil masuk ke rumah sakit, siapa yang memeriksa tensi misalnya, kalau itu sudah bersama itu. Nah, kalau dia masuk IGD, kemudian itu dilakukan perawatan. Kemudian kalau dia ada perlu perawatan yang berkaitan dengan kebidanan, kita minta bidan atau kita diundang. Jadi artinya kita melakukan itu secara bersama-sama. Mudah-mudahan dengan adanya perhatian daripada rumah sakitnya tentu akan menjadikan wahana ataupun media untuk bisa bersilaturahmi dan bisa berdiskusi atau tukar pikiran itu dapat terjadi dengan baik. Sehingga Sehingga IPC-nya itu dapat berjalan dengan baik di rumah sakit tersebut. Demikian.
Baik, terima kasih luar biasa Pak untuk jawabannya. Bahwa memang untuk mewujudkan IPC di rumah sakit itu, seperti yang Pak bilang di akhir, kita perlu mempererat dulu hubungan kita dengan orang lain, dengan kolega, apalagi dengan profesi lain, sehingga nanti ketika berhadapan atau ingin membentuk service excellent tersebut dengan silaturahmi yang baik, itu akan dapat terlaksana dengan baik pula. Baik, demikian Ibu Verina untuk jawabannya. Baik, kita lanjut ke pertanyaan selanjutnya Pak, dari Ibu Fatima. Bagaimana pasien bisa mengetahui pelayanan bidan yang excellence jika pasien tersebut pun bertanya akan proses sterilisasi alat, sedangkan di praktek tersebut tidak ditemukan alat untuk sterilisasi. Ini untuk keamanan pasien tersebut. Mungkin ini berkaitan dengan service excellent, Pak. Salah satunya mungkin ditemukan di masyarakat. Pasiennya juga bertanya akan hal-hal seperti ini. Bagaimana pendapat Pak?
Jadi begini, memang apa yang seperti yang kita katakan tadi, bahwasanya indikator untuk mengatakan service excellent itu kan sulit menentukannya ya. Sebenarnya yang kita pakai sekarang itu kan banyak berkaitan dengan kepuasan pasien. Ya, kalau kepuasan pasien kan itu sangat relatif juga, ya kan? Nanti kalau dia berada di dengan Bu Irma, dia enggak apa-apa lah katanya. Ya karena enak melihat Bu Irma aja, yang lain enggak dihitung lagi gitu kan. Sehingga kita mengatakan apakah itu sudah excellent? Enggak, tapi mesti ada standarisasi. Standarisasi itu mulai dari karena kita tidak membicarakan service excellent, tapi adalah standar SOP-nya. Jadi kalau proses SOP. Yang kedua adalah fasilitas SDM. Yang ketiga adalah sarana prasarana. Jadi ketiga komponen ini harus dipastikan itu tersedia memenuhi sesuai standarisasi. Nah, pertanyaan ini kan bagus kan nih. Bagaimana kita pasien itu bisa mengetahui ini pelayanan yang excellent atau tidak? Tentu kita harus memberikan pemahaman juga kepada pasien-pasien atau kepada masyarakat. Dan kita lihat di di YouTube ataupun di media sosial itu banyak sekali sekarang ya untuk menyampaikan memperlihatkan bagaimana standarisasi proses pelayanan tersebut. Yang paling banyak sekarang diketahui oleh pasien itu adalah berkaitan dengan informed choice-nya tadi. Ya, dia sudah tahu sekali bahwasanya haknya ini, kewajib ininya ini. Sehingga dia dengan demikian maka mereka akan bisa mengatakan, oh ini ibu bidannya begini. Nah, bagaimana kita bisa memberikan keyakinan kepada pasien? Itulah jawabannya dari pertanyaan ini. Keyakinan itu adalah begini. Itu kan pasien setiap dia masuk itu kan dia suatu pasien itu baru masuk itu semua pasien itu kan curiga itu saya lah. Coba aja kalau kita berobat kepada dokter yang pertama atau yang baru ataupun ibu-ibu, kalau ke sana berobat di mana? Nah, setiap tindakan itu sebetulnya pasien itu akan bertanya semua itu, tergantung tingkat pengetahuannya, ya kan? Tingkat pengetahuan. Kalau dia tidak punya pengetahuan betul, baru dia pasrah itu, ya kan? Nah, tapi pada dasarnya yang namanya manusia tetap dia menjadi perbandingan. Nah, maka dari itu karena adanya proses banding membanding ini, maka untuk menentukan service baik atau tidak itu tentu harus ada indikator gitu.
Ya.
Nah, indikator itu kalau di BPJS dia bikin sarana-prasarananya harus ini. Nah, kemudian SDM-nya harus ada bidan yang ini. Kalau seandainya untuk SOP-nya mana SOP-nya? Kalau ada nanti yang disuntik, kalau dia gatal-gatal, bagaimana cara pengobatannya? Kalau dia nanti untuk sterilisasi, dia bagaimana cara sterilisasinya? Apakah dikirim ke rumah sakit? Nah, itu nanti bagaimana pula dia mengelola sampah medisnya. Nah, jadi semua itu akan menjadi bagian daripada indikator-indikator yang bisa kita gunakan untuk menentukan oh ini servisnya excellent ataupun tidak. Nah, jadi banyak sebetulnya kriteria kita untuk menyatakan dia baik. Dari sisi pasiennya saja boleh juga ya. Nah, maka dari itu jawaban ini adalah bagaimana kita bisa meyakinkan pasien itu untuk bisa memahami ada loh ini gitu. Disterilkan ada, nah, ini alatnya. Nah, tapi kalau seandainya pasiennya dia memiliki pemahaman bagus, bahwasanya kalau di sini kita katakan oh di sini kan bersih, karena kan biasanya kan banding dengan dukun misalnya kan. Kalau dukun kan ibu nanti ininya sudah berkarat, ini sudah begini, dan di sini kan steril. Nah, dia tanya nanti, ini kalau sterilisasi di mana di steril? Kalau dia pengetahuan itu, ya kan? Nah, tapi kalau tidak, ya dia diam aja itu, ya udah tempatnya bersih dibandingkan dukun ya sini aja gitu. Nah, sehingga apa sehingga kita bisa katakan bahasanya bagaimana upaya untuk menjadikan ini? Ya jawabannya adalah sesuaikan standarisasi yang kita miliki, kalau klinik yang kita miliki terhadap standarisasi yang sudah digariskan oleh undang-undang. Ya, itu barangkali jawabannya, Bu Fatimah. Ya.
Baik, terima kasih Pak, luar biasa. Demikian Bu Fatimah jawaban dari Dr. Afriwardi terkait Service of Excellence dalam pelayanan kebidanan. Izin Pak untuk materi kita. Izin dari peserta apa ada lagi pertanyaan? Silahkan. Masih tersisa waktu sekitar 3 menit. Apabila tidak ada, saya izin menyimpulkan bahwa tadi untuk pelaksanaan interprofessional collaboration dalam rangka mewujudkan Service of Excellence pelayanan kebidanan itu tadi bisa kita gunakan filosofi sepeda, bahwa memang pelayanan kebidanan itu tidak bisa bekerja sendiri dan membutuhkan memang tenaga profesi lain dalam rangka mewujudkan service yang excellent. Salah satu dari model praktek bidan juga menyarankan bidan untuk melakukan partnership baik dengan pasien maupun dengan tenaga kesehatan lainnya sesuai dengan bidang masing-masing. Untuk mewujudkan service of excellence, di sini kita memiliki beberapa indikator. Salah satunya adalah SOP, kemudian ada sumber daya manusia, kemudian ada sarana prasarana yang mendukung. Demikian untuk kesimpulan pertemuan kita pada sore hari ini. Baik, terima kasih banyak Pak Afriwardi untuk materinya yang sangat luar biasa. Saya pribadi dan para audiens saya rasa juga mendapatkan insight yang baru terkait interprofessional collaboration. Saya sebagai moderator mohon maaf apabila ada kesalahan dalam penyampaian. Terima kasih banyak atas atensinya. Saya mohon undur diri. Wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Kembali ke MC. Terima kasih banyak Pak Dekan.
Ya, sama-sama.
Okay. We would like to thank our moderators, Ibu Mirani, as well as the excellent speaker in the session today. Thank you very much for the very enlightenment presentation from Sir Afriwardi. Hopefully,
Okay, thank you. Good afternoon.
hopefully
Yes.
it could boost our insights, yes, sir, about the importance of collaboration, not only with our colleagues, but also others' probation in order to increase better outcomes for mother and child.
Okay.
Okay,
Thanks.
now we will begin the last session of our conference today. The keynote speaker for this session is Professor Dr. Hardisman, MHID, Dr. PH, from Andalas University, which is he is a Vice Dean of Medical Faculty of Andalas University, with the topic of the importance of evidence-based practice for midwives. This last discussion will lead by Bu Ulfa Faralisa, SSTM Cap, as moderator. But first, I would like to share her CV. So, as you can see in the screen, that Ibu Ulfa is actually the assistant ahli, and her right now she is a lecturer in Andalas University in undergraduate program, and in her undergraduate program in midwifery was in Poltekkes Kemenkes Yogyakarta in 2009 until 2010, and then she continued to postgraduate in University of Pajajaran in 2012 until 2015. And then she, like you can see here, in the last 5 years, she had a lot of research and publication. Like it's also with the several funding, and she also have lots of community services. Like recently in 2019, there's a few of it, like giving care, a basic care to the reproductive health for fertilized women in Car-Free Day. And as we can see here also, she is published lots of article in the journal with a nice accreditation, and yeah, so on. I think there's a lot of her track record that I think I could say. I couldn't give one by one, but however, we will greet our very excellent moderator. Hello, Bulfa.
Hello, Mrs. Hani.
Hello, Bulfa. How are you today?
I'm fine.
Okay, even though we are in the last session, but I think you still look fresh and ready to lead this session. Okay, I will give the screen to you, and also time is yours.
Thank you, Miss Hani. Good afternoon. Hello, everybody. Assalamualaikum warahmatullahi wabarakatuh. Maybe I will talking in Indonesia because all of participant is Indonesia. Baik, ini merupakan topik terakhir kita, tetapi ini tidak kalah menarik ya dengan topik kita, yaitu the importance of evidence-based practice for midwives. Di mana di sini narasumber kita juga sangat luar biasa, yaitu ada Bapak Prof. Hardisman. Mungkin kita undang terlebih dahulu Bapak Prof. Hardisman.
Assalamualaikum, Bu Urfa.
Assalamualaikum, Pak.
Semuanya.
Selamat sore, Pak.
Alhamdulillah, selamat sore.
Baik, Pak. Sebelumnya izinkan kita memperkenalkan diri dulu narasumber kita sore ini. Nama lengkap beliau adalah Prof. Dr. Hardisman, MHD, PhD, Dr. PH. Kemudian pendidikan beliau telah menempuh sarjana kedokteran dan profesi dokter di Universitas Andalas, yaitu 2021 dan 2023. Kemudian beliau melanjutkan Master of Health International Development, School of Medicine, Flinders University, Australia pada tahun 2008. Dan beliau juga menamatkan program Doctor of Public Health, School of Medicine, Flinders University, Australia pada tahun 2012. Luar biasa ya Pak pendidikannya. Kemudian beliau juga aktif setelah menyelesaikan program doktornya, postdoctoral fellowship, dan kualifikasi profesional. Salah satunya yaitu pada tahun 2014 mengikuti short fellowship Healthcare Leadership Harvard School of Public Health. Kemudian yang terakhir pada tahun 2021 di sini ada Fellow of Royal Society of Public Health di Inggris, UK. Dan publikasi beliau tidak diragukan lagi, sangat banyak sekali ya, bahkan lebih dari 20 publikasi. Di sini ada lebih dari 20 buku dalam bidang kebijakan kesehatan, etika, metodologi riset statistik, serta publikasi di jurnal internasional, nasional, dan media massa. Di antara publikasi dapat dilihat di profil Orchids, Scopus, Google Scholar, dan Sinta. Beliau sekarang merupakan profesor atau guru besar ilmu kesehatan masyarakat dan kedokteran komunitas Fakultas Kedokteran Universitas Andalas, dan juga beliau menjabat sebagai wakil dekan bidang umum dan sumber daya FK UNAND pada tahun 2022 sampai 2024. Sebelumnya beliau menjabat sebagai wakil dekan bidang kemahasiswaan dan kerjasama FK UNAND 2021 sampai 2022. Beliau juga menjabat sebagai sekretaris program studi S3 Kesehatan Masyarakat FK UNAND pada tahun 2019-2021 dan juga sebagai ketua program studi S2 Kesehatan Masyarakat FK UNAND pada tahun 2014-2019. Beliau juga aktif sebagai konsultan dan kegiatan eksternal, yaitu salah satunya adjunct senior lecturer di Flinders University Australia 2015 sampai sekarang. Kemudian Certified International Trainer, Analisis Data Kualitatif, MAXKIDA. Kemudian Certified International Trainer, Analisis Data Kualitatif dengan Atlas. Baik, luar biasa sekali Bapak di usia yang sangat muda sudah bisa menyandang guru besar. Mudah-mudahan ini bisa menular ke saya dan teman-teman audiens sekalian. Baik, Bapak, kita materi hari ini sampai jam 5, di mana di sini juga sudah termasuk diskusi dan tanya jawab. Kepada Bapak, saya persilahkan, Pak.
Baik, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Terima kasih, Bu Ulfa. Selamat sore semuanya. Selalu semangat. Mudah-mudahan sore ini saya tidak menambah capeknya, tapi juga menambah semangat untuk sebagai praktisi dan profesi bidansa.
Alhamdulillah selalu semangat, Pak.
Selalu semangat, oke. Baik, izinkan saya share screen. It's up to the audience. If you speak in English, that's fine. If you speak Indonesia, that's okay. If you speak Arabic, it's okay too. That's fine, okay. Okay. إذا نحن نريد أن نتكلم باللغة العربية هذا طيب. إذا نريد أن نتكلم بالإنجليزية صحيح. Okay, fine. Sebagai intermezzo biar nggak ngantuk nih sore-sore kan ya. Baik. Sekarang kita bicara tentang evidence based midwifery. Apa kepentingannya, nanti bagaimana mempraktekannya, di mana posisinya, demikian ya. Tentunya ini tidak kalah pentingnya dari materi-materi yang sangat bagus, mulai dari, saya pikir pertama adalah Andrea Regelson dari New Zealand, kemudian ada beberapa pembicara lain dari IB, dari IK, dan lain-lain. Nah, apabila bagaimana kita meramu tersebut, ada sesuatu yang kita mesti terapkan disebut dengan evidence-based policy in midwifery atau evidence-based practice in midwifery. Dan dari tataran praktis yang memang mesti kita lakukan terkait dengan hal ini. Apa yang kita perlu bicarakan hari ini adalah pertama tentang mengenal evidence dan bagaimana kita membaca data. Terutama nanti kita contoh-contohkan lah, karena yang jelas saya tidak bidan ya Bu Ulfa ya. Tentu insight saya tentang profesi bidan akan berbeda dengan bidan yang berbicara. Ya. Nah, tetapi paling tidak saya sejak kecil pasti dekat dengan bidan, lahir dengan bidan ya, lahir ditolong bidan jelas ya, tidak dengan SPOG. Kemudian setelah besar banyak yang bidan ya, mertua saya bidan, kemudian adik ada bidan gitu ya. Nah, jadi cukup banyak berinteraksi dengan bidan. Nah, sehingga nanti meskipun demikian, insight saya memahami tentang profesi dan tentu akan berbeda dengan bagaimana bidan berbicara. Tapi saya akan coba bagaimana kita mengaitkan, mengerti tentang evidence dan membaca data sebagai seorang praktisi kesehatan, terutama dengan bidan. Kemudian, bagaimana kita melihat level scientific evidence? Apakah memang iya selalu meta-analisis dan systematic review itu menjadi hal yang utama bagi kita? Kita hanya melihat angka dan angka. Nah, apakah mentang-mentang nanti saya sebagai orang yang mengajarkan metodologi riset, apakah angka itu selalu yang juara? Nah, apakah memang demikian? Nah, tentu tidak juga. Nanti kita lihat bagaimana sesungguhnya kita bisa membaca data. Dan kemudian bagaimana menerapkan evidence itu kalau memang sudah kita yakini itu benar, bagaimana menariknya kepada praktis? Itu jauh lebih penting juga. Karena data itu fakta, tapi fakta tidak bicara di ruang kosong. Fakta dan data itu berbicara dalam konteks yang utuh. Dan kemudian kita praktekkan bagaimana pula gitu. Nah, itu yang mudah-mudahan kita bisa berdiskusi hari ini. Mudah-mudahan saya tidak terlalu lama, sampai jam 5 waktunya dengan diskusi. Kalau bisa saya 10 menit, bagus sekali, 15 menit, mungkin sekitar itu mudah-mudahan. Oke. Apa itu evidence? Secara sederhana kita kan bukti, proof. Gitu. Nah, proof yang bagaimana, evidence itu bukti yang seperti apa? What kind of the evidence? Nah, evidence tetap beranjak dari fakta. Berarti ada kontennya di situ. Maka secara saintifik ya nanti kita mesti lihat datanya seperti apa. Itulah makna utama. Nah, bagaimana data itu terjadi itu mesti dilihat lagi ya. Jelas pertama evidence dibuktikan dengan data. Apakah evidence itu benar, maka terkait dengan bagaimana data itu diambil. Kan begitu. Jadi kalau kita ingin mengetahui, oh benar enggak ini, datanya seperti apa? Lalu kita lihat, apakah evidence ini bisa baik atau bagus atau seperti apa nanti bisa digunakan, maka kita terkait dengan bagaimana data itu diperoleh. Nah, maka secara kuantitatif nanti selanjutnya kita bisa bicara juga bahwa bagaimana secara metodologis dia diambil dan seterusnya. Kemudian setelah nanti itu kita ketahui, maka data tidak bicara dalam ruang kosong. Data mesti dilihat secara konteksnya. Konteks data itu hadir seperti apa? Maka itu menjadi sesuatu yang sangat krusial juga. Nah, data yang sama-sama, misalnya gini, angka kematian ibu 356 tahun pada SDKI sebelumnya gitu. Konteksnya seperti apa? Oh, semua secara konteks dia dianggap tinggi, tidak berhasil MDGs sebelumnya gitu ya. Nah, kalau sekarang kita bicara pokoknya di Supas 306. Konteksnya seperti apa? Konteksnya dianggap berhasil atau turun atau pemeriksaan yang benar, terserah bagaimana kita interpretasi. Nah, konteksnya dianggap aki kita turun dari Supas setelahnya, aki kita menurun. Karena konteksnya kita melihat pada pemeriksaan sebelumnya, pada survei sebelumnya 359. Nah, lalu kalau konteksnya diganti, maka evidennya data tadi bicara lain. Oh, ternyata sudah sekian lama kita melakukan program, ternyata eviden kita terbukti juga aki kita tiap 300 tetap tinggi dong. Jadi angka 300 tidak bermakna apa-apa. Angka 300 menunjukkan kontennya sama, datanya sama, tambah 306, tapi dia secara konteks dia bisa akan berbeda kalau dilihat secara delivery-nya berbeda. Apa delivery-nya? Delivery-nya diganti narasinya, mengatakan angka kematian ibu 306 per 100.000 kelahiran hidup, diganti narasinya. Bagaimana kita menciptakan narasi metode delivery-nya dengan konteks yang berbeda bahwa ternyata setelah sekian tahun programnya Indonesia tidak berhasil, angkanya tetap tinggi di atas 300. Jadi evidennya yang dengan konten atau fakta eviden yang sama dengan delivery yang berbeda, maka eviden menjadi berbeda. Itu yang mau saya sampaikan. Nanti di dalam kenyataan sehari-hari kita melihat data juga demikian. Bagaimana data fakta itu di delivery dengan konteks yang sesuai, maka dia menjadi eviden yang berbeda. Kesimpulannya yang pada slide ini yang saya katakan, angka kematian ibu kalau hari ini kita periksa umpamanya ya 250, kita temukan 250 per 100.000 kelahiran hidup, maka dia menjadi eviden bagi seseorang dengan konteks yang berbeda, dengan metode delivery yang berbeda, menjadi eviden bahwa ternyata pemerintah Indonesia tidak mampu menurunkan angka kematian ibu, padahal bidannya sudah banyak, SPOG sudah banyak, dan seterusnya. Tetapi dengan fakta dan data yang sama, dengan konteksnya yang dinarasikan, di delivery yang berbeda, dia menjadi berbeda. Bahwa ternyata hari ini pemerintah atau Kementerian Kesehatan berhasil menurunkan angka kematian ibu yang sebelumnya di 359 berhasil turun menjadi 250 per 100.000 kelahiran hidup. Di situ ditunjukkan keberhasilan. Maka dia menjadi evidence sebagai bentuk keberhasilan. Itu baru data deskriptif. Sehingga evidence itu sangat tergantung dengan fakta dan bagaimana dia delivery, maka artinya dia tergantung juga bagaimana dia diinterpretasi data itu. Inilah yang saya sebut tadi, data, jadi evidence bukan hanya sekedar data angka. Evidence adalah fakta data yang diinterpretasi sesuai konteks dan bagaimana dia delivery. Sehingga bagaimana dia diadopsi dan diterima. Tergantung dari fakta, data, dan interpretasinya. Ini agak filosofi statistik, tapi saya pikir dengan contoh tadi kawan-kawan bisa memaknai. Sama saja, apakah angka anak kita dapat, maunya ibu semua yang punya anak di rumah yang masih SD, SMP, apakah dia dapat 80 itu bagus atau baik? Belum tentu. Bagaimana konteksnya? Selama ini dia selalu dapat 100, berarti hari ini nilainya jatuh. Faktanya sama. Jadi angka 80 menjadi evidence bahwa dia sudah malas-malas belajar. Tapi kalau beda lagi, anak kita itu selama ini 60, 65, 75, hari ini dia dapat 80, faktanya sama, dia menjadi evidence bahwa dia telah menunjukkan keberhasilan. Itu poin utamanya. Jadi apa itu evidence? Evidence adalah fakta yang didelivery dan diinterpretasi sesuai konteks. Nah, selanjutnya bagaimana kita membaca data itu, terutama data-data kesehatan. Saya tidak akan terlalu dalam ke sini, tapi yang paling penting adalah kita mesti melihat data secara 3 hal utama. Pertama, objektif. Kedua, komprehensif. Ketiga, open-minded. Kalau tidak dengan demikian, maka kita akan terjebak nanti yang disebut dengan logical fallacy. Ini bahaya dalam interpretasi. Apalagi kalau kawan-kawan lagi S3, ya, penelitian dapat grant, gitu, disertasi terutama untuk S3. Maka kalau kita tidak melihat data secara objektif, komprehensif, dan open-minded, maka kita akan salah mendelivery datanya karena konteksnya tidak seperti itu. Contoh, nah ini gambar ini saya pikir merepresentasikan bagi kita bagaimana kita mesti objektif. Ya, jangan-jangan data kita itu kucing, kita melihatnya seperti singa. Jangan-jangan kita sudah kurus, tapi melihat cermin lalu merasa tidak kurus terus atau sebaliknya, gitu. Nah, membaca data mirip dengan kita melihat di kaca. Jangan sampai apa yang disebut dengan terjadinya logical fallacy. Apa yang memungkinkan ketika melihat ada data disampaikan, terutama data-data kebidanan, data ibu hamil kah, data di antenatal kah, data neonatal kah, maka kita mesti melihat secara objektif. Data berbicara sendirinya sesuai dengan konteksnya. Artinya data diinterpretasi bukan dengan keinginan kita. Itu prinsip objektif. Apa yang memungkinkan kita tidak objektif secara metodologis? Singkat saja, pertama yang disebut dengan ini bahasa anehnya nih, ignorance fallacy. Artinya kita mengasumsikan bahwa data itu kita punya preasumtif tanpa pengetahuan yang kuat, tanpa data yang cukup terhadap data tersebut juga, tidak punya pengetahuan dan lain-lain. Ini mirip-mirip kalau kita bicara dengan COVID-19 ya. Mengapa banyak orang menolak? Karena yang pertama ini, dia mengasumsikan sesuai apa ya, sesuai dengan dia pikirkan. Maka muncullah macam-macam distorsi, hoax dan lain-lain. Karena menurutnya dia memang begitu, padahal dia tidak tahu apa-apa gitu. Nah, kita melihat data juga demikian. Kita umpamanya ada laporan tentang antenatal care di daerah A. Nah, kalau kita mengasumsikan jangan daerah A ini persis seperti daerah B, C, D yang kita lihat, maka kita akan menyimpulkan salah. Dan biasanya orang sering terjebak begitu. Karena dia ada preasumtif. Kita tidak punya pengetahuan cukup tentang konteks daerah A, tapi kita asumsikan karena kita sudah melihat banyak yang lain tidak seperti itu. Maka selanjutnya muncul yang disebut dengan observer paradox, egosentris dalam berpendapat. Pokoknya menurut saya begini gitu. Nah, ini sering terjadi kalau penelitian-penelitian yang berbau teologis tentang kesehatan. Bicara datanya, bicara lain, kita terjebak dalam hal jangan sampai deh nanti hasilnya nih membantah konsep-konsep agama yang saya ajukan. Sebenarnya kan nggak begitu. Kalau ternyata tidak sesuai, kita lihat apakah ada di samplingnya, metode sampling yang tidak sesuai, dan seterusnya. Begitu juga kita membaca data orang. Apa tidak sesuai ya? Mengapa dia tidak sesuai? Oh, ternyata jumlah sampelnya cukup, penyelesaiannya benar, tapi konteks yang dimaksud itu berbeda dong. Nah, kalau kita lihat dengan situasi COVID kan juga sama. Begitu orang sudah LNC fallacy, dia masuk ke observer paradox. Yang menurut dia memang harus mesti begitu gitu. Apalagi dia pada posisi yang bisa menginstruksikan orang itu. Nah, bahaya lagi kalau dia egosentris, bisa dari LNC fallacy langsung ke strawman atau dari observer paradox ke strawman. Nah, dia mencoba mengalih-alihkan. Nah, kalau kita melihat data, kita mesti lihat data itu dari pangkal sampai ke ujung atau dari ujung ke pangkalnya pada konteks yang sama. Kalaupun ada berbeda, maka dijelaskan pada konteks yang berbeda. Tidak seperti kita menginterpretasi strawman itu artinya seperti pipet dalam bahasa Minang. Kalau dalam bahasa Indonesianya sedotan di dalam air ya. Sedotan di dalam air kalau kita masukkan itu kan akan berbeda pencerminannya, arahnya. Maka kalau kita menginterpretasi dalam konteks ruang tanpa air, padahal sedotan itu sudah dalam air, maka akan distorsi dia. Nah, begitu juga lah kita data berbicara sehari-hari ke kita. Kalau ada data atau kita lihat, nah kita menginterpretasi mesti sesuai konteksnya. Kalau tidak, kita menginterpretasi sesuai dengan kemauan kita, masuk ke observer paradox, atau kita bawa sendiri sesuai dengan kemauan kita, ya akhirnya distorsi. Nah, yang ketiga kemungkinan bagaimana fallacy itu muncul. Ini cara membaca data, belum masuk contoh-contoh ya. False justifikasi. Nah, false justifikasi mungkin kalau dalam keseharian kita penelitian kah, kita membaca laporan kah, ya. Bisa appeal to false authority. Jadi kalau seperti yang ekstrim contohnya adalah COVID ya. Begitu dia kata gurunya begitu, dia mesti ikut juga. Padahal tidak tahu gurunya itu memang ahli COVID kan enggak gitu. Oh, kata Pak Lurah demikian, kata kepala sukunya demikian. Nah, apalagi kalau appeal to tradition and old belief ya. Jadi dan dia meyakini bahwa kalau sudah begini ini ada konspirasi nih, udah terus lanjut begitu. Nah, sehari-hari juga mirip gitu. Kalau kita melihat data kebidanan kita disajikan ke kita, bagaimana kita mesti objektif melihat data berbicara sendirinya dengan konteksnya dia sendiri. Tidak sesuai dengan kemauan kita interpretasinya. Nah, kalau ini bisa dilakukan, maka itulah yang disebut dengan membaca data secara objektif. Datanya kucing memang kucing, bukan kemauan kita karena kita ingin itu tuh adalah singa gitu. Kemudian komprehensif. Ini sederhana. Kelihatannya ya, tetapi kita sering tidak melihat data secara komprehensif. Kita terjebak dalam satu titik sesuai dengan ukuran-ukuran yang sudah ditetapkan, lalu lupa melihat yang lain. Jadi evidence, ya, nanti kan evidence midwifery ya. Evidence itu tidak hanya angka-angka yang telah dirumuskan Lalu itu yang menjadi kesimpulannya. Seperti ini, ya seperti masyarakat orang-orang buta memegang gajah ya, tentu dia akan deskripsikan gajah sesuai dengan hasil ini sudah biasa. Disimpulkannya. Tetapi ada yang lebih berbahaya. Ya. Kita terjebak ketika kita sudah belajar metodologi, maka kita mengatakan bahwa, nah itulah kesimpulannya. Saya yang mengajarkan statistik dan metodologi kepada mahasiswa juga, kepada kawan-kawan, pada pelatihan, statistik atau statistik yang bermakna tidaklah menunjukkan segalanya. Jadi nilai P bermakna itu tidak menunjukkan semuanya. P itu hanya menunjukkan bahwa ada kemaknaan hubungannya, tapi apakah semuanya yang ditunjukkannya? Tidak. Jadi kalau kita tidak melihat data secara komprehensif, kita hanya akan terjebak pada nilai P-nya. Oh, dia bermakna. Contoh ini. Umpamanya ini ada penelitian melihat korelasi, hubungan korelatif antara umur wanita usia subur sampai menopause dengan tekanan darahnya. Lalu kita lihat, oh ternyata P-nya bermakna sekali 0,003 dengan R 0,28, berarti korelasinya positif, sedang ya, peningkatan umur terjadi peningkatan tekanan darah. Lalu kita akan menginterpretasi, oke deh, berarti yang muda-muda kita tidak perlu khawatir. Kan itu artinya nih. Karena yang tingkat peningkatan darah itu terjadi pada peningkatan tua. Iya. Tetapi data tidak bicara itu. Evidence tidak hanya signifikan statistik. Nah, ini coba kalau kita lihat agregat datanya dengan scatter plot. Nah, panah-panah di atas di bawah sengaja saya tunjukkan. Kita kan bicara ini nih. Statistik hanya bicara line, kecenderungan, bermakna iya. R-nya koefisien korelasinya sedang, positif. Peningkatan usia terjadi peningkatan tekanan darah. Jadi yang tua lebih cenderung hipertensi, iya. Tapi kita lupa. Evidence based tidak hanya angka bermakna statistik. Jadi, begitu juga nanti kalau kita lihat data midwifery, pastikan lihat agregat datanya. Kalau di sini contoh, kita lihat ternyata ada kemungkinan yang muda-muda itu ya hipertensi, ini contohnya. Maka kita menginterpretasinya begini. Evidence menunjukkan bahwa ada kecenderungan peningkatan darah dengan peningkatan umur. Tapi juga ada bukti bahwa pada umur-umur muda dimungkinkan terjadi hipertensi. Maka ini yang perlu dieksplorasi. Kalau dalam penelitian ini yang perlu dieksplorasi kan. Dan membaca evidence juga demikian. Berarti ini ada sesuatu nih. Kalau ada yang begini justru ini yang perlu kita perhatikan. Oh jangan-jangan ini menjadi perhatian. Mungkin karena tidak ada umur. Wanita yang seperti apa sih yang bisa hipertensi pada usia 20-an, 30-an gitu. Ini contohnya kan. Nah, dan sebaliknya ada yang sudah umur 60-an menopause juga normal-normal aja tensinya. Ini mengapa ya bisa begini? Berarti ini menjadi evidence untuk apa? Evidence untuk agar orang kalau terjadi peningkatan umur dia tidak hipertensi. Buktinya apa? Buktinya data kita menunjukkan ada orang yang sudah berumur lanjut tekanan darahnya normal. Inilah yang evidence untuk apa? Untuk kita untuk kita melakukan pencegahan di masa datang. Ini menjadi pelajaran bermakna, ini berharga sekali untuk preventif. Ini menjadi yang muda hipertensi ini juga menjadi pelajaran berharga apa? Agar jangan terjebak nanti yang muda-muda juga begini. Berarti kita sudah tahu dua clue, data menunjukkan seperti ini. Jadi poin saya adalah melihat data secara komprehensif, artinya melihat data-data agregat yang jauh lebih penting menjadi apa? Menjadi nilai tambah dalam kita melakukan preventif kah ataupun bentuk pencegahan lain kah, baik nilai yang positif ataupun yang negatif, dua-duanya menjadi penting. Nah, itulah yang saya sebut tadi, jangan seperti orang memegang gajah gitu. Meskipun itu sederhana, tapi kadang-kala kita terjebak dengan perilaku yang sama. Oke. Contoh lain. Nah, ini sering juga nih mahasiswa. Kalau saya suruh interpretasi juga sama. Hubungan proporsi melihat terjadinya HPP dengan ibu-ibu risiko tinggi, ya. Ada yang risiko tinggi yang resti, ada yang tidak resti. Ternyata yang risiko tinggi yang tidak resti itu ada pasiennya kita temukan di cross-seksional 41, yang resti 69, yang tidak 41. Nah, dari yang risiko tinggi ternyata HPP 23 orang. Ya, tidak sampai separuh. Nah, ternyata dari yang tidak resti ada juga terjadi 6 orang. Nah, biasanya kita setelah kita lakukan analisis statistik, kita tidak lihat data itu lagi. Kita terjebak di yang saya kasih kurung ini, yang biru. Dia bermakna 0,031. Kemudian rasionya 2,9. Artinya kalau dia ibu-ibu yang risiko tinggi berisiko 2,9 kali terjadinya HPP. Sudah selesai. Lalu kita cerita macam-macam di situ. Tapi yakinlah, kesimpulan statistik tidak bicara semuanya. Evidence tidak hanya disampaikan oleh data statistik ini. Nah, apa yang kita observe? Nah, dan untuk kawan-kawan yang melakukan penelitian ini perlu dibahas agregat datanya. Kalau yang pada yes dan yes di maternal risk, kemudian terjadi HPP, HPP-nya udah jelas tuh, udah clear kita. Kemudian yang tidak ada clear juga. Tetapi pertanyaannya, mengapa ya, terutama yang 6, dia tidak risiko tinggi, tapi terjadi HPP. Pada siapa itu terjadi? Kalau kita tidak melihat itu, maka pembahasan dan kalau kita menulis sendiri penelitian kita juga akan terjebak dalam menjelaskan secara teoritis. Ya, teorinya benar, hasilnya juga benar. Orang yang risiko tinggi dia HPP, yang enggak gitu. Bermakna ya jelas. Kemudian rasionya 3 kali. Pertanyaannya, ternyata ada loh yang tidak risiko tinggi, yang HPP. Siapa mereka? Inilah data. Nah, jadi evidence ditunjukkan oleh agregat data semuanya. Dan agregat data itu menjadi penting untuk menjadi evidence. Kalau dalam midwifery nanti jangan deh orangnya tidak resti, tapi nanti HPP juga. Mengapa? Oh, berarti mungkin ada ini. Ini kan penting sebagai evidence. Termasuk juga dia memang resti. Ini bagus nih. Bahkan lebih banyak dia resti, tetapi tidak HPP kan. Artinya apa? Bagaimana orang yang resti, banyak restinya sedih karena dia pendek atau yang lain lah ya. Tapi tidak dari mungkin ada anemia dan seterusnya ya. HPP tidak terjadi. Apa yang perlu dilakukan untuk itu? Nah, itu evidence. Jadi, poin kedua, membaca data mesti komprehensif, tidak hanya melihat statistiknya. Tidak hanya melihat ininya. Evidence lahir dari situ. Mesti tadi objektif, yang kedua, melihat agregat. Jangan sampai ada yang observe. Open-minded. Ya. Ini juga penting. Ketika kita melihat data, ya, melihat data, kita lihat apakah data itu memang demikian adanya. Nah, ketika disampaikan, terutama laporan-laporan yang tertulis ya, apakah metodenya, apakah dari sisi interpretasinya, ya, mungkin jika data itu diinterpretasi berbeda, mungkin tidak sesuai dengan yang kita interpretasikan. Kita lihat di sudut pandang berbeda. Nah, menerima interpretasi berbeda itu penting untuk melihat, terutama lagi kalau sifatnya mungkin data yang belum dipublikasi, mungkinnya di dinas kesehatan, di tempat kerja atau di mana ya, kita melihat data bersama. Oh, menurut kita, oh ini begini nih. Kalau ibunya kondisi ini, nanti ibunya seperti ini. Nah, ternyata kita terjebak tidak komprehensif, interpretasi kita salah. Nah, kita tidak memaksakan kehendak, wah ini mesti 4. Padahal kalau dilihat ternyata hanya cuma 3 ya. Oke. Baik. Kemudian selanjutnya kita lihat data dalam yang kan bisa gunakan dalam praktek kebidanan ya. Data evidence yang seperti apa? Tadi apa itu evidence sudah bisa disimpulkan dari yang saya sampaikan di awal. Kita juga sudah punya knowledge yang cukup, saya pikir sebelumnya, bahwa evidence adalah data yang dipresentasikan sesuai dengan konteksnya dan delivery dan diinterpretasi sesuai dengan konteksnya juga. Nah, sehingga dia menjadi evidence untuk kita sebagai praktisi ya dan akademisi itu termasuk juga. Nah, data yang bisa digunakan di dalam sebagai evidence base untuk praktek midwifery atau perubahan berpikir, perubahan protap, tata kerja dan lain tentu adalah evidence yang scientific. Apakah itu published paper terutama, ya, termasuk unpublished yang memenuhi syarat. Kemudian baru beranjak kepada evidence yang non empiris yang nilainya sangat rendah dari pengalaman dan testimoni. Mengapa pengalaman bisa menunjang? Bisa. Tapi pengalaman satu orang mungkin akan menjadi bias, ternyata kita lupa dengan konteksnya. Apalagi testimoni. Ya. Apakah testimoni bisa jadi evidence? Kalau dia tidak kalau dia menuntut yang scientific paper dan published paper itu sangat bagus. Tapi kalau testimoni saja, apalagi dia bertentangan dengan experience orang, bertentangan lagi dengan published paper yang scientific, itu menjadi masalah. Mengapa testimoni tidak laku dalam tanda petik di dunia kedokteran dan kesehatan barat yang kita anut saat ini? Misalnya ada 10 orang yang pakai testimoni, pengobatan A sangat bagus, testimoninya dari menteri, pejabat, dan seterusnya. Masalahnya, kita akan tanya, yang pernah melakukan pengobatan A itu berapa orang? Jangan-jangan ada 1000. Yang 990 lainnya kemana? Jangan-jangan ada 800 tidak berhasil, yang lainnya antara berhasil dan tidak, yang 10-nya berhasil, itu yang pakai testimoni. Kan di situ masalahnya. Maka testimoni tidak menjadi rujukan untuk sebagai evidence kita selama dia tidak dapat menunjang yang saintifik. Kemudian experience kita pribadi bisa digunakan, bisa juga digunakan kalau dia tidak juga bertentangan dengan yang empirical scientific evidence. Pertanyaannya bagaimana kalau scientific evidence-nya tidak ada? Tentu dia akan melompat kepada yang menjadi evidence sekarang adalah experience kita. Mungkin ibu-ibu semua yang sudah pengalaman jadi bidan lebih dari 25 tahun, ternyata saya tidak menemukan kajian-kajiannya. Nah, tentu experience menjadi evidence ketika itu. Tapi apakah bisa diterapkan di tempat lain? Tentu dulu perlu ada diskusi lebih lanjut dan seterusnya. Nah, ini yang paling sering di level scientific evidence. Nah, saya tidak akan berlama-lama di materi ini. Tentu pandangan expert saya bicara atau seseorang berbicara itu level bawah dari scientific evidence. Artinya tapi lebih tinggi dari pengalaman ya. Tetap jauh lebih tinggi dari testimoni. Jadi satu orang pakar menyampaikan hal yang tema atau topik yang sama itu jauh lebih dihargai dari 10 testimoni orang yang bukan ahlinya. Nah, satu pakar yang menyampaikan itu juga jauh lebih bermakna evidence-nya dibandingkan dari satu orang yang tidak pakar ya, yang memberikan keterangan menurut pengalaman. Tapi kalau itu bicara atas pengalamannya atau ibu-ibu semua dianggap expert karena sudah praktek sekian lama, maka ungkapan pengalamannya tadi kalau yang di sini berarti dia menjadi pengalamannya menjadi expert opinion. Levelnya masih paling bawah. Jadi Ibu Irma Hayati namanya mengungkapkan cerita pengalamannya itu bisa dianggap sebagai expert opini. Opini expert ya, opini pakar, opini ahli. Karena dia berpraktek, dia profesi sebagai bidan praktek sekian lama dan sudah levelnya di bawah. Karena perlu diuji lagi. Apakah umpamanya Ibu Restu Ayu dan Bu Ulfa juga mendapatkan pengalaman yang sama gitu. Ini kan perlu dibuktikan. Nah, di atas itu apa? Case series. Maka kalau bagaimana pengalaman-pengalaman pasien-pasien kita itu dibuktikan, dituliskan menjadi sebuah kasus serius. Nah, naiklah tingkatannya. Karena diuji secara bersama. Bu Ulfa kasusnya A, Bu Feni, Bu Restu juga menyampaikan kasus-kasus yang sama, bikin kasus serius, dia menjadi meningkat pasti. Nah, Tapi masih di bawah, tapi sudah lebih tinggi daripada Bu Ulfa sendiri yang berbicara sebagai expert. Di atas itu apa? Kita lakukan penelitian-penelitian sampai di selanjutnya kita melakukan eksperimen. Nah, semua laporan-laporan tadi diuji lagi. Kita sebutlah sebagai systematic review. Di atasnya kita lakukan systematic review sama meta-analisis hanya beda tipis ya. Nah, satu lagi di atasnya adalah dengan melakukan analisis statistik dari data yang kita lakukan systematic review. Kita sebut sebagai meta-analisis. Ini sudah biasa dan mungkin bisa dipelajari lebih lanjut dan kita terus belajar untuk hal ini ya. Oke. Pertanyaannya, bagaimana kita memilih eviden tadi? Bagaimana kita membacanya? Misalnya laporan penelitian yang belum systematic review ya, dia kan disebut sebagai levelnya sudah di atas expert opinion. Laporan dia sudah di atas case series. Maka apakah ini benar atau tidak? Maka apakah bisa dipraktekkan atau tidak nanti? Kita tetap yang disebut sebagai critical appraisal scientific evidence atau critical appraisal terhadap laporan tersebut dengan melihat apakah ada benar nggak konsisten antara masalah yang dia teliti dengan theoretical framework atau landasan teoritis yang dia gunakan. Jangan-jangan dia mau meneliti tentang kebijakan, ternyata yang dia gunakan, yang dia gali segala tentang perilaku ibunya. Padahal dia mau melihat bagaimana sih kebijakan pemerintah segala macam. Tentu tidak cocok. Atau sebaliknya, dia bicara tentang perilaku, bagaimana health belief model, tentang perilaku ibu nanti memanfaatkan antenatal care kunjungan K1 sampai K6-nya. Dia mau lihat kenapa ibu tidak mau segala macam. Ternyata dia bicara pas di pembahasan segala macam, dia lihat dia tidak bicara masalah perilaku orang memilih layanan yang mesti dipakai oleh teori perilaku belum teori Skinner, health belief model dan lain-lain kan di situ ranah dia berbicara. Tapi ternyata dia bicara, oh ini kebijakan pemerintah kurang sehingga masyarakat tidak mau. Ini kan salah framework sebenarnya. Dan itu bukan tidak jarang ya. Artinya kalau kita mau buka artikel-artikel publikasi, orang ada yang terjebak ke arah sana. Nah, kemudian yang paling penting kita lihat juga setelah dia bahas, benar dilihat dia menggunakan framework apa, ya tentu adalah metodenya. Dia gunakan apa? Yang ekstrim ya. Yang ekstrim yang mungkin tidak terjadi, contoh sederhana. Dia mau lihat seberapa besar kasus di sana. Tapi ternyata dia dilakukan penelitiannya case control yang tidak cocok. Kalau Anda mau cari kasus berapa sebesaran kasus, ya tentu dengan cross-sectional dan seterusnya. Nah, jika itu penelitian kuantitatif, kita lihat lagi sampelnya benar atau enggak. Ya, agar jangan interpretasi itu salah. Maka kalau kita bicara sampel, ada 3 hal ya. Jumlah sampel, sample size, kemudian cara pengambilan sampel, dan kriteria sampel. Dan ini mesti runut, jelas. Karena bisa, sampel saya sudah sesuai. Jumlahnya saya pakai rumus Lemeso, atau kita baca artikel 400 ya, dengan simpangan D-nya 5%, alfanya 5% juga. Udah benar. Itu baru sampelnya. Tapi cara ngambilnya benar nggak? Dia mau melihat umpamanya tentang pola perilaku ibu terhadap antenatal care di wilayah tersebut. Tapi ternyata dia di wilayah satu wilayah. Tapi dia lupa wilayah itu ada beberapa kelurahan yang tentunya tersebar. Dia ambil hanya di satu perumahan saja. Padahal dia mau inferensial untuk daerah tersebut. Tidak cocok juga, salah juga. Nah, apalagi kalau sudah melihatkan hubungan antara variabel dan seterusnya. Kalau untuk kualitatif tentu beda persoalan kita. Ya. Maka istilah sampel diganti menjadi partisipannya apakah appropriate, sesuai atau tidak, kemudian dia trustworthiness datanya sesuai atau tidak, apakah dia ada triangulasi sumbernya, apakah nanti untuk meyakinkan validitas dalam kualitatif tersebut trustworthiness ada dia juga melakukan prinsip-prinsip kualitatif yang lain gitu. Selain dari teknologi metode, ada juga teknologi sumber, kemudian dia interpretasi juga dengan kaidah-kaidah yang sama. Nah, tentu ini menjadi perhatian ketika kita menyimpulkan ini betul dan eviden ini bisa dimanfaatkan untuk keilmuan kita. tentu selanjutnya adalah suitable method data collection. Nah, dia mengambil datanya benar nih yang saya sebut tadi. Tidak hanya sampel jumlahnya, tapi juga bagaimana mengambilnya. Gitu. Ya, secara ekstrim ya. Semua ibu-ibu di sini ternyata sudah patuh terhadap layanan antenatal care. Dia lupa. Ternyata dia komplek bidan di situ, ternyata keluarga-keluarga bidan semua gitu. Jadi ya patuh-patuh di situ gitu. Jadi ternyata dia disimpulkan tidak terdapat hubungan antara kepatuhan. Nah, jomplang-jomplang lagi ya. Ternyata karena di situ patuh-patuh semua gitu ya. Terhadap masalah-masalah kebidanan dan seterusnya. Oke. Nah, tentu yang terakhir setelah bagaimana kita membaca data, lalu bagaimana kita melihat tingkatan evidence-nya, mana yang akan bisa kita gunakan, tentu nanti bagaimana kita bisa menggunakannya dalam keilmuan kebidanan, dan termasuk juga bagaimana kita menggunakannya, how to use the evidence into practice, that's the most important. Nah, pertama, kita melihat apakah evidence itu sudah valid dan reliable sesuai dengan tahapan-tahapan kita tadi. Ya. Kalau data kualitatif kita baca evidence itu secara kaidah-kaidah kualitatif, tersortir tidak dia? Ya. Terpenuhi tidak kaidah-kaidah triangulasi sumbernya atau metodenya atau appropriateness-nya? Nampak tidak ketika dia lakukan analisis, saturasi tidak datanya di situ? Itu kualitatif ya. Nah, ketika kita bicara tentang itu trustworthy, kalau kuantitatif beda lagi kan? Apakah valid, reliable datanya? Metodenya sesuai dengan yang dihasilkan. Secara ekstrim, umpamanya dia mau menyimpulkan dengan yang sangat kuat pemeriksaan hemoglobin, anemia tidak anemia. Ternyata dia periksa pakai HB Sahli, tidak cocok, tidak dipakai. Yang periksa juga diperiksa pada jam berapa? Jam 5, HB-nya HB Sahli. Itu mata udah kabur semua. Itu contoh ekstrim ya. Nah, hal-hal sederhana perlu diperhatikan. Itu juga misalnya pemeriksaan tekanan darah hipertensi. Valid nggak? Itu dilihat bagaimana dia memeriksa. Siapa yang memeriksa? Oh, memeriksa memang adalah bidan yang pengalaman. Tapi kapan dia periksa? Oh, ternyata dia periksa 2.000 orang per hari, 2 orang. Nah, ini tidak mungkin, tidak benar ini. Apa dia memang tunggu orang dulu habis berkunjung, habis dan seterusnya untuk baru diperiksa tekanan darahnya. Pantasan dapat hipertensi sampai 80% begitu. Nah, ini kan jadi masalah. Perlu dilihat apakah valid, reliable dengan kalau kita membaca data, membaca laporan, kita tahu bagaimana dan cara mereka melakukan koleksi datanya, pengumpulan datanya. Untuk kuantitatif dengan kaidah-kaidah kuantitatif, untuk ini juga. Nah, kalau sudah kita yakin datanya benar, sederhana, valid atau reliable atau trustworthy, maka kita bisa aplikasikan sesuai dengan konteks yang akan kita gunakan. Kuantitatif memang evidence based, data kuantitatif memang kita untuk gunanya adalah inferensial, tapi tetap kita aplikasikan sesuai dengan konteksnya. Kemudian terakhir yang sangat penting adalah apakah memang feasible untuk diadopsi. Ya. Ini tergantung terkait dengan metode-metode misalnya. Kajian-kajian terbaru dari siswa kita nih dengan lupa sebenarnya meneliti hal yang banyak tentang prenatal yoga, home birth atau water birth gitu. Nah, tentu kita ukur dari atas apakah yang dibaca itu valid reliable ya? Oh, valid. Appropriate enggak? Sesuai dengan konteks enggak? Nah, ini mulai bermasalah nih. Mengapa konteks home birth orang bisa di situ? Ternyata prasyarat terpenuhi. Apa prasyaratnya? Higienis sanitasi orang di New Zealand itu terpenuhi dong. Apalagi seandainya syarat-syarat terpenuhi, seandainya ada apa-apa, karena di Australia dan New Zealand, walaupun di rural area, tetap cepat nyampainya ke layanan rumah sakit. Di kita gitu. Nah, ini kan suitable content tidak jadi. Di visible adopsi misalnya dilihat di situ. Jadi evidence yang mantap, bahkan sudah valid reliable, belum tentu sesuai untuk diadopsi. Kenapa? Konten tidak sesuai. Nah, sederhana saja kan. Kalau kita mau adopsi home birth di kita, oh banyak persoalan. Dia tidak risiko tinggi, Pak. Bisa, iya. Nanti kalau terjadi apa-apa di rumahnya tuh bersih enggak? Nah, ini masalah nih. Kalau terjadi apa-apa, dekat enggak? enggak Pak, ya ini tambah masalah lagi. Akhirnya tidak bisa dilakukan, diadopsi hal demikian, meskipun syarat pertama terpenuhi. Tim Bapak Ibu, kalau ada Bapak yang hadir ya, dan Ibu-Ibu terutama, bidan semua, mungkin saya berbicara secara general, kembali yang saya sampaikan di awal, insight saya tentang bidan, bidan tentu akan berbeda dengan bidan yang akan menyampaikan, kalau bidan menyampaikan. Karena saya bukan praktek sebagai bidan, tapi saya coba mencontohkan apa-apa yang mungkin dan bisa dikaitkan, bagaimana menggunakan evidence base di dalam midwifery, mulai dari teori ke aspeknya sampai kepada visible adopsi dari evidence base tersebut. Mungkin demikian sebagai bahan diskusi kita. Kalau ada yang mau diskusikan, terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Sangat menarik sekali materi kita hari ini. Enak sekali didengar, Pak. Di sini sudah ada beberapa pertanyaan, Pak. Izin saya membacakan. Yang pertama sekali ada dari Ibu Elda Yusefni. Pertanyaannya adalah, Prof, mohon penjelasan maksud dari crude OR dan adjusting OR pada suatu kasus kebidanan.
Ganggu, Pak. Maaf, sinyal saya terganggu. Bentar ya. Sekarang lagi patah-patah di sini.
Baik, Prof.
Ya, suaranya putus-putus.
Sudah terdengar jelas, Prof?
Sebentar. Karena PowerPoint-nya nggak mau tertutup di sini. Sebentar ya.
Baik, Prof.
Oke. Ya, silakan ulang, Bapak. Maaf.
Ya, nggak apa-apa, Prof. Biasa komputer juga punya batas kerjanya ya, Prof.
Iya.
Baik, ini pertanyaan dari Bu Elda Yusefni. Prof, mohon penjelasan maksud dari crude OR dan adjusting OR pada suatu kasus kebidanan.
Crude OR ya?
Iya.
Oke. Pertama gini, kalau yang kita sebut sebagai orasio, ya, itu mungkin barangkali dimaksud ya, saya tidak lihat pertanyaannya. Orasio itu sebenarnya ada pada penelitian desainnya adalah case control ya. Nah, sehingga kita bisa pastikan berapa risiko untuk terjadinya kasus tersebut atau penyakit tersebut jika dia mempunyai faktor risikonya. Misalnya kita yang tadi, kalau kita desainnya kita ubah menjadi desain case control, kemudian antara kasusnya HPP dan non HPP sama-sama banyak sebagai kontrolnya, maka kalau kita dapat rasionya itu menunjukkan betul-betul adalah berapa besar faktor kemungkinan terjadinya risiko HPP pada faktor yang berisiko pada yang Ibu Resti umpamanya. Nah, jika dia penelitiannya cross-seksional, maka disebut sebagai di prevalent orasio, karena sebenarnya dia tidak orasio murni. Itu beda, ada orasio dan form, ada OR dan ada POR. Kemudian ada lagi orang ketika kita baca data disebut dengan new atau crude OR, itu adalah orasio yang kita dapatkan di penelitian kita. Tapi kalau yang disebut dengan current, kita kan punya pembanding nih. Kita dapatkan yang lama itu berapa sih? Itu disebut dengan current ratio. Hanya itu saja membedakannya. Jadi orang nanya berapa sih ratio didapatkan? Karena untuk ratio tidak ada nilai adjusted-nya dalam statistik kan. Yang ada adjusted-nya itu pada R atau R square pada korelasi dan regresi. Dan ratio tidak ada nilai adjusted-nya. Jadi yang disebut crude kasar kan. Apa yang kita dapatkan hari ini? Kenapa disebut kasar? Bruto ya, karena dia baru satu penelitian, sedangkan yang existing atau current itu berapa sih yang secara teoritis atau established sekian banyak studi yang sudah disimpulkan berapa rasionya. Nah, sepanjang yang saya pahami dan yang saya baca demikian.
Baik, terima kasih Prof atas penjelasannya. Bagaimana Ibu Yelni? Baik, saya rasa sudah sangat jelas ya, Bu. Baik, kita lanjut ke, iya, bagaimana? Bu Elda, maaf ya, Bu Elda. Baik, terima kasih. Kita lanjut, Prof, untuk pertanyaan berikutnya. Di sini ada dari Ibu Hotmah Hutagaul, di mana di sini ada 2 pertanyaan, Prof. Bagaimana cara pandang kita terhadap data agregat yang selama ini tidak kita observasi, unobserved? Apakah bila kita juga membahas tentang agregat, data ini nantinya dapat menimbulkan paradoks terhadap hasil akhir penelitian kita? Itu pertanyaan pertama, Prof. Kemudian pertanyaan kedua, saya lanjut yaitu bagaimana agregat data yang unobserved tadi akan berpengaruh terhadap evidence base atau hasil akhir penelitian kita. Maksud saya, Prof, apakah bila menghasilkan evidence base berdasarkan data agregat yang unobserved tadi, Prof?
Baik. Pertama, bagaimana cara pandang kita terhadap yang selama ini? Jadi, yang harus kita lakukan adalah melihat data itu memang secara komprehensif. Selalu saya mengatakan jangan hanya terjebak kepada nilai signifikansi dan OR yang kita hasilkan kalau kita meneliti. Begitu juga kalau kita membaca artikel penelitian orang lain. Kalau seandainya di penelitian tersebut tidak dibahasnya, ya, maka kita mesti lihat data yang display seperti apa sih. Jangan-jangan, apalagi data korelasi ya, yang kita bisa tahu bagaimana sebaran scatternya. Nah, kalau scatternya tersebut nampak sekali, ternyata ada kelompok-kelompok responden atau sampel yang memang berbeda sebenarnya kedudukannya dengan kesimpulan akhir. Maka ini perlu menjadi perhatian. Oh iya, dia bermakna. Tapi kan ada yang lain yang tidak dibahasnya, demikian. Nah, itu kalau kita berarti masih ada faktor lain sebenarnya yang memang mesti diperhatikan. Itu. Nah, kalau kita yang sebagai peneliti yang akan melaporkan, ini perlu menjadi perhatian. Bagaimana sikapnya? Ya, untuk selanjutnya perlu kita perhatikan itu. Nah, kemudian, apakah dia akan merubah, pertanyaan keduanya, apakah akan mempengaruhi kita terhadap cara kita bersikap? Ada 2. Kalau dalam sikap yang merubah dalam hal penelitian, itu ya ada sedikit ya. Kita menyampaikan, ya, memang terdapat hubungan bermakna, Mbak. Memang terdapat korelasi positif, sekian, sedang, gitu ya. Berarti kalau A naik, faktor risikonya naik, kemudian penyakitnya juga meningkat, ya. Skor penyakit juga meningkat. Udah clear itu. Bahwa memang kita perlu hati-hati, ya clear di situ. Tapi sikap selanjutnya bagaimana? Tetapi jangan lupa, ada kemungkinan juga loh orang yang pada posisi ini yang akan terjadi. Kalau dia laporan yang lengkap seperti tesis, seperti laporan harian, untuk laporan kita kinerja di institusi, yang akan merubah cara pandang kita melakukan sesuatu, ini perlu dijelaskan lebih panjang. Ada kelompok-kelompok, apalagi kalau data kategori tadi ya, ternyata ada loh yang risiko tinggi, tapi tidak bisa kita pertahankan, tidak HPP. Berarti ini kita perlu berperhatian. Mengapa ya? Oh, ternyata pada kelompok yang ini usaha maksimalnya sudah dilakukan. Memang dia anemia awalnya, kemudian dia memang pendek, tetapi tidak ini ya, tidak HPP. Atau kita cari lagi betul, dia tidak HPP. Risiko tingginya apa ya? Oh, ternyata umpamanya risiko tinggi yang dipunyai hanya risiko tinggi seperti ini. Artinya apa? Kalau dia risiko tingginya jenisnya ABC, kemungkinan bisa kita pertahankan untuk ini. Kan banyak kemungkinan ya. Banyak kemungkinan itu yang perlu kita delivery. Kita analisis lebih lanjut menjadi evidence yang sebenarnya jauh lebih penting dari hanya bermakna atau tidak. Nah, mirip-mirip dengan skripsi mahasiswa atau penelitian mahasiswa yang sering misalnya hubungan pengetahuan dengan metode edukasi. Nah, hasilnya udah tahu kita dulu, belum keluar hasilnya kita udah tahu juga. Edukasi yang dia gunakan meningkatkan pengetahuan. Jelas itu. Tapi apakah itu saja yang penting? Enggak. Masalahnya, ada enggak yang orang yang setelah diedukasi enggak meningkat pengetahuannya? Justru itu yang jauh lebih penting kan? Atau sebaliknya, kalau seandainya dia punya pembanding, ada juga enggak kontrol yang tidak diedukasi dengan cara kita yang meningkat jauh pengetahuannya? Ada. Mengapa bisa? Nah, ini kan menjadi penting. Kalau hanya terjebak yang tidak komprehensif, terjebak hanya dengan angka, belum ada pun laporan kita sudah menduga kok, oh ya, orang resti yang banyak pasti lebih banyak deh HPP-nya. Kemudian kalau pakai metode ini akan pengetahuannya akan meningkat. Itu udah jelas tanpa dia olah pun kita sudah asumsi demikian. Hipotesisnya juga demikian. Nah, sikapnya kalau dia laporan yang akan merubah cara pandang kita terhadap persoalan di lapangan, mungkin nanti ada penyuluhan, edukasi, perubahan program dan seterusnya ya. Maka dua kutub tadi, apakah yang positif risikonya dia tidak positif di kasusnya, atau sebaliknya dia tidak ada risiko tapi ternyata dia bermasalah. Ini dua-duanya perlu menjadi perhatian agar menjadi bahan untuk perubahan program ke depannya. Mungkin demikian Bu Ulfa.
Baik, terima kasih Prof. Memang ini sangat bagus sekali pertanyaannya ya, karena ini juga memang sering kita dapatkan pada mahasiswa kita ataupun mahasiswa yang sedang penelitian. Seharusnya memang itu yang lebih penting kita kaji ya Prof ya. Dan apakah sedikit mungkin menyambung pertanyaan, berarti data tersebut apakah kita analisis berdasarkan jurnal-jurnal atau literatur yang ada juga Prof?
Ya, tentu ya. Kalau kepentingannya melaporan ilmiah tentu dibahas dengan referensi ilmiah juga. Apalagi kalau kita mau menyampaikan di publikasi umpamanya, tentu bisa kita sampaikan di situ. Ada rujukannya. Pada kondisi tentu kita berbasis data agregat kita juga. Tentu kita yang tahu ya. Data yang positif risiko, kemudian tidak ada kasus, ya tidak ada penyakitnya. Mengapa dia bisa begitu? Nah, tentu kita akan cek juga. Dan
terima kasih banyak, Prof. Prof, ini sudah jam 5, tapi masih ada satu pertanyaan di kolom chat. Apakah kita lanjut satu pertanyaan lagi, Prof?
Boleh bertanya.
Baik, terima kasih. Ini terima kasih atas pencerahannya Prof dari Bu Hatma tadi, Prof. Kemudian pertanyaan selanjutnya dari Ibu Perwitasari. Selamat sore, izin bertanya Prof, bagaimana supaya data kualitatif lebih bisa digeneralisasi untuk pengambilan keputusan pada asuhan kebidanan? Apakah untuk membuat suatu intervensi kesehatan perlu dimulai dengan eksplorasi kualitatif? Terima kasih.
Baik, saya jawab dari yang umum dulu ya. Secara awal, mazhabnya, pakai mazhab nih, data kualitatif, penelitian kualitatif ya, bukan data kategori kuantitatif ya, data kualitatif tidak ditunjukkan untuk inferensial atau generalisasi. Itu awalnya. Meskipun dia bisa digunakan tempat lain yang disebut transferability. Ini soal istilahnya penting. Apa bedanya? Kalau kita meneliti tentang kuantitatif itu eksperimen ya, atau case control lah, antara faktor kita lihat kasus HPP dengan faktor risiko apa yang kita cari ya. Faktor risikonya umpamanya anemia. Terbukti ya bahwa anemia pada ibu hamil meningkatkan risiko terjadinya HPP dengan Proession 6, sekian kali dengan rentang CI-nya sekian ya. Nah, lalu hasil kuantitatif itu bisa kita terapkan mau di Padang mau di Aceh. Kalau ada anemia maka dimungkinkan terjadi HPP sekian kali rentangnya. Mungkin akan beda-beda sedikit-sedikit saja. Itulah yang disebut dengan inferensial atau generalisasi. Generalisasi tidak memandang tempat lagi. Dia hanya bicara faktor risiko, dia hanya bicara kasus atau penyakit atau apapun yang kita sebut. Nah, kalau kualitatif tujuannya bukan awalnya kan mencari makna, meaning yang bisa menjelaskan sesuatu itu. Misal, kita mau eksplor nih. Mengapa ya ada yang tidak kita mau eksplorasi, bukan eksplor nih, eksplanasi sekuensial. Kita mau cek nih dengan kualitatif. Mengapa ya ada ibu-ibu yang dari HPP tadi. Kita mau jelaskan yang resti seperti apa, yang non resti. seperti apa. Jadi mengapa ya kita mau yang non resti ini jadi anemia juga. Lalu dapatlah hasilnya. Ternyata yang tidak resti itu jadi anemia karena begini-begini. Oh, jadi penjelasannya. Nah, nanti dapatlah datanya saturasi ya. Dari pada metodenya, apakah metode triangulasinya sumbernya sudah ya. Mungkin kita bisa buktikan juga dengan triangulasi metode, mungkin ada dokumentasi dari catatan ANC, kemudian dari pertanyaan ke bidan dan seterusnya juga dapat. Nah, hasil itu tidak diperuntukkan untuk generalisasi. Misalnya penelitiannya di Kota Padang, hal itu belum tentu bisa diaplikasikan di Banda Aceh, di Kota Medan, di Jakarta, di Bandung, ya, di mana terserah mau dimanapun kita, ya. Dia hanya bisa disebut sebagai transferability. Apa itu transferability? Kalau melihat kontekstual betul, oh ternyata ibu-ibu yang non resti, yang tidak anemia, bisa terjadi HPP pada kondisi-kondisi seperti ini dan lain. Setelah kita eksplorasi, mengapa dia HPP? Ternyata faktor HPP-nya karena ini dan seterusnya. Nah, kan tidak bisa generalisasi nih. Seandainya ibu-ibu yang tidak resti tetap terjadi anemia kalau terjadi ABC, belum tentu. Maka kita lihat kontekstual yang sama. Itu yang disebut transferability. Meskipun ada mazhab kedua mengatakan transferability generalisasi juga gitu. Ya boleh lah gitu. Itu kan bahasa kuantitatif dipakai di kualitatif kan. Yang mau saya tekankan adalah kita kembali pertanyaan, bagaimana kita mau meningkatkan kalau peningkatannya? Bagaimana kita meningkatkan data kualitatif itu bisa di transferability, digunakan terhadap asuhan kebidanan? Jawabannya satu, kita mengenal secara kontekstual data kualitatif itu dihasilkan seperti apa. Yang kedua, apa variabel, atau kita rubah jadi kualitatif, apa tematik dan subtematik yang dieksplanasi, yang dijelaskan dalam penelitian tersebut atau data yang disajikan ke kita tersebut. Yang keempat, ya, apakah konteksnya tadi sudah sesuai enggak dengan kita sehingga kita bisa transfer untuk aplikasinya ke kita. Oh ya, konteksnya sama. Yang tidak itu hanya A, B, C, D, E gitu ya. Tapi konteks ini tidak akan berpengaruh terhadap penerapan ini secara teoritis ataupun secara praktis. Oh, berarti kita bisa simpulkan, kita bisa gunakan. Jadi demikian ini. Tapi yang paling penting di atas dulu, critical appraisal sudah benar tidak? Ya, yang di atas itu paling mutlak ya. Apakah hasil kualitatif itu sudah bisa kita percaya, trustworthy? Kita lihat dia penelitian yang sudah benar, metode sudah benar, ada triangulasi sudah benar, data saturasi. Jangan-jangan kita mengambilnya bukan data yang saturasi, kita mengambilkan kuotasi daripada informannya, tapi bukan data itu yang menjadi data evidence sebenarnya. Mungkin demikian, Bu.
Baik, terima kasih Prof. Sangat jelas sekali ya. Bagaimana Ibu Purwitasari? Baik.
Terima kasih.
Terima kasih. Baik Prof, berhubung waktu menunjukkan sudah pukul 5:08, artinya juga sudah selesai untuk sesi kita hari ini, Prof. Izin sedikit disimpulkan terkait tentang topik kita hari ini, yaitu terkait tentang evidence base, di mana evidence base ini bukanlah sekedar data, tetapi evidence base merupakan suatu fakta yang disertai dengan bukti yang didelivery dan diinterpretasi, di mana juga harus kita lihat secara objektif, komprehensif, dan open-minded. Evidence base juga harus berdasarkan research, bukan dari testimoni, isu-isu, dan lainnya. Oleh karena itu, kita sebagai dosen dan sebagai bidan-bidan harus menghasilkan suatu bukti nyata, yaitu berupa dari hasil penelitian-penelitian, baik yang kita publish ataupun yang tidak kita publish. Mungkin itu dari saya. Terima kasih banyak Prof. Hargisman, sangat luar biasa
Terima kasih.
materi hari ini, rasanya tidak cukup waktu kita 1 jam untuk membahas terkait tentang evidence base. Mudah-mudahan ada kesempatan di lain waktunya. Saya sebagai moderator mohon maaf dan undur diri. Assalamualaikum warahmatullahi wabarakatuh. Saya kembalikan kepada Ms. Hanifah.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much for the moderators and our remarkable speakers. Hopefully today's lecture could motivate us to give the best service based on evidence and also contribute to the establishment of an evidence-based midwifery process in the future and each of our roles in this field. I believe many of the participants agree that all of the speakers are very inspiring and definitely give us the courage to do better for the development of our the midwifery services. I would say thank you to all the participants today, and we hope that you have learned and enjoyed this presentation. And I would like to inform that for the attendance link, which participants that still haven't filled it yet, you could access the link through the chat Zoom. And also the certificate, you can also it will also send to your Google or a G form that you already registered in that link. Jadi untuk absensi bagi yang belum mengisi dapat diakses pada kolom chat Zoom, dan juga untuk sertifikat akan dikirimkan langsung oleh panitia ke masing-masing partisipan yang sudah mengisi dan memberikan link dari Google atau emailnya. Okay, once again, I would like to say thank you to the amazing participants who have been stayed until it finished and actively involved in the discussion. Me, as the representative of the Midwifery Department, Andalas University, would like to humbly apologize if there are so many mistakes that happened during the process of our agenda today. Thank you and see you in another event. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.